why the society of the subspecialty is needed, and we could do that. We could make awareness among our orthopedic surgeons about the subject. Pediatric orthopedics is a very special subject. There are many things to learn, and we will see within 10 years, next 10 years time, there will be other super specialty from the pediatrics orthopedics as well. There will be the surgeons doing only the obstetric brachial plexus injuries. There will be surgeons doing only the trauma in pediatrics surgery. And there will be surgeons who are doing only in scoliosis in pediatrics group. So there will be other subspecialty in future. Probably we will not see that, but we think that will develop. So by this 8 years time, we have achieved something at least, but for the last 2 years due to the COVID pandemic, we could not progress. I am only encouraging, but main part of my work is being done by Professor Sarwar Abdul Salam. And there are some juniors who are very enthusiastic in this subject, and the seniors, Dr. Dipankar, Dr. Samal, Dr. and other seniors teachers. So let us work together, and definitely we will achieve something. And with these few words, Dr. Alam has said, Dr. Gonimullah was also spoken about some of this ethical part. I always, in my all meetings, I always say, be sincere and honest. For an honest surgeon, there are less competition in the country. If you become dishonest, there will be more competition is much more. So be honest, try to remain honest. Honesty is the only thing. I always say, if you in your every activity, there is no substitute to honesty. Even in prayer, if you are not honest in your prayer will not work. So that is in all work. Money is not everything. So be honest, sincere, then you can achieve many things. With these few words, we are already 15 minutes late. I think we will all remain attentive. The juniors, I will ask the juniors to ask questions to the speakers and try to participate in the meeting. So I welcome you all. Thank you very much. Thank you all once again. Thank you very much.
Thank you, sir. I would now request our dignitaries on the stage to take their places in the front row. And we'll soon start our first session. We have 3 sessions, I said. There will be papers of 12 minutes. And after that 12 minutes, there will be discussion for 3 minutes. And these sessions are mainly reserved for the foreign faculties and the interactive cases. And for the local faculties, the talking time will be 8 minutes, and there will be 2 minutes of discussion. First session will be chaired by Professor Dipankar Talukder. He is an executive member of POSB, and Professor Shamul Chandra Devnath, Joint Secretary of POSB. I'd request Shamul sir and Dipankar sir to come to the stages to start the first session.
Yes, sir. Morning. Yeah. So just, oh yeah, yeah. Let me know when I can share the screen.
Shamal
Okay?
sir, please come to the stage.
Okay. Okay.
Recording in progress.
Mhm. Yeah. Yeah.
Let's me have the pleasure to convey my heartfelt felicitation and welcome to all national and international faculties and delegates in the 8th POSBCON 2022, which has been dedicated in the precious memory of Dr. Chamirul Islam. Me, Professor Dipankar Nath Talukdar and Professor Dr. Shamal Devnath have taken the opportunity to share the session. There are 6 international faculties who are actually the national and international leaders in the respective fields. This is the first session we are conducting. There are 10 papers. 10 papers. The first paper will be presented by Dr. Maulin Shah, my favorite and very prestigious BP surgeon. May I request Dr. Maulin Shah to present his paper?
So my screen is visible.
I am requesting all delegates, please
Yeah.
keep your mobile.
And can you hear me clearly? Please let me know if you can hear me clearly.
Dr. Maulin Shah,
Yeah, can you hear me?
surgical fracture in osteomyelitis.
Can you hear me clearly? That's what I want to know. Yes. Okay, fine. So I'll start.
Yes, Dr. Maulin Shah, please start.
Yeah.
Uh,
So pathological
we
fractures
cannot hear you, please. Maulin Shah,
Okay.
we cannot hear you, please.
Yeah. Okay. So pathological fractures in osteomyelitis, and we have fond memories of POSB. Kaisa? Yeah. Am I not audible? Oh, because Taral can hear me. So, yeah, please clear from your side.
So Maulin, you are
Sir, we
heard
can
on
hear you.
Zoom. They'll have to connect Zoom speaker to the hall speaker.
Sir, we can
Yeah.
hear you.
Yeah, so Kaisar cannot hear me, but we can, you can hear me. So they have to do some modification.
Hello. Hello.
Yes.
Hello.
So I can hear the faculty.
Sir, can you hear us?
Yes. I can hear you. But you cannot hear me what I speak. Yeah.
Yeah. No, right.
I can hear you.
Yes. Hey,
Now we can hear you, sir.
So can you hear me
Yes, sir.
now?
Yes, sir. We can hear you, sir.
Okay, so can you see my screen?
No, sir.
So you want me to share it again? So now you can see my screen, right? Now?
Yes, sir. Yes, sir.
Okay, so
You can share your screen, sir.
can you see my screen? Hello? You want me to share it again?
Yes, sir. Share it again, sir.
So now you can see my screen, right?
No, go on.
No, it's not. Screen share on.
Hello? Yes.
Yes, sir. Now we can.
Should I start?
Yes, sir. Please go on, sir.
And is my screen visible? I'll reshare. Yes.
A small one visible. A small one.
Hello? They cannot hear me.
Now we can hear you, sir. Small screen is Ravi Thakur's music. Instrument.
They cannot hear me.
Now we can hear you, sir. Small screen is Ravi Thakur's music.
Yeah. Hello? Okay, so I should. No. Okay, fine. Yeah. Yeah. So, thank you very much. My visit to Bangladesh is not too many years away. In 2018, we visited and we had a fantastic time with the recommendations of Professor Kiri and Romil. We had Kaisar Ravi with us. And I can say confidently that he was one of the most tech-savvy and sincere fellow I had. Coming to the subject, and we had a fantastic time with the recommendations of Professor Kiri and Romil. So osteomyelitis can weaken the bony architect and predispose the bone to fracture. And this incidence is about 4.7%. And we have fantastic. About 80% of patients will require a series of surgeries to restore the normal bony architect, and thus is a very challenging problem. Now, in types of pathological fractures are twofold. One is without active infection, which happens due to inadequate splinting of the bone, and the other is with active infection due to weakening of the structure. And mainly it happens at the junction of affected and non-affected region because that acts as a stress riser. So this young boy who had a healed tibial osteomyelitis was jumping on it and he sustained an undisplaced fracture and we could treat it conservatively. And this girl with a healed humeral osteomyelitis was doing acrobat at home and she sustained a fracture which was conserved and she healed well also. Now the fractures with active infection are the real challenge. We have published our data last year and where Kaisar was also part of it. Now we can foresee that which fractures can go for a pathological, which osteomyelitis are predisposed to get fractures. And there are some risk factors. And the first one is circumferential abscess. More than 50% if it is present So it devitalizes the underlying periosteum to form the involucrum, and they are likely to develop fracture. Another risk factor is an associated soft tissue abscess. We know that periosteum receives blood supply from compartment as well as the intramedullary canal, and with an associated undrained soft tissue abscess, this can lead to periosteal devitalization, which will not grow new bone and will end up into pathological fracture. Multiple local surgical interventions without decompression of the medullary canal can also lead to pathological fractures. And finally, MRSA has a higher incidence of path fractures, which can happen spontaneously without any trauma. So basic principles of treatment are multifold. The first and foremost is to eradicate the infection. Then comes the removal of sequestrum if it is present, fracture stabilization, and achieving union. This fourfold are the principles of treatment. For eradicating infection, mainly the PVL secreting MRSA, we have to instill appropriate parenteral antibiotic. At times we take help from infectious disease specialists. And nowadays we use a lot of local antibiotic administration in the form of Stimulan, which is an absorbable calcium sulfate pellet, where we can mix vancomycin, tobramycin, gentamicin, antibiotics of different categories. Let me share you a case. Is a 9-month-old girl had a fall, trauma, abscess formation, which was drained by a pediatric surgeon. And there was a persistent sinus with a fracture at the ulna. And this was the X-ray picture. The central ulna was not forming any involucrum, and the distal end was moving. MRI also confirmed the same findings. What we did, I did open and drained the abscess completely. We did not find any periosteum lying there. There was an attempt at formation of involucrum at the top and bottom end. And we filled up the cavity with stimulant beads mixed with vancomycin. And this was the X-ray to start with. At 1 month follow-up, the whole diaphysis got sequestrated. And in 2 months, we could see some scaffolding formation. And at 6 months, the disease healed. At 1 year follow-up, this was getting remodeled. And at 2 years, there was no evidence of previous infection with full range of motion. So the stimulant helps in making bony scaffold and osteoinduction, and then we can use it for path fractures in metaphyseal area sometimes. For the bigger bone and older children, we need to eradicate the infection, and one can use intramedullary decompression without jeopardizing periosteal health. For the long tubular bone, we can use small or forearm reamers. But when it comes to smaller bones like tibia or forearm, we have developed a technique of using a giggly saw wire assisted intramedullary decompression. And I'll take you through a small technique video. So I'm showing this in for a 1-year-old child with pan-osseous osteomyelitis of tibia. You can see the marrow edema till the distal diaphysis. So here, after draining the subperiosteal abscess through a metaphyseal incision, one has to make multiple small drill holes to create an oval window, a small oval window so that it does not fracture the bone. And it's a unicortical. And through that window, you use your scoop to do local decompression of the debris. And then you introduce a giggly saw wire loop. And this loop will go right to the distal diaphysis and distal metaphysis. And with the tip of giggly saw wire, you can scrap all the walls, and at times you can retrieve the separated sequestrum pieces also. And then you should put an infant feeding tube of appropriate size, and you lavage the medullary canal, and you will see that a lot of debris and muck is coming out through that drainage. So this is the infant feeding tube we are introducing, and then with a normal saline, you can see all the debris would come out. So this kind of intramedullary decompression is required for small children who had pan-osseous osteomyelitis. And this will not weaken the bone. And you can splint them till the bone gets healed. And this is 3 months follow-up. And this is 1 year follow-up of the same child. So that was about decompression of the medullary abscess. Then comes fracture stabilization. Mainly we use external fixators for pathological fractures, and we also use nails, especially antibiotic mixed cemented nails for the pan-osseous disease. And once the disease heals, we have to augment it with bone graft at times. And for the massive sequestrectomy and graft non-union, we use fibular graft and bone transport at times. So let me share a small brief technique video how we make antibiotic impregnated cemented nail. So when you ream the canal, you measure what is appropriate nail size you want. For instance, for this case of tibial osteomyelitis, I could ream with a 4 millimeter reamer. So my size was 4 mm. And so you choose an intercostal drainage tube of appropriate size. You take a 9-inch K wire and make serrations over it so the cement get impregnated it very well. Then you make a cut into the tube. And this is a longer video. Yeah. So we don't use this cutter to make a serrations, but now you use the tube and cut it little short because you want to bend the tip of the wire. And all the tubes have a marking in the center, orange or green, depending on the size. So after putting it on reamer, you cut it in the center. And then again, you put your thin wire in the tube and prepare your cement with the antibiotics and pour the cement over the thin nail. So here you have to pour the cement while it is a bit liquid so that it accommodates and it lies all around the nail. And once the tube is filled with cement, you wrap around in your bandage and keep it there to consolidate for some time. And once it consolidates, you take off and peel off these plastic tubings. And so you have this nail ready of the desired diameter like this. And this is a bit flexible also. And then you introduce this nail just like the common Williams technique. You draw it out from the tip sheen and put it back, band it so that it lies over the calcaneum. And it will emit antibiotics for 1.5 months. It will stabilize the fracture as well. So this is the technique. Now we used it for this 4-year-old boy with osteomyelitis, pan-osseous osteomyelitis. Once we did the Giglio wire assisted debridement. Later on, the child developed sequestrum and path fracture and healed with a deformity and again fractured. So it was treated with an intramedullary rush rod. After deformity correction, an infection flared up. And so we used antibiotic mixed nail with external fixator and the disease went on healing. This is an 8-year-old MRSA osteomyelitis of proximal humerus with pathological fracture. So we did debridement. I placed an Ender's nail retrogradely because the hold of my proximal pins was not very good. And you can see multiple intraosseous sequestra. This patient disappeared and came back to me after a year with a pus discharging sinus and a non-union, persistent non-union of the proximal humerus. So this time I placed an antibiotic mixed nail and placed the LRS fixator going through the epiphysis because the proximal segment was very small. And once the infection healed, we placed a lot of iliac crest bone grafting. And this is 4 years follow-up of that child. I kept the nail inside and this is his healing. The hand is little lower, little smaller, but he can do his activities of bowling, which he likes to like to play. Another girl, 10 years old. Nowadays, we don't put nails, but because of the advent of stimulant. So this girl has proximal humerus fracture, pan-osseous osteomyelitis, and we did debridement, Gagliso assisted decompression, placed the fixator and placed the stimulant weights. And fortunately, this fracture went on healing and she did do well. No discrepancy in the length, everything was fine. But at times we are not fortunate enough. The similar kind of fracture in the humerus with sequestrum, we performed the same operation. But this, because the lateral bone was missing, this child ended up into healing of bone, but it was lacking the ball posteriorly. During lockdown, the child was playing at home and he fractured this bone and presented with this gross-tech deformity. But we confirmed that there was no underlying infection, and so we went on doing plating, and this boy did well thereafter. Sometimes we have patients who underwent multiple previous surgeries of multiple local drill holes without draining the whole medullary canal. And this boy of 6 years presented to us with this picture. You can see the diaphyseal sequestrum. So we placed the frame and removed the sequestrum, debrided the extremity. And our colleagues Sandeep and Dr. Taral, they have published a series of interpositional fibula grafting. So we performed the same. Unfortunately, the infection flared up again and the whole graft got resolved. So we had to start distal corticotomy and transport. We shifted the whole segment up and it gradually healed after docking. And this is 5 years follow-up of that child. Fibula has, of course, reformed. So in conclusion, these pathological fractures without infection can be treated with appropriate splinting. If they are angulated, then you can plate it if there is no infection. But fractures with infections are really challenging problems, and it would need staged intervention. And every time you have to counsel families and show the examples of previous surgeries. Gigliosomaia is a very important, it's a boon for us. It can be used for medullary decompression to young children with pan-osseous disease. Antibiotic mixed cemented nails are used for stability as well as delivery of local antibiotics. And show the examples of previous surgeries. And gigliosomaia is a very important, it's a boon for us. It can be used for medullary decompression to young children with pan-osseous disease. Delivery of local and show the examples of previous surgeries. Gigliosomaia is a very important, it's a boon for us. It can be used for medullary decompression to young children with pan-osseous disease. Examples of previous surgeries. Gigliosomaia is a very important, it's a boon for us. So do we have any questions? I'm not able to hear you that.
Sir, next presentation, sir.
You want me to go for next presentation?
Yes, sir.
I could not hear any question. Oh, so you will take questions at the end? Okay.
We will take your next, after next presentation, we will take questions.
Okay. Yeah. Fractures and just a moment. Just a moment. So yeah, so now can you see my screen? Yeah, okay, so can you see the screen now?
Yes.
Yeah, I'll start. Okay. Yeah.
Amar voice to them.
Yeah, so can you hear me now?
Yes.
Probably it was a bit delay or lag when I was speaking.
Yes.
Huh? I'm sorry for that. That's a technology. Okay, so can you see the screen now?
Yes, yes.
Yeah, I'll start. Okay. So Kaiser asked me to cover this big topic in 12 minutes. And we have acute Monteggia fractures and chronic Monteggia fracture dislocations. An acute Monteggia fracture dislocation is the most missed fracture, which we should understand that we should not miss them. The Bedo classified them into 4 types. The type 1 is the most common with anterior dislocation of radial head. Type 2 is a posterior dislocation. Type 3 is a lateral dislocation with ulnar fracture, which is associated with posterior interosseous nerve palsy. And type 4 is both the radius and ulnar fractures. Letts and colleagues, they introduced 2 more types, and they said that ulnar need not to have complete fracture for radius to get dislocated. So they introduced plastic deformation and green stick fracture as the types of Monteggia. And you et al., they explain Monteggia equivalents or Monteggia variants, which we all should be aware of. Now, Peter Waters and David Rain, they presented an algorithm of management of acute Monteggia fracture, and they say the treatment of acute Monteggia depends on the ulnar fracture pattern. If it's a plastic deformation or green stick fracture, we should do close reduction and casting, that is enough. But if it's a transfer or short oblique fracture, then one should put a nail across to maintain the length of ulna. And for a long oblique and comminuted fracture, an open reduction and plate fixation is required. So let's see some examples. This 3-year-old boy who fell and had an acute Monteggia, you can see one should take a film with the joint above and below to not miss the Monteggia. And when you are in doubt, you take contralateral images. The left side, the metaphyseal radius line is crossing the capitulum, but on right side it is missing. And the ulnar straight border is now bowed here. So this is plastic deformation with Monteggia, and one can do close reduction. So we took patient under OR, inflection, it remained subluxed, but when we pressed it, with a pop, it reduced, and then we checked the stability in extension, and we plastered it in 90-degree flexion. At 3 months follow-up, it healed very well. And the word of caution, although for this closed injury, is it's difficult for follow-up, especially when you have applied plaster in 90-degree flexion and Bedo type 3 fractures, which is, it's difficult to visualize. There is a risk of compartment syndrome when there is a already swollen elbow or multiple level injuries. And Mercer-Rang and colleagues described that 20% of this initially reduced radial heads may get subluxed later on. So be careful about this. Now, this 2-year-old girl fell from vehicle and she had an oblique ulnar fracture. You can see an air arthrogram. And as it was transferred in short oblique, we went on doing an ulnar nailing and did an arthrogram to confirm the reduction. This is 3 months follow-up, and this is the fully functional child. So she did well. But this 10-year-old boy who had a long oblique length unstable fracture, we resorted to plating, and this went on well. So this protocol has been followed worldwide, and there is a paper, the multicentric study, when they followed this protocol in 112 patients, the results were satisfactory when they were treated according to the protocol. But when it was treated less aggressively, meaning that when there was a short oblique fracture and patient was conserved, about 1/3 of times, the patients required a repeat visit to operation theater. I have been practicing this algorithm for long, and we have not seen any failure so far. Coming to chronic Monteggia fracture dislocation, we have to answer some important questions. And the first and foremost is, what is the natural history of untreated Monteggia? Do we really need to treat them? How much old is safe to reduce a chronic Monteggia? Can we reduce Monteggia without opening radiocapitellar joint or only dealing with ulnar deformity? Can one use radiocapitellar wire as a definitive treatment? And finally, what is better, an acute correction or the fixator-assisted gradual correction, and where to do an osteotomy? So let's answer these questions. So what is the natural history? Now we know that there are a lot of papers which shows that untreated Monteggia leads to radial head AVN and deformity, progressive cubitus valgus, pain and instability at elbow, subluxation of distal radial ulnar joint, and the neuropathies. So it is very clear from the literature that we need to treat these fractures and we should not leave them. Now, this 32-year-old lady is repeatedly coming to my orthopedic adult colleague for elbow pain. She sustained this fracture before 21 years at the age of 11 years, and she is now in the stage of early arthropathy. So we must treat them. Now, the question is how much old is safe to reduce now? So there are some landmark papers. This is a JBJS paper from Japan, and they found that when the 3 years time has elapsed from the original injury, and when the child's age is more than 12 years, they are associated with fair or poor results. Another study from JCO, which also suggests that when it is more than 3.5 years of index injury, the results were fair, although the age of patient is not the factor. So by and large, we all follow that if it is 3.5, 4 years old injury, the results can be satisfactory. Beyond that, if we want to put that radial head back in, then we explain a guarded prognosis to the family. Now, many times we have a tendency of bypassing or having a shortcut for the success. And there are some papers which are very rare reports that fixator assisted radial head reduction was done. Our own Dr. Venkat Das published a series of 5 cases with sliding angulation osteotomy. But we communicated and he said 2 or 3 out of his 5 cases had some sort of subluxation. So doing only ulnar correction without clearing the radiocapitellar joint had very high chances of radial head remaining subluxated and creating problems later. So what is the conventional way to reduce chronic montagia? Kaisar asked me to share my video and let me share the technique which we use. So this is an 8-year-old boy with 1-year-old ulnar fracture, which was treated conservatively. He had a prominent bump in the front and it leads to limited flexion and ulnar bow. And there is anterior dislocation, Bedo type 1 fracture with annular ligament calcification. Here we take an extensile focus approach, which start from the lateral distal arm, and it is centralized over lateral condyle, and we go to the forearm over the ulnar subcutaneous border. The primary dissection is between the anconeus and the common extensor, and this interval is reflected anteriorly. The first thing is to dissect the posterior interosseous nerve. For that, you go anteriorly between brachialis and brachioradialis. Peter Waters told me to decompress these nerves because in very severe cases, sometimes while doing reduction maneuver, this nerve may get neuropraxic injury. So I have been doing this in my practice. So this is the nerve. You can see for any attempted supination, this nerve may get stretched. And to prevent that neuropraxic injury, one can gently deal with it. Then comes the dealing with annular ligament. Annular ligament is usually lying superior and anterior than what we expect. And it lies between the radius and capitellum. So you have to find out the dent in this annular ligament and make multiple radial cuts and expand it, and then reduce or milk the radial head through it. I'll show you the top view. So this annular ligament was lying there. After making scapular cuts, we reduced it like this. And then radial head will come in front of capitellum. And if it is not stable, then you proceed for the ulnar osteotomy. One can pass a temporary radiocapitellar wire to template the ulnar osteotomy, which should be removed later. So in this case, I have done flexion osteotomy of ulnar and fixed it with the double stack plates. And once we fix it, you have to check the reduction in full range, especially in the extension and supination, because in extension and supination, there is a chance that it may get subluxed or redisplaced. You should confirm under image intensifier as well before you close the bone. This 3 years follow-up of the same child with well-healed radial, the montagia, well-located radial head, and the adolescent get a good range of flexion and chronosupination. Now, question is what type of ulnar osteotomy and what is the site? So there are 2 types of osteotomy can be done. If the radial head is not too much proximally migrated, one can do only ulnar flexion osteotomy, and or you can do a flexion lengthening or distraction osteotomy. I leave this on after putting a temporary K wire and I see how much ulna is distracted. If it is distracted, I'll put an iliac crest graft in between. It is wise to do a proximal osteotomy than distal, because by doing proximal osteotomy, you have more pressure, more stretch on interosseous membrane to keep the radial head down. We do not do osteotomy as fora, we do with proximal osteotomies. Is annular ligament reconstruction necessary? There is no consensus in the literature about it. There are papers which show that there is no difference with or without annular ligament reconstruction. One of them is from Dr. Atul, a friend from Mumbai. People have also studied the efficacy of palmaris longus over triceps fascia, and some reports are showing complications of this as well. So annular ligament reconstruction usage is, there is no consensus. Should transcapitular wire be used for the for holding the reduction? The answer is no, because there are evidence that it induces more stiffness. And if the wire gets broken, then it is very difficult to retrieve. And there are no difference whether you use this or not. So we should avoid it. Yeah, we can use a temporary wire for templating your ulnar osteotomy. That's what this Donald-based paper is saying, and that's a nice technique. What is the future of Monteggia fracture management? We receive many neglected Monteggias coming after 3 years, 4 years with a significant cubitus valgus and radial head deformity. We tend to do 3D printing of this bone models to see whether this radial head will fit into the radial notch of ulna or not. Because if it is not fitting in, then there is surely lead to a lot of stiffness. And there are some cases where, based on these models, we have done radial shortening osteotomies also for patients presenting 4 or 5 years after the index injury. So this is the future of, or probably current scenario we use in the Monteggia fracture dislocation. So with this, I stop my presentation here. Thank you very much.
Thank you, Molin, for your very brilliant and informative presentation. Please keep yourself with us.
Yes.
We are now starting the question and answer session. Question and answer session for the first topics. Management of pathological fracture in osteomyelitis.
We have 2 mics there, and I have a mobile one. Anyone interested asking any question regarding any paper, sir?
Question on first topics, please.
So, Molin, one question
from delegate. Yes.
One question from me, that you put a rod, I mean antibiotic impregnated rod through the talus. So, did you do that for the sake of stability? You have fused that ankle is going to fuse, isn't it? So, my question is, stability is so important that you have given up the ankle. Is that?
So the first thing is, when there is a fracture in the distal half and with an active infection, we are worried about the stability. We cannot put a plate across because there is an active infection. This distal fragment is very small. To hold the fragment, we put a nail across, and this is not a permanent nail. So once we see the union, we tend to remove the nail. And for the distal tibial osteomyelitis, we do this. For proximal or diaphyseal fractures, we can put antegrade, avoiding entry through the ankle joint. One of the risk factors is when you try to remove the nail, you may not be able to remove the cement. That's one of the complications we have seen. That cement layer would remain there and may hamper the ankle movement. So we try to remove this nail as early as possible. So that's one thing which one should keep in mind. Otherwise, it's a temporary nail, so it will not compromise the motion. Once you remove it, the movement should restore.
Another question from Dr. Sunni. Have you faced difficulty in passing the nail in the medullary cavity?
So the nail size should be templated from your reaming. You know, when you do decompression, you see which size of reamer you are doing. And if it is a 4 millimeter, their intercostal drainage tubes are different sizes available. So you use the same or one size lesser size. Now we want a rotational stability as well. So there is no problem. Just like pseudoarthrosis tibia we can do the nail insertion pretty easily. If you find there is rotational instability, you add a temporary monolateral external fixator. And the stability is very important when you want to achieve infection control, you know.
I have one question. Professor Mollin, in osteomyelitis of tibia in children, we uses Elizarov external fixator and the result is good. Have you any experience about that?
Yeah, I demonstrated one case. We use Elizarov for kind of where multiple attempts at union has been done and it has not healed. When there is a gap non-union with devitalized bone ends. We have been using fibular graft as well with a native clean bed. But when that also fails, we do Elizarov transport. And I agree with you, that's a wonderful technique. But the problem is it's time consuming. So we use only for those cases where we are not left out with any other option. You know? But that's a wonderful technique.
Is there any questions?
Thank you, sir. Thank you, sir. So I have a question. In chronic osteomyelitis children, in pan-osseous intermedullary decompression by Gigli saw, sometimes Gigli saw broken in the medullary canal and it's very difficult to remove.
Yeah. So I agree with you. In about 100 cases we have done so far, there was only one incidence of Gigli saw via loop got broken, and it got broke pretty proximally, so we could not retrieve it. And I talked to family, and that went on healing very well. Now, what happens that if you use new Gigli saw wire every time, then this is not a problem. That should be a new and good quality Gigli saw wires. Otherwise, you don't use one wire for multiple cases. So, out of this long series, we have one experience what you have said.
And thanks. Now we like to shift the second topics.
One question on seven. What antibiotic and in which dose? The usual dose we give in IV or oral?
So that depends on what bacteria is retrieved. If it is MRSA, then we use vancomycin and ceftriaxone. Vancomycin should be given in infusion pump, because if you give IV and if your nursing staff is not well trained, then that may lead to a Reitman syndrome. So for long years, I have been admitting patient to the PICUs or pediatricians nearby in our setup. But now our staff is well acquainted with so we use infusion pump and vancomycin can be safely administered. Now, so that depends on what bacterial growth you get, you know.
Thank you. We like to go to the next question and answer session for the second topics. Management of Montegia fracture dislocation. Is there any question, please?
Sir, in case of chronic Montegia fracture dislocation, we reconstruct annular ligament by deep fascia. So, is there any difficulty? Is there any complication? It's not possible.
Yeah. So over a period of years, you know, what I have seen is at times it becomes difficult to identify whether this annular ligament is completely torn or it is there and we are not able to reduce it. What we have found is we try to find out the top of annular ligament. And if we find the hole, then we enlarge it, put it back. If we have to cut it completely, then we take loose sutures over the ends after reducing the radial head. Now, once we do that and we do ulnar osteotomy, frankly speaking, in the series which I have done, and Dr. Atul Bhaskar, who has also a large series, we have not reconstructed annular ligament with triceps fascia or palmaris longus. And the rate of resubluxation has been the same. So the key thing is, when you fix the ulnar osteotomy, check the stability of reduction. And if the radial head remains there, you don't need to reconstruct the annular ligament. Initially, we fix with only one screw. And then if we need more flexion, then we give more flexion to the osteotomy and try to align it. There are some chronic cases where the radial head is enlarged, and with an attempted pronosupination, it sublux. In those cases, we have reconstructed with annular ligament. We have done fascia, and those patients have shown to develop some sort of stiffness and pronosupination restriction. So probably it is not required, and that's what some papers say, but there are also many papers who have been advocating annular ligament reconstruction.
Thank you, sir. Dear Molin sir, nice to see you. I want to know about the acute dislocation of Montezia, bed type 1 or 2. In cases of plastic deformation, how do you reduce or correct the deformity during close management and maintain the reduction of the radial head?
Yeah, so in this plastic deformation also, there what happens is the radial head pops out of the capsule. So once you take the child under anesthesia, you have to push it, and if you feel that the radial head reduced with a pop, that means it is went back through the original capsular bridge. That will be a stable reduction. And for plastic deformation of ulna, it's not very easy to correct, but you have to give a 3-point pressure for about 5 to 7 minutes, and that will gradually get straighter. So it's not very easy, but you have to give persistent pressure under anesthesia, and that plastic deformation will reduce. At the same time, in few cases where the radial head spontaneously got reduced with a mechanical pressure, I did not correct the deformation, and it did not sublux. So at times you may get away without giving a lot of force on ulna,
Thank you, sir.
Sir, one question. One of our patient is 6-year-old chronic Montezia fracture dislocation. Should we go for open reduction and ulnar lengthening osteotomy? 6 years.
Sorry, what's the question?
6 years. 6 years time for chronic Montezia fracture dislocation. Should we go for reduction?
So as you know that when more than 3.5 years have elapsed from the index injury, there are high chance that patient would develop stiffness and restriction of pronosupination or resubluxation. So we should choose the surgery if patient is having progressive cubitus valgus, pain, restricted elbow flexion. And we must discuss this with family that the children more than 3 years old have a higher chance. I happened to reduce one 9 years old dislocation because child had a lot of pain and increasing valgus. After opening, clearing the radiocapitellar joint and doing ulnar lengthening osteotomy, also this radial head was not coming down. So we happened to do radial shortening osteotomy and then putting a nail from bottom. So that the child fortunately did well, but at times you may see difficulties intraoperatively. After doing everything, the radial head is not coming down. So don't hesitate to do distal diaphyseal radial shortening. That's an easy way. This is what we have been doing in DDH cases, hip dislocations. We shorten the femur. Similarly, you can shorten the radius.
Thanks, Molin. Thanks again.
Thank you.
Molin, shorten the fibula radius at which level? Proximal fibula?
So this shortening, that should be done at the distal diaphyseal-metaphyseal junction. And it should be a little proximal so that your intramedullary nail or tens nail can easily pass through. Yeah, so I will share that case to you, Sarvar and Romil, and you can share with your colleagues.
Thanks a lot, Maulin Shah. We want to shift to the next speaker. In my topic is by Dr. G.M. Jahangir. This topic is on arthroscopic suture bridge fixation of tibial spine avulsion fracture in pediatric patients.
Hello, Jack. Assalamu alaikum. Very good morning. I am privileged and feel proud to be a part of this most favorable educated program. And thanks to Bangladesh Paediatric Orthopaedic Society Conference Organizing Committee of 2022. There is vast majority of the pediatric groups are sports injury, having in the arena of sports injury section. And among them, knee injury is more common among the pediatric sports patients. And my topics is arthroscopic suture bridge fixation of tibial spine avulsion fracture in pediatric patient. The integrity of ACL and its attachment to femur and tibia is essential for proper knee kinematics, and medial and lateral tibial spine constitute the most distal aspect of ACL complex. And it is tibial spine fracture is equivalent to ACL injury in adults. That means it is equivalent in spine in ACL injury in adults. In case of about 8 to 14 years of age, this happening in the sports injury, especially tibial spine or eminence fracture in children. Tibial spine fracture represents a violation of ACL complex, and it is first described by Fonsett in 1875. And mechanism injury, it involves hyperextension injury with rotational component. Also, as in adult, that is semi-flexed knee, stand and weight-bearing position, and valgus force. The same like as. And mode of injury, it is also most commonly occurring in pediatric group. It is fall from bicycle and also from height and during their sports activities. And most predisposing factor to the type of injury is weak and unossified osteochondral junction. And it also occurs in middle-aged women due to the osteopenia. There are some classification of pediatric tibial spine injury, but mostly accepted one, Mertz and McKibbe, and it is type 1, type 2, type 3, type 4. And type 1 just partial displace of the tibial spine, and type 2 variety, it is complete fracture, but it is like bird beak type protrusion. And type 3 complete fracture and dislocation. And type 3-1 when it involves the only non-articular intercondylar eminence, and type 3B when it involves the medial tibial plateau. And type 4, it is also comminuted large fragments, sometimes elevated and malrotated. And there is most important when we go for the surgery of tibial spine, there is involvement other important structure that involve usually meniscus injury, ACL injury, condyle injury, and tibial plateau fracture, mostly medial tibial plateau, intermeniscal ligament injury, we always diagnose it by MRI and during arthroscopic procedure. And prognosis of tibial spine fracture remains guarded due to ACL laxity. And these are the evidence by some literature mentioned below. if we untreated this tibial spine, then there's some unwanted incidents are happening there. That is continuous pain, and there is stiffness of the joint, instability of the joint, functional limitation. That is daily activity is limited. And to recognize and treat associated injury as well as reduction and fixation of tibial spine fracture for satisfactory outcome. So what is the goal of treatment? Anatomical reduction of displaced fragment, achieving a continuity to ACL fibers, removal of any block to reduction like bone fragments, blood clots, intermeniscal ligament or meniscus. Adequate rigid fixation which allows early range of motion exercise and eliminate the extension block and impingement due to displacement fragment. So in our perspective, we do the protocol for the treatment of tibial spine fracture in case of pediatric patient. Type 1, only immobilization in long leg cast with 0 to 20 degree flexion and some surgeon paper to keep it the leg in full extension, 0 degree extension, and some allow to 20 degree flexion. And type 2, 3, and 4 always need surgery when meniscus or meniscofemoral ligament may be interfered, in this case reduction, and aspiration extension reveals satisfactory reduction, then immobilization in long leg cast. Otherwise, open reduction or arthroscopic procedure should be done for the type 2, 3, and 4 types of tibial spine fracture. So, I highlight the my topic in this point, that is arthroscopic suture fixation for type 2, 3, and 4 fixation. And this literature revealed that good result with arthroscopic suture fixation. Among them, most common fixation methods include either cannulated hissing screw or suture fixation. The arthroscopic suture bridge fixation, we can see this slide, that is tibial spine fracture in a children, and MRI we can see that is in homogeneous continuity of the ACL, and it is fall down, and we see this figure that is just reverse upside down of the tibial spine, and we can see that is tibial spine is also interposed with the intermeniscal ligament. And for reduction and fixation arthroscopically, we first after debridement we reduce the fracture fragment and temporarily fix the fracture fragment with K-wire from the outside. And this is the tibial spine and temporary fixation with K-wire, and we drill for the suture bridge fixation. And you can see that is outside drill, outside temporary fixation with K-wire. And after temporary fixation, we shuttle the suture proximally, usually 2 threads. And after shuttling the main, that is fiber tape or surgical wire, we do the fixation. And outside the fixation, we see that sometimes with the bone bridge or with some endobaton, or sometimes it may be do suture disc. You can see figure. And this video, we can short video for tibial spine fixation arthroscopically. We can see that is debridement of the soft tissue by radio frequency ablator, and to clean the fracture fragment and the fracture crater, and followed by we do some.
Sir, please skip to your slides because we are running time.
How many time? 8 minutes.
Already 8 minutes gone.
Have you done? Yes, only 1 minute remain. And this is procedure. You can see there is video for the arthroscopic fixation. Next. So in my conclusion, arthroscopic tibial spine fracture fixation with suture leads to adequate reduction, restoration of ACL length for appropriate healing. Secure fixation can initiate early range of motion and prevention of arthrofibrosis, the most common complication. And thank you for attention.
Thank you, sir. Thank you for your nice presentation. Please stay here for a few moments. And now we can open the floor for question. Question to Dr. J.M. Jahangir.
Thank you, Dr. J.M. Jahangir, for your nice presentation. I have a question regarding your presentation. There is the suture bridge technique. So I am anxious about suture bridging. If you bridge the whole of the tendon by suture, do you think that there is interruption or jeopardization of the blood supply of the ligament? What do you think?
There is the tendon is attached to the bone fragment. So we just put fix the bone fragment and its union will acid, then it's a continuation. So its blood supply will not hamper because two suture, shuttle suture, shall we fix the ligament, one from distal one through the posterior side and proximal one through the anterior side. So tendon, there is alternately needling suture passing through the tendon. So there is no hampering the.
You will not suture whole of the tendon.
No, no, two.
Partially.
Partially. That is distal one posteriorly and proximal one suture bridge anteriorly. So there is interruption, no continuation of the suture. So there is chance of there is wave or bleeding from the blood supply to the whole of the ligament. Thank you.
Thank you, Jahangir.
Okay.
Thank you for your nice deliberation. Shift to the next presentation by our foreign faculty.
May I request Dr. Tarun Nagda from India, one of the prestigious faculty of this session. Dr. Tarun Nagda, he will be talking about the competent assisted deformity correction in children, the fourth dimension. I think this is the top presentation. It's supposed to be me.
Okay. So I think I will start right away. And with a big thanks to POBS, I attended the first meeting of POBS, me and Dr. Wilkins, and pleasant memories of being associated with the organization. I bring to you something which is unique work which we are doing, and this is something which has been completely developed in a third world country. With help of our own engineers and our own technicians, the deformity correction in children, which is computer assisted. So all of us work on correcting deformities in children. And this is a typical child with genovalgum. And what we do is calculate the mechanical axis and do a paper planning where we would calculate Cora and then correct the angulation on paper. The problem is when you go into the operating room, it is all done by eyeballing. Whatever you planned on the paper and what you execute, it is approximate, and many times there are many mistakes which are done. Now, how computer-generated planning is different? It is not two-dimensional. Two-dimensional plannings are based on X-rays. This is based on CT scan, and it is three-dimensional. It is precise. It also allows us creation of jigs. And how the correction would take place, in the computer room before you enter the operation theater. So all types of different correction possibilities you can execute and do a virtual surgery before the actual surgery is done in the operating room. The process is as follows. We do a 3D CT scan of the area. In this case, it's a knee, and convert this 3D CT scan by segmentation into a 3D model. And then a virtual planning is done, a virtual surgery is performed in the computer lab. And then based on this design, we design a guide, and that guide is printed by a 3D printer. And that 3D printed guide now comes into the operating room, and then it allows us exact correction of the deformity in all the planes and allows us to put a plate. So this is, in this case, this is data acquisition using a CT scan This is the model which we made. And like how we plan for any deformity correction, we calculate all the angles in all the three planes, and a virtual wedge is cut. The deformity is corrected. You can see here that you can play around with the translation. On the left, you see the translation is not corrected. Mechanical axis is not maintained. On the right side, the translation has been corrected and mechanical axis has been corrected fully. So all this can be done in the computer program. And then we plan this surgery and we use routine plates. We don't 3D print specialized plates. Routine plates which are available. This is an LCP, and we 3D print a template to bend the plate so that that will completely hold the correction. So this is the guide which has been designed, and then it is 3D printed. And what computer engineers would do is give us a complete sort of a 3D video of how the correction is going to take place. So this is how the wedge will be removed from the medial side. This is the jig on the medial side, which will help us to remove the exact wedge and correction. And the screws are all pre-drilled, so that when you put the plate, the screws will go through pre-drilled areas. And as soon as you put the plate and put the screw, the deformity is automatically correct. Okay, so this is how it is done. And this is the 3D printed jig which has been done. And on the table, you can see that through a medial approach, we are putting this jig, do a medial close wedge osteotomy, and then put this plate. And you can see that the reduction is very well. On the left is the planning, and on the right side, you see the execution, and they match absolutely fine. Okay, give me 1 second. So there are many other applications. We had this case of malunited forearm fracture. Again, the deformity here is in radius and ulna, and it's not just angulation, there is also a rotational problem. And this was a big debate as to how are we going to treat this patient. This patient had restriction of pronosupination, and this was almost a year down the injury, and the X-rays don't do exactly justice to the deformity. So what we did was we realized that this deformity requires correction. Osteotomy, rightly done, can correct this deformity and get this child the right range of pronunciation supination. And there are papers, from Japan, where computer-assisted corrective osteotomy has been shown to have a good effect. But these sort of programs which are available are very expensive, beyond the reach of most of the patients. So what we did is develop a local program in India by which in less than 20,000 rupees, we could sort of plan this deformity correction. And this is how this entire thing is done, normal side and for the deformed side. And then plan the osteotomies on the model, and then develop these jigs so that when you put these wires and then finally correct the position of these wires, proximal and distal, automatically the deformity will be corrected in all the three planes. So this was done for radius and ulna. The site of the deformity correction, the amount of rotational correction, the amount of angular correction, everything has been planned using the computerized plan. So now to make it easy for us, to make sure that everything works well, the company also gives us 3D printed models. So this surgery is first performed on the computer. The second rehearsal occurs on these models to make sure that everything is going to happen well. And then you execute this surgery on the operating table using the jigs. And you can see these are the wires in the radius and ulna, before and after. Before, they are at an angle. When you correct the deformity, all the wires become parallel to each other. And this very complex deformity you can correct in apilateral and oblique planes. And this also allows you to put the plates in a proper fashion. This normal LCP, the early mobilization, and at almost 3 months after the surgery, this child has almost normal pronation supination and is able to do all the work. So this sort of results can be obtained through a 3D controlled, 3D assisted deformity correction. Supracondylar fractures malunited with cubitus. And here we do it easy. You can see that distally I'm passing these wires through the jig, and then proximally there will be wires to the jig, and we also have a slot to perform the osteotomy so that the entire surgery can be done percutaneously. You have proximal wires, distal wires, and the osteotomy being done, everything to the jig percutaneously. It is all pre-engineered so that during the surgery, you don't have to think much. It has all been planned before. And once the deformity is corrected, the wires are parallel to each other. Then you just fix it with an external fixator so that the correction of cubitus varus and rotations and hyperextension, everything can happen three-dimensionally through one simple jig. So this is how the patient looks post-op. And we have also tried this for a lot of femoral and acetabular procedures. So I'll just give you an example of a child with Coxa-Vara. So this child with Coxa-Vara also had a retroversion, and we required 3D deformity correction. So we planned the deformity correction on paper first, did a 3D CT scans, did a computer-assisted correction. And you can see here, you can have multiple options. You can have less translation, more translation, and select what it's going to give you the exact deformity correction. So that's the jig which has been made. This is the jig which is printed using a 3D printer. And this is on table, jigs being put and the deformity correction being achieved. And you can see that even in expert hands, the planning and the execution doesn't match. But here, because of the involvement of the computer, your surgical skills get enhanced. And whatever you plan, the same thing you will execute, because there is zero chance for error in this technique. So what I wanted to just convey in short is there are multiple applications of computer-assisted jigs, and this is a technique which is here to come. It's available, and at the POBS, if you want to take this as a project, along with your engineering colleges, we are ready to help you to develop this technique so that this sort of techniques are possible to do even in the third world countries. Thank you very much.
Thanks, Tarun, for your very nice technology-based, knowledgeable and expertise presentation. Now I am inviting questions from the delegates. Is there any question?
Yeah, Taral, thank you very much for pediatric orthopedic surgery of the future world. So my question is,
no, it's not, Sarwar. This is not of future. It's happening now.
For me, it's future. So is it?
And if you send us a CT scan,
right. If I send you
if you send us a CT scan, I can print a jig and send to you. I can export it to Bangladesh. It's easy to do.
So it's commercially available. That's my question. This thing is.
So we are at present doing as a research topic. Yeah. So at present, Sarwar, we are doing this as a research topic with a company association called Imaginarium. And this has been done purely as a research subject. So there is no commerce involved at present. But as far as the cost is concerned, the cost of the entire process, including printing of the jig, it is not more than rupees 20,000 per case. So every case requires a separate planning, separate jig, and they are able to do it in that cost. To give you an example or comparison, the same technology, if you were to do in Boston Children's Hospital, they spend almost $2,000.
Thank you. Let's plan this.
Which is almost Indian rupees 1,60,000. Yeah.
Next conference, you will fly to Dhaka and show us this.
Show us, please.
Next year.
Yes.
Thanks.
I have another question. No doubt it was a brilliant presentation. So my question is, definitely you have some good experience and maybe some bad experience also. What is your most worst experience in your series?
So anything which is new, whether it's a recipe for a new food or a new surgery, it goes through an evolution. It's never perfect on day one. And it has to go through that whole process. And it has taken us almost 6 years to now perfect this technology. And in this 6 years, we have had number of issues were there. I would not say there were no issues. They have been let down. There were moments of frustration. But I think today, after passing through all that, today, I think this technique has been perfected for everyone to follow. So there were problems on table. There were problems. There were fights with the engineering company. Sometimes I felt like giving up. But I think whenever you feel like doing that, giving up, don't give up. Just think one step ahead, overcome that moment, and new solutions will come. So I agree with you that there were problems, but now at present, after all those 6 years, I think we have perfected the technology and the tech.
Thanks, Tarun. Possibly this is the last question. How do we find the landmarks on the skin while placing jig?
Yeah. So when you do absolutely. That's a very good question. So when we do a CT scan, that CT scan also has skin contours. And when the jig is planned, it is planned so that it fits onto the skin contours and the bony contours. So you saw the jig for the proximal femur. You saw the jig for the supracondylar fracture. So these are jigs which are placed on the skin and they exactly fit and guide your surgery. Now there are jigs which fit onto the bones, and because it is sort of produced from CT scan of that person's bone, it exactly fits onto the bony contour. So this is one part. The second part is we also build in the navigation systems so that the wires which are placed, they correspond to some bony landmarks. So these are two check mechanisms. One is the way the jig is made to fit the contours, and secondly, wires which convey the levels. They will both, make sure that the jig is placed properly on the bone or on the skin. I hope that answers the question.
Thank you, sir. Thank you for showing us a new dimension and your way of treatment of
I have a question.
deformity correction.
In case of coxa vera, there is a subtrochanteric wedge osteotomy. Is it possible, sir, with this jig, wedge remove the wedge from the...
Yeah. So I've shown in the, So I've shown in the last case, and in this case, we have not removed any wedge. We have just done angulation translation osteotomy without any wedge, because if you remove the wedge, that will give rise to shortening. Coxa vara already has shortening. So by planning this osteotomy, the length will be maintained. So no wedge was taken.
Thank you. Now we'll shift to the next speaker. Next speaker is our Professor Dr. Moinuddin Ahmed Choudhury, one of the eminent pediatric orthopedic surgeons of Bangladesh. His topic is on distal radial fracture in children, management, tricks and tips. I'm inviting Professor Moinuddin Ahmed Choudhury, sir. Thank you.
Assalamu alaikum. Respected chairpersons and learned audience, I should pay my gratitude and thanks to the organizer of Paediatric Orthopaedic Society of Bangladesh to give me the opportunity to be here. My topic is distal radial fracture. Basically, this is the distal radial metaphyseal fracture in children. Why we should be careful about treating this type of fracture? See the scenario. This is a distal metaphyseal fracture of radius. So doctor is saying that's a simple undisplaced fracture. So we can treat it only a short-term back slap. But after 2 weeks, mother of the patient comes with an X-ray with the displacement of the fracture. And doctor is saying that I forgot to tell you that these fracture may displaced within plaster. But mother become angry. She's telling, you are just saying that because you did not set it right in place. She's so angry that she's saying, what about my daughter's hand? How would you treat? And last, she commented that you better learn the concept before you treat my daughter. So he's repented. Doctor is thinking, oops, I should have taken X-ray after 1 week. And the patient, children is thinking, why did not he do it the first time? So knowledge has no boundaries and nor any fixed starting point. So where you start, that's the start. And what you got, that's knowledge. There's the two pictures. Are these the same? This is the distal physeal fracture, which accounts 34% of the distal radial fracture. And this is the metaphyseal fracture, which is 66%. Due to the time limitations, I shall discuss only the distal metaphyseal fracture, which is more common. So distal radial fracture, the physeal and metaphyseal fracture, and classification of the metaphyseal fracture. Biomechanical patterns, there's the incomplete fracture and complete fracture. Incomplete metaphyseal fracture, the torus fracture, compression gymnastic fracture, and the bicortical gymnastic fracture. Among the complete fracture, there's the length maintaining. There is no overriding of the fracture site. And another is there is overriding where length is not maintained. This is called the bayonet fracture. Now, we have to think about the management. Depends upon the biomechanical pattern and depends upon the direction of the angulation. Torus fracture. It is very simple. Everybody we can treat it. This is stable, symbol cortex. Splint or cast for 2 weeks, 2 to 3 weeks only. No difference between if you apply the dorsal plaster or volar plaster. Anything you can give it. This is a very simple thing. But important issue of metaphyseal fracture to treat, how you will treat, you have to consider this point. If it is a gymnastic fracture, you have to think about incomplete fracture. Should we complete it? Should we correct the angulation of the fracture? Should we correct the overriding? So how will keep the limb in position of immobilization? Is there any recurrence of deformity after treating this thing? So, gymnastic fractures, whether we shall go for the completing the fracture, incomplete fracture, what literature says? Literature says, if we do not complete the fracture, there's the chance of recurrence is more. There is many literature here. But if we complete the fracture, what complication may occur? There is the displacement may occur after completing the fracture. How we can overcome this displacement? We can overcome this displacement by doing the Evans rotatory concept and the 3-point molding type. Now come to the second issue, angulation. How we can go for this angulation? A 7-year-old girl, check X after a week, and there is 32-degree angulation. The patient's parents go to the doctor. Doctor is saying, I shall go for remanipulation. But family decided to go for another opinion. They are not agree for remanipulation. The doctor said, don't worry, it will be corrected. Keep it alone. But what literature says? Professor Soik, he presented such a girl of 8.5 years old. After correction, within the plaster, after 1.5 months, the angle was 42 degree. And at the 9 months, the angulation decreased to 25 degree only. And at 19 months, the angulation is 11 degree only. So what should be the conclusion? We have learned that remodeling is very good if the age of the patient is less than 10 years. And what other literature says? How much angulation can be accepted? If the age of the children is less than 10 years, dorsal angulation up to the 39 degree we can accept. Molar angulation up to the 22 degrees remodeled, and radial angulation up to the 39 degree can be remodeled. So don't worry if the age is less than 10 years. But if the age is between 10 to 15 years, dorsal angulation up to the 38 degree, molar angulation up to the 16 degree, and radial angulation is 23 degree. So age is less chance of remodeling. Bayonet fracture, where length is not maintaining in the fracture site. Bayonet is two types. One is dorsal bayonet, another is the volar bayonet. This is one of the bayonet fracture. 10 years old child, 1.4 centimeter overriding. How will you treat it? What problems can occur if we don't correct the bayonet position? What literature says? Close treatment of overriding distal radial fractures without reduction in children. They have this paper. This published in JBJS, and they have the 51 patients, metaphyseal with bayonet position, 3 to 10 years of old, overriding 1 to 15 millimeter. And their procedure was that no anesthesia, no attempt to correct the overriding. They have corrected only the angulation, short-term cast for 6 weeks. The result was that at the 1 year follow-up, no pain, no tenderness, no non-union, wrist range of motion was normal, grip strength was normal. So at 6 weeks, and there is after 1 year. So conclusion is that if the age of the patient is less than 10 years and it come with the overriding or bayonet fracture, bayonet reduction is acceptable. Short-term cast without anesthesia is possible, and we should correct only the angulation. So second comment was right, not go for any anesthesia or reduction. Another issue of the treating this metaphyseal fracture was the recurrent deformation. What is this thing? Literature says if there is a bicortical fracture has the 3 times more chance for recurrence. And apex volar displacement is more common, but less deformity occurs. Those fracture has the dorsal angulation, they are less common, but deformity is more common. Now come to about the fixation. What is the position of the elbow and cast? Above elbow or below elbow? We sometimes remain in confusion. How we should apply the plaster. Meta-analysis of 300 patients says that no difference in displacement rate below elbow group and above elbow group. So it is proved that below elbow you can put the plaster, but you can give also the. Okay, thank you. Few minutes. Casting materials. What type of materials we can use? It is the plaster of Paris or fiber optic glass. There is the literature, and what winners do not different things, but they do things differently. And winners do not use different materials, but they apply cast differently. So application of the plaster is most important, not the plaster or materials. Good casting technique is important for success. What are the criteria for good cast? Criteria for the evaluating the cast is the cast index, padding index, gap index, 3-point fixation. But which one is the most important for this index? The cast index and 3-point index is the most important for maintaining the plaster and maintaining the position of the bone. And this is the cast index we know, A and B. A divided by B should be the 0.7. And cast index is less than 0.8, redisplacement rate is 5.6% only. But if the cast index is more than 0.8, redisplacement rate is 26% only. So well-molded cast reduces the possibility of redisplacement. So applying the plaster is most important thing. Should we pin the reduction? when to pin the radius. If there's a comminuted fracture, if the age of the patient is less than 12 years, and the fracture of ulna. And how many pins you should keep. This is the technique of pinning. And importance of the points is that the sharp K-wire, it should be less than 2 millimeter and single attempt should meet. And though pin causes the growth arrest, it is unclear. There is many literature, 65 to 75 molar, all lower and radius were pinned. Not a single growth arrest. And there is a literature, 11 patients followed up at the 3 to 6 months with MRI do not find evidence of growth arrest. What causes the growth arrest? If we use the large diameter pin, larger duration of placement, threaded pins, non-perpendicular pins, multiple attempts, and titanium pins and the biodegradable pins. This may causes the growth arrest. Close reduction and percutaneous pinning, what to do if there is a severe soft tissue swelling, if there is unstable fracture, and there is ipsilateral fracture, and there is need to remodeling. Ipsilateral fracture, close reduction and pinning, which fracture should be treated first? In ipsilateral, we should first fix the elbow or supracondylar, then we should go for the radius fracture. And if there is the open fracture, we can treat by this. When we have to plate the plate, we can do the plate open reduction and plating such a way. So we can use also the external fixator in open fracture. We learned that the reduce in 1 or 2 attempts, look for early slip or reduction, remanipulate up to 2 weeks in metaphyseal fracture. Never go after the 2 weeks. Pin in needed while avoiding the physis, avoid multiple attempts, less thin diameter pins should be used, keep long-term follow-up for growth arrest. How we communicate the parents? Any fool can make things complicated. It's hard to make things simple. Thank you.
Thank you, sir. Here I am announcing that every speaker should be confined to their limited time because we are running short of time. I'm not opening the floor for question and answer. I'm inviting straightforward Dr. Ashfaqur Rahman for his paper. His topic is on Paediatric Orthopaedic Clinic in Dhaka Medical College and Hospital.
Assalamu alaikum. Respected teachers and dear colleagues, very good welcome. And this girl is a 5-year-old girl. She is suffering from osteogenesis imperfecta, and I will shortly tell about her later on. And see his smile, and her smile explains everything. How care she have in our hospital by Professor Sarah Ibn Salam, sir. Good day. Starting 8th Paediatric Orthopaedic Society of Surgery Conference 2022. I am Dr. Ashfaq, presenting about Paediatric Orthopaedics Clinic of our Dhaka Medical College Hospital. Paediatric Orthopaedics in Dhaka Medical College, relentless endeavor to create smiles. One of its kind and prototype in the country, I think so. And it focuses on pediatric orthopedic cases as well as highlight them among all. Pediatric cases has been treated in this hospital since long, but specialized pediatric orthopedic clinic started about 8 years back. Though not well organized initially, but taking shape over the past few years. Orthopedic department of Dhaka Medical College Hospital runs a pediatric orthopedic clinic. every Saturday in ward number 113 and outpatient department room number 15, and other rooms are occupied for trauma and other male and female patients. Time is 8:30 a.m. to 2 p.m. These are our pediatric orthopedic clinic, ward 113, and in the patients are waiting there, the babies, and room number 16 and 15, we alternate it for see the pediatric orthopedic clinics. And this is the room number 18. We usually used to sit there, but now we are used to sit in 15. This is the treatment card. It was established by Professor Sir Ibn Salam sir for pediatric patient only. Total patient attending in the clinic last 6 to 7 years, what I have calculated, 21,467. Among them, common cases were cerebral palsy, 1,643, developmental dysplasia of hips, 363, LCPD, 276, congenital telepathic conivarus, 1,160, slip capital femoral epiphysis 32, and congenital dislocation of knee 92. Fixation deformity of the knee 48, rickets and its complication about 276, butt trauma, torticollis, supracondylar and lateral condylar fractures of humerus with the delayed complications frequently came to our OPD. Fracture shaft of the femur, we used to do TENS if they come earlier to our OPD or emergency. Congenital pseudoarthritis of tibia, a challenging one, and our Sir Ibn Salam are developing some tricks day by day for this treatment of congenital pseudoarthritis of tibia. Operative facilities, only 2 OT schedules are allotted for pediatric cases per month. Within our limit facilities, we try to operate varieties of cases as many as possible. Number of cases increasing geometrically as a good number of postgraduate students doing their thesis research in this field. Still, 450 cases are in operation serial, and each admission day serial is increasing day by day. Among them, 116 cases has been done so far. Specialized operation done in Dhaka Medical College Hospital, single event multi-level release for cerebral palsy 160, congenital telepathic conivarus, PMR, and tenotomy 230, more than 230, development dysplasia of 72, Barthes disease 93, bilateral CDK 34, fixation deformity of the knee 29, pseudoarthritis of tibia 19, fracture shaft of femur operative with 102. For CP, we usually do single event multi-level diseases for Barthes disease, varus derotation osteotomy, and osteogenesis imperfecta, deformity correction and stabilization by titanium elastic nailing system. Some pre-op and post-operative cases I want to show. This fracture shaft of femur, pre and post-op. Fixation by close interlocking intermediate nail by titanium elastic nailing. Closure internal fixation of supracondylar fracture by K-wires. This is that girl. She is smiling and welcoming you all from in my first slide, and she has broken her bone about 82 times. Then she came to Professor Sir Ibn Salam sir for treatment, and we have done shish kebab osteotomy at her left femur and right tibia and stabilized by titanium elastic nail. This is another case, arthrogryposis multiplex congenital with polydactyly of and equinus deformity with CDK with bilateral DDH. Now gradually it has been corrected gradually. This is the post-operative case of congenital pseudoarthritis of tibia. This is percutaneous fixation for capital femoral epiphysis, slip capital femoral epiphysis. And this is the older case, slip capital femoral epiphysis, and modified done was done. And this is the follow-up case. And, it is the picture of a pulse osteotomy with fibular graft, and we also use angle plate for that. hereditary multiple exostosis. We have operated this in Sheikh Hasina Burn Institute. These are pre and post-operative cases. Perthes, another case of Perthes disease. And this is a case of chronic osteomyelitis with exposed bone. We have operated 1 month earlier, and this is the largest sequestrum I have ever seen. Some tips and tricks we have applied here, that is for closing, and Professor Molinsha also showed that Wrigley saw when we troubled to insert the Wrigley saw into the malleolar cavity. I have used a K-wire with the Wrigley saw, so in small foramen, Wrigley saw can be used. And this is the shoelace technique by stopper pin is very useful to us. And in this whereas the rotation osteotomy, we put 2 K-wire to see the angulation and internal and external rotation can be measured clinically. Our limitation. Our resources are limited. Trained, skilled, and experienced specialists and associated healthcare personnel are not sufficient. Video. This is the actual picture of Dhaka Medical College when it is in this corona situation. It is also crowded like that. And adult patients are usually take seat in floor for waiting for operation. In case of pediatric children, we have to have that list, waiting list, and we call them upon after each time bed is vacant. We call them from their home to admit at the same time. Take home message. Paediatric orthopedic patients need special attention and care. Paediatric Orthopaedic Clinic of Dhaka Medical College is trying to build a platform for them. All physicians, especially orthopedic surgeons, are requested to share ideas and experience to strengthen this effort. This is our Sir Ibn Salam, sir. Puler pashe unake ashole manai ebong the picture showing the blurred effect of Sir Ibn Salam, sir, as he has transferred from Dhaka Medical College to Nitor, and saying that the bagan rekhe gelam, full rekhe gelam, Bobby, Ashfaq, Maruf, Jilani tomra jotno niyo. And this is the pediatric orthopedics also spreading to Meherpur, Chuaranga, Borishal, and Joshua, as well as Bamishing by Dr. Noman also. Thanks to Professor Anwar Query, sir, for starting the journey of pediatric orthopedics in Bangladesh, and hats off towards the effort of Professor Dr. Sir Ibn Salam, sir, for popularizing pediatric orthopedics among youngsters and teaching his pupils what he learned over his lifetime. Sharing his experience with all made him a living legend. Thanks to all my teachers and spreading the lights at every corner of the country by their passion, knowledge, and hard work. Thank you. Thank you all.
Thank you, Ashfaq. This is a brilliant job, and you are keeping your accounts of your service. And Dhaka Medical College, this is a museum, live museum of patients you are dealing with. Thank you once again. I'm inviting now Dr. Wakil Ahmed. Wakil Ahmed, his topic is on double bundle medial patellofemoral ligament reconstruction, a dependable option for patellar instability. Dr. Wakil Ahmed.
Thank you, Mr. Reporter. Respected chairperson of the session and the leading orthopedic surgeons of the country. Just very good morning to everybody. It's a great privilege for me to be here with my presentation. My presentation is a double bundle medial patellofemoral ligament reconstruction for the lateral patellar instability. It's a dependable option for patellar instability. This is Dr. Wakil Ahmed. I'll be with you for next 8 minutes with my presentation. At the end of this presentation, the learned audience will be able to recapitulate the risk factors and causes of the patellar instability. I will talk on the clinical and radiological evaluation, some important steps of the MPFL reconstruction, post-op rehabilitation, and some video clips. The knee joint is one of the largest weight bearing joint of the body. Then patellar stability is very important for very smooth and good function of the joint. You know, when the articulation of the joint is well tracked, well aligned, and good functioning joint is possible. So see the anatomical landmarks of the MPFL, that is medial patellofemoral ligament, which attaches from the medial side of the patella, and the femur you see in between the adductor tubercle and the medial epicondyle, the femur. The role of the MPFL, you know, it is the most vital chakrane, medial stabilizer of the patella, which prevents the lateral dislocation of the patella from its normal position. And it's from the full extension up to the 30 degree. The pattern of tear you see, the tear may be from the patellar side, the tear from the femoral side. Sometimes it may be the mid substance, or sometimes it may be in combination from both sides. So instability is inherent disorder, and stability is always a safety. There are different factors for the instability of the patella. You know, there are some general factors, there are some anatomical factors, osseous and muscular. You know the classification, the acute or traumatic dislocation, you know the recurrent dislocation, habitual and permanent dislocation of the patella. The complaints of the patient, you know, there is knee buckling suddenly, can no longer support the weight, the kneecap or patella slips, sudden catching of the moment, and pain. Sometimes there is crack sound and swelling of the joint also. The physical examination, you know, there is patellar mobility. You will find the Z sign when you move the knee joint. A precision test is positive, and there will be increase in the acute angle of the patient. See the X-ray? The patella is shifted laterally in the skyline view or in the sunrise view. See? The radiological evaluation is important for surgery because the position of the patella, you see, by Blumenstedt's line, you can see the position of the patella, whether it is high up or in normal position, or insult salvation ratio. We can measure the position of the patella. And preoperative planning is also important to identify the anatomical landmark of the MPFL in the femur. You see the landmark, the star mark. This is the femoral attachment, which is the red line in the posterior cortex, along the posterior cortex. The blue line you see in the posterior condyle line, and 2 cm below, that is epicondylar line. And in between these two lines, and just 1 mm in front of the red line, that is the anatomical point for the attachment of medial patellofemoral ligament. See? The MRI can give the accurate delineation of the injury pattern of the medial patellofemoral ligament. In single time dislocation or in single time instability, we should not try for the surgery. We can try conservatively. But when there is recurrent dislocation when there is frequent dislocation, the surgery is indicated. You know, there are different methods of surgical options, surgical management. But the most modern, most popular, and most dependable technique is the MPFL reconstruction. We should follow some basic principles regarding the selection of the graft, which should be strong, or should be stiff, which should be isometric when you fix it, in correct tension, with stable fixation, without having any impingement and rubbing. An arthroscopic evaluation of the interior of the joint is very essential to see whether there is any cartilage damage or any cartilage or bony fragment inside the joint. We should be removed it. You see the interior of the joint. So this procedure in the pediatric group of the patients is arthroscopic assisted. See the graft site, harvesting the semitendinosus from the patient's region. The graft is prepared by stitching both the free ends. You see, the two parallel hole is made in the patella in center and just above the center, 2 centimeters apart. The hole size is 3.5 to 4 mm. The tendon is passed through both the tunnel, making a loop. You see the BD clip, and we do the lateral raise by arthroscopically prepare the graft. At the same time, passage of the graft through the tunnel, making a loop on the lateral side. And both the side of the tendon, both the bundle of the tendon is pulled medially. And cycling of the knee joint for adequate tension. See? And the shortest point that I mentioned earlier, which is identified by fluoroscopic view, and we fix the graft on the femoral side by a biodegradable screw. And post-op rehabilitation is very essential to get a good result. In our series, we did 12 pediatric patients, age range from the 14 to 18 years, and average follow-up was 24 months. One patient had fracture of the patella during physiotherapy, and one patient did not gain the full range of motion. But in our series, we got the improved knee stability, improved knee function, and reduced pain. You see the follow-up after 3 months of the surgery, the full squatting. You see pre-op and post-op video of the patient. Full range of motion of the patient. And full squatting of the patient, you see, from standing position. So take home message. The MPFL is the most important check frame and stabilizer of the patellar stability. MPFL reconstruction is the most reliable, most dependable, and most popular option nowadays. Preoperative assessment and proper planning is very important, and adequate post-op rehabilitation is necessary. Success to me is only two things. When there is stability, there is happiness of the patient. And thank you very much for your patience hearing.
Thank you. Okay. This is a very nice presentation, I think.
Sir, I have a question.
Opening
Sir,
the floor for
only
question.
in habitual dislocation of patella, only MPFL reconstruction is sufficient, sir? This is a la carte approach.
Yeah, if it is permanent dislocation, the result is less. If it is traumatic dislocations and recurrent dislocation, the result is very good. But if we augment the medial MPFL reconstruction with MPTL, that is medial patellofemoral and tibial reconstruction, they give the most better result. Yes.
Patella, the medial lateral structure is usually contracted. On the medial side, there is lax.
Yes.
How can you balance in such case where lateral structures are contracted?
Already I mentioned we did lateral release by arthroscopically. Sometimes we need to extend the release up to the quadriceps. So lateral release is essential, and medial graft stabilization or reconstruction. Thank you very much.
Another question. Okay.
Yes.
Thank you for your presentation. My questions two. Number one, what is the double bundle site on the medial side of the patella? And another question, I just put the biodegradable issue on the
Femoral side.
femoral side. What is the position of that?
The first one is the site of patella, the tunnel in the midpoint and just above, because the anatomical attachment of the MPFL is the proximal half of the patella. That's why our tunnel position is the center and just above is 1 to 2 centimeter apart. The second one is the position of the biodegradable issue. I already mentioned there is the shuttle point. Shuttle point is between the landmark is between the medial epicondyle and medial.
No. Now my question, where is the position of the knee? Either full flexion or 30-degree flexion?
30-degree flexion.
0-degree extension.
20 to 30-degree flexion during insertion of the screw.
I think I won't allow any more question. We are running short of time. I'm inviting my next speaker.
Thank you very much.
Is Dr. Tariqul Alam Noman. His topic is on interpretation of X-ray in LCPD, leg curve Perthes disease, interpretation of X-ray.
Thank you, Mr. Chairperson, sir. My respected teachers and delegates. This is Dr. Tariqul Alam Noman from Mymensingh Medical College going to talk on the interpretation of X-ray in Perthes disease. You all know LCPD is a condition where the blood supply of the capital femoral epiphysis is disrupted. Ultimately, it results in epiphyseal osteonecrosis and chondronecrosis, as well as cessation of growth of the ossification nucleus. Most prevalent in 4 to 8 years of age with bilateral involvement of 10 to 13%. Independently, this, sir. Sorry for the interruption. Sorry for the interruption. You all know this is Dr. Tariqul Alam Noman from Mymensingh, going to talk on interpretation of X-ray in Perthes disease. Actually, LCPD is a condition where blood supply of the capital femoral epiphysis is disrupted. It results in epiphyseal osteonecrosis and chondronecrosis. Ultimately, cessation of the ossification nucleus has been occurred. This is most prevalent in the patient group of 4 to 8 years with bilateral involvement of 10 to 13%. In 1910, this was recognized as by Arthur Lake, Jacques Carr, George Perthes, and Henning Waldenstrom. Among those, Mr. Henning Waldenstrom at first described the radiographic findings of Perthes disease. In diagnosis as well as the evaluation of the stage and the extent of the disease, we do X-ray of hip, including we do X-ray of pelvis, including both hips, AP and frog leg lateral positions are sufficient. X-ray, plain X-ray is sufficient to determine the extent of the epiphyseal involvement as well as to stage the disease. It is very important to view all radiographs sequentially and to compare them with the previous radiographs to assess the prognosis of the affected hip. Mr. Waldenstrom radiographically classified Perthes disease in 4 stages. This is the stage of increased density, where the ossification nucleus is usually smaller and the medial joint space is usually wider. This widening is due to the synovitis as well as the decreasing size of the involved femoral epiphysis. In fragmentation stage, radiographically, the repair process has become more prominent. By seeing this type of fragmentation, we can radiographically assess or diagnose the fragmentation stage of Perthes disease. This is crescent sign. This is one of the very early signs of Perthes disease in fragmentation stage. Actually, this is the subchondral fracture or subchondral radiolucent zone you are seeing here. At first, it was described by Waldenstrom. Later, Mr. Kefe brought these signs into a wider attention. Actually, Salter-Thompson classification is based on the involvement of these findings. In healing or reossification stage, radiographically, normal bone density try to returns. At first, the 4th stage were considered as the healed stage. Later on, Waldenstrom modified these stages as the stage of residual deformity. Here, the proximal femur may have residual deformity either from the disease process or from the repair process. This X-ray was taken 4 years after the involvement of Perthes disease. Here you are seeing that the hip is reossifying, but this is not completed. These X-ray 2 years later more, that is after the 6 years of involvement. Here, this is the ossification of this involved hip is improved. We sometimes find some findings in the metaphysis of the affected hip as well. Among those, the metaphyseal cyst is the most important one. This is the metaphyseal cyst. If any confusion arises, we can do an MRI to exclude the other pathology of the metaphysis. In the metaphysis, sometimes you can get sagging rope sign. What is this? A sagging rope sign, this is the sign, which is a rope-like radiodense line across the intertrochanteric area. This actually caused due to the enlarged femoral head or coxa magna radiographically. In the physis, sometimes we got some breezing. Here you are seeing the breezing. And this breezing may cause these types of changes in the physis. That is trochanteric overgrowth, femoral neck shortening with valgus tilt. This is another thing which is called bicompartmentalization of the acetabulum. When femoral head protrudes from acetabulum, medial wall may form that looks like a second compartment of the head. This one. This is one compartment, this is another compartment. This is considered as the bicompartmentalization of acetabulum. Look, this is a very indication of very poor outcome. In acetabulums, we can find in a healed Perthes as the acetabular retroversion. There, the lateral ease of the anterior acetabular wall ends more medially than the lateral ease. This one. Actually, this is indicated by the crossover sign of these two walls. Catarrhal classified radiographically the Perthes disease into 4 steps. In catarrhal group 1, only the anterior portion is affected. In catarrhal group 2, more part of the anterior portion with some findings in the metaphysis you can see. In catarrhal 3, most of the epiphysis is sequestered. This is the catarrhal stem. Most of the epiphysis is involved. And here the metaphyseal changes are diffuse or local, especially in anterolateral area of the neck. In group 4, whole of the femoral head is usually involved. Radiographically, lateral pillar classification has got more popularity. In these stages, this was introduced in 1992 with 3 groups, group A, B, and C. Later on in 2004, Herring and his colleagues added another group by adding B and C. In group A, usually the lateral pillar is intact. This is intact, but less than 50%. And this here, more than 50% is collapsed. B and C is in between. Sometimes we apply lateral pillar classification too early. This has some problem. If you apply lateral pillar classification in early stage, there may be a chance of underdiagnosis of the disease. These X-rays were taken from the same patient 4 months sequentially. This shows lateral pillar B. After 4 months, B and C. After 4 months, this is C. So be cautious to apply the lateral pillar classification. This is the Stuhlberg classification. By using this, we can find out the outcome. Actually, this is a technique by which we can distinguish Stuhlberg 2 and 3 hip classification by making a circle in the AP view and that match with the frog leg lateral view X-ray. This is Saturn phenomenon. This is radiographically, this is an indication of poor outcome. Here, the epiphysis got sclerosis surrounded by a ring of lucency, and this saucer-like appearance, that is the medial and lateral flattening, is often outcome is often poor. Sometimes radiographically, we have to differentially diagnose the differential diagnosis of LCBD. In normal hip, you can find this type of dimple effect. Actually, radiographically, this is the radiographic projection of central notch of the femoral head. This is not the hip of Perthes, this is a normal hip. In epiphyseal change in hypothyroidism, we find delay and irregularity of ossification. And in multiple epiphyseal dysplasia, there is usually no metaphyseal involvement is found. Jihad, an 8-year-old boy, presented to us with lateral pillar BC and lateral group 2. We did video. This X-ray was taken 12 weeks after. This is 8 months post-op. This is 6 months post-op, 16 months post-op. And this X-ray was taken 2 months after the removal of the implant. This is another case type. He at first presented to me with lateral pillar A, lateral group 1. We decided to observe the patient, but after 10 months, he developed lateral pillar B, lateral group 2 also. We did video. And this is the 1 year post-op X-ray. This is another patient, Raihana, 8 years girl, lateral pillar BC, lateral 3. We did video. This is Adil, a 5 years boy. We applied a Petri cast and we find a good result in this patient. Finally, I can say radiography findings help to assess the extent and severity of the disorder. Several systems have been developed to determine the severity of the disease and to address final outcome based on radiographic findings only. Plain radiographs of hip in AP and frog leg lateral positions are sufficient. Radiographic findings are used in making the diagnosis and also for the assessing of the prognosis as well. Thank you.
We can invite only 1 or 2 questions as we are running short of time. Please, if anybody asks. If
lateral or cross-table lateral is more informative.
Thank you. Thank you.
In early stage of disease, both AP and frog lateral both are needed. At the first stage, we find out the increased density that you can see in the AP view. In the very early stage, you can find out the widening of the medial joint space in AP view. But whether the condition of the lateral pillar, is it involved or not, to include or to exclude this, you have to do the lateral pillar, frog leg lateral view.
Thank you, Noman. I'm now inviting Dr. Kaiser Rafi. Kaiser Rafi, his topic is on factors affecting the outcome of chronic osteomyelitis in children.
This is the last lecture of this session, and after that we'll go for tea. Previously we had 30 minutes for tea time. Now we'll have only 15 minutes of tea time. Next chairman, Professor Moinuddin Ahmed Choudhury and Dr. Mehdi, please take it in your mind. And Lunchtime we will also curtail by half an hour after the second session. Okay. 15 minutes. Okay.
Start, please. Good morning to you all. Today we are here. Our topic is factors affecting the outcome of chronic osteomyelitis in children. I am Dr. Kaisurabi. Sound, please. Chronic osteomyelitis results from inadequate or delayed treatment, and treatment of chronic osteomyelitis is obviously challenging. Sound video it's very difficult to predict the outcome. Then the outcome of sound video We evaluated 40 consecutive patients who were treated for chronic osteomyelitis in a single center with uniform protocol of treatment. The purpose of this study is to identify the factor that is associated with poor outcome, which in turn help the treating surgeons to forecast the possible course or length of treatment. 40 patients were included in this study who were treated in between 2006 to 2012, was primarily diagnosed as acute hematogenous osteomyelitis. And we excluded some patients who was like chronic osteomyelitis secondary to open fractures and postoperative infections. The male-female ratio was like 2:1, where male was 27 and female was 13, with an average age group of 8 years, ranging from 1.5 to 14 years. Detailed history about the onset and duration and surgical intervention, previous surgical intervention were obtained, and the history of any associated illness, like if there is any comorbidities, are also noted. The main thing that we used before starting treatment was like a plain X-ray and a MRI. MRI was carried out, and this MRI is like a standard T1, T2, and fat suppressed images. Along with that, blood investigation like complete blood count, ESR, CRP was also taken. All these patients after operation, like we send the pus, sometimes all of the abscess for bacterial culture, and sensitivity to antibiotics was gained from there, and used that to treat that patient. And standard treatment protocol was followed for each and every patient. After reviewing the MRI, we actually decided regarding the local or pan-osseous debridement, and fewer times we decided to go for marrow decompression also. Fewer patients came with pathological fracture, and sometimes gap non-union was there with the long or short segment of sequestrum also there. And we used additional stabilization with a nail, and fewer times with external fixators also. Patient receives parenteral antibiotics for like 5 or 7 days. Then when the blood markers was slowly going down, then we shifted from injectable antibiotics to oral antibiotics, and continued that oral antibiotics for 6 weeks. The average follow-up was like 2.5 years, ranging from 1.5 years to 7 years. We classified our terms into 3 main groups: good, fair, and poor. Among the good, which was 18 among 40 patients, none or single surgical intervention was needed to restore the bony architect properly. And in fair group, which is 10 among 40, the further intervention required to improve the range of motion or bone morphology. In these cases, we needed like a soft tissue release, sinus tract extraction. Then fewer times we need to go for sequestrectomy. Fewer time we needed external and internal devices to stabilize the segment also. And in poor group, which is 12 out of 40, there was no gap non-union, and local bone grafting and additional stabilization was done. Then in Second stage, we used bone transport by using destruction histogenesis, osteogenesis by means of either releaser of ring fixator, and fewer times we used uniaxial fixators also. Bacterial culture of the pus and the material revealed that methicillin sensitive Staphylococcus aureus was like 33 among the 40 cases, and methicillin resistant Staphylococcus aureus was 5, and 2 cases were presented with gram-negative bacilli. So in between the poor, fair, or good outcome patients, there was no statistically significant difference in the occurrence of poor outcome with the regard to like age of the patient, site of the infection, which bone involved, like type of antibiotics we used, or type of causative organisms. Though one note is there, like among these 12 patients, 5 patients has had comorbidities like aplastic anemia, splenectomy, and fewer time they had suffered with systemic multifocal infections also. The key finding that we found that differentiates between poor outcome and good outcome is like there was circumferential soft tissue abscess around the periosteum in 75% cases of poor outcome, though in good outcome it was only 20%. And another thing is like the symptom duration. In all poor outcome patients, the symptom duration for presenting towards the operating surgeon was like more than 6.5 weeks, and in those cases with good outcome it was less than 4 weeks. In conclusion, what I should say, like it's not uncommon to see the delay, and the treating surgeon may be in a dilemma because this patient may have went through multiple surgeries over the past few months, first few weeks before presenting to you, and this study actually will help predicting the possible outcomes in these patients. But what we recommend is going for an MRI before treating or before starting to treat the patient. And to keep in mind, those patients with chronic osteomyelitis who have symptoms in excess of 5.5 weeks before the first surgical intervention, if there is multiple local debridement without pan-osseous decompression and presence of soft tissue abscess on MRI, these are the significant risk factors that is associated with gap non-union. The vote of thanks extends towards our co-authors, Dr. Malin Shah, Gaurav Gupta, and Akash Makaria. Thank you all.
Thank you all. So now I'm open for questions if you have any questions regarding this.
Thanks all speaker for their elegant presentation of this session, and I am congratulating all the speakers of this session and wish you all the best for 2020.
Sir, একটা প্রশ্ন আছে একজন রুলাবিন বলো।
Assalamu alaikum. In this study, 4 patients was managed chronic osteomyelitis. Among them, how many patients was managed by intermedullary nailing, and what was the outcome?
So we considered intermedullary nailing when there was any like pathological fracture was there, or if we have seen or studied through the MRI and got that the bone condition is not good enough after debridement, and sometimes fewer times like marrow decompression, the bone may not hold itself. If we have found out bone like that weak, then we considered intermedullary nailing or external fixator in the form of ring fixator or monorail fixator. Fewer patients, like 4 or 5 patients, went through fixation in this case series. But what I should say, among the poor outcome group, we have 12 patients. Among those 12 patients, each and every patient went through external fixator or intermedullary nail. The exact figure of only intermedullary nailing that is only 5. Okay. But along with intermediary nail, we used a ring or uniaxial external fixator in all the pore group. As I have defined there, the pore group is only those group who had gap non-union at the end. Okay, so to combat the length of the bone or length of the tissue or length of that limb part, we use that external fixator device also.
Thanks. We are now concluding the first session. The second session will be started after 15 minutes of the tea break. The chairpersons will be the Director Professor Moinuddin Ahmed Chaudhary.
Thank you.
Moinuddin Ahmed Chaudhary and Dr. Mehdi Nawaz.
from several children's hospitals over South Korea. And I'm going to talking about the timing and types of very difficult issues. So first of all, is the parent responding appropriately according to your treatment philosophy? And also, how do you judge a satisfactory hip development? And lastly, when do deterioration of the hip development? This is a natural history of the DDH case. Even though the patient has a good acetabular and femoral side development, after 7 years later, at the age of 15, we have no subluxation, but still dysplasia or poor acetabular coverage. We do not know the fate of this hip in the long run. After 2 years, 7 years later, I have done the Surgery innominate osteotomy for treat the residual dysplasia. The remodeling and the femoral side is almost normal, but we do not know the
Hello, sir. Hello, sir. Sandeep, sir, can you hear me? Sir, please unmute yourself.
Yeah, can you hear me?
Yeah, I can hear you, sir. Yeah, now we are in tea break. After 10 minutes, we'll be back. Hey, PEDHKIM, onake co-host koro. Please make co-host him. PEDKIM. Co-host. Fine, thank you. Kim, sir, can you hear me?
Yeah.
Oh, thank you very much. Yeah.
Okay.
Now we are in tea break. So we'll be back on after Within 15 minutes.
15 minutes?
Yeah.
Okay. Okay.
Yeah. Please stay on till then. Thank you. Yeah, sorry, sir.
Is there any mechanical problem in presenting the files?
Good morning, sir. Yes, sir, I have checked your video presentation, sir, and it's perfectly okay. There is absolutely no problem over there. So once the whole recording will be concluded, then you can start your question and answer session, sir.
Okay, good.
Okay, sir. But we are running a little bit behind right now. The tea break is about to be completed by now. So after that, we will start our second session, and you are on the fifth position in that second session, sir. So from now on, the four speaker will speak first, and then your session will come, sir.
No problem.
Yes, sir. Thank you for joining, sir.
Okay, no problem. No. Good morning, everybody. I'm Hyun Kim from Seven Children's Hospital, Seoul, South Korea.
Welcome to everybody. In the session 2, Paediatric Orthopaedics Society of Bangladesh is welcoming everybody to hear the session 2. I am requesting Dr. Muhammad Sirajul Salihin. Dr. Muhammad Sirajul Salihin to come to dais to present his paper. His paper is Limb Salvage in Pediatrics Malignant Bone Tumor. With the chairperson, I am Professor Dr. Moinuddin Ahmed Chaudhary, and
I'm Dr. Mehdi Nawaz.
He's from Vice Principal of Khulna Medical College.
Sirajul Salihin will get 10 minutes, 8 minutes, first bell, and final bell after 2 minutes. And his topic is limb salvage in pediatric management bone tumor.
I feel honored to give me the Paediatric Orthopaedic Society of Bangladesh to give me the opportunity to present this paper in this prestigious occasion. I, Dr. Muhammad Sirajul Salihin, working as the Assistant Professor and Chief Ortho Oncology Unit, National Institute of Cancer Research and Hospital. And my topic is limb salvage for pediatric malignant bone tumors. And this is my institute, National Institute of Cancer Research and Hospital. It is 500-bedded hospital, and Ortho Oncology Unit is going his journey last year. It is a 9-bedded unit. And now, come to my presentation. Although malignant bone tumors are uncommon in children, but pediatrician and orthopedic surgeons are frequently involved in the initial evaluation and management of the children with these tumors. Primary bone tumors are the 6th most common neoplasm occurring in the children and constitute approximately 6% of all childhood malignancies. Benign bone lesions frequently are more common compared with the relatively rare malignant neoplasm of the bone. In pediatric age group, most common cancers metastases to the skeleton are neuroblastoma, rhabdomyosarcoma, and the clear cell sarcoma of the kidney. And 2 types of primary bone tumors dominate in the pediatric and adolescent oncology. Number 1 is osteosarcoma, and another one is Young sarcoma or pinnate family of the tumors. So what is limb salvage surgery? It is a set of surgical techniques that have been developed to restore the skeletal continuity following en bloc resection of the bone and soft tissue neoplasm. The goal is painless limb and functional tumor-free limb. So the criteria for limb salvage surgery is tumor resection with oncologically sound margin. Reconstruction leads to a functional limb, and all soft tissue defect can be closed primarily or with soft tissue transfer. So there are 3 stages for performing a limb salvage surgery. Stage 1 is tumor resection, that is principle of surgical oncology. And stage 2 is stable painless skeletal reconstruction, that is principle of orthopedic surgery, and surrounding and soft tissue reconstruction is the principles of plastic surgery. So 3 types of surgery are involved for doing limb salvage surgery in pediatric malignant bone tumor. So there are reconstruction options are 2 types: non-biological options, endoprosthesis, allograft prosthetic composite, and resection arthrodesis. And biological reconstruction methods are non-vascularized graft. We usually use fibula. We can use up to 22 centimeter fibula for the vascularized and non-vascularized graft. Allograft, recycled bone, and rotational plastic can be done. So what are the barriers for the limb salvage surgery in children? The first barrier is the poorly placed biopsy incision. So biopsy must be done by the operating surgeon who will perform the limb salvage surgery. The next option barrier is the major neurovascular bundle involvement, displaced pathological fracture, fungating an infected tumor, recurrence of the malignant tumor, and maintain the limb length discrepancy. So there are 3 strike rule: bone, nerves, vessels, and soft tissue envelope. If 3 of these key components are involved, limb salvage is probably not worth considering. So for doing the limb salvage surgery of malignant pediatric bone tumor board is mandatory. The members of the tumor board are orthopedic oncosurgeon, pediatric hemato-oncologist, radiation oncologist, radiologist, and histopathologist, especially muscle histopathologist. And by giving the decision from the tumor board, we will perform the limb salvage surgery. So for doing limb salvage surgery, first take proper diagnosis is mandatory. Take proper history, and X-ray is the basic investigation, and next is the MRI, and sometimes CT scan is done in the inaccessible site like pelvis. And next step is the histology. Always biopsy, and we prefer needle biopsy, that is jump city needle biopsy. And the next step is the staging. We do CT scan chest, bone scan, and preferably PET CT scan. And last of all, the treatment options are neoadjuvant chemotherapy, then surgery, adjuvant CT or RT. So successful of the limb salvage depends upon early management and referral. Multidisciplinary workup is mandatory. Early stage, good prognosis, and patient education is mandatory. And always do R0 surgical resection, and we will get successful limb salvage surgery. And now a 14-year-old boy presented with osteogenic sarcoma of the distal femur with received 4-cycle neoadjuvant chemotherapy. And this is the post-NACT X-ray and MRI. And this is the paraoperative picture. We include the biopsy mark along with the incision. And this is the resected specimen. This is the biopsy tract also. And this is the endoprosthesis. And this is the femoral artery and femoral vein. And this is the 6 months follow-up patient. And patient is walking with no aid, walking aid. And this is we follow up by musculoskeletal tumor society scoring system. And this is another case, 16-year-old boy presented with osteosarcoma of the proximal tibia with 4-cycle NSCT. This is a paraoperative picture. We give the gastroflap after putting the endoprosthesis. And this is a 6 months follow-up. And this is a 16-year-old girl presented with osteogenic sarcoma distal tibia. We have done wide local excision with bone transport by Elijaros, and arthrodesis of the ankle joint was performed. This is another boy, 17-year-old boy presented with osteolytic lesion in the proximal femur. And unfortunately, our orthopedic surgeon do biopsy with fixation by DHS, long DHS. And we have given 6-cycle NSCT and wide local excision and endoprosthesis was performed. This is another patient, young sarcoma of the diaphysis of the femur. We have done wide local excision with diaphyseal endoprosthesis. This is a postoperative X-ray. And this is a 14 postoperative day follow-up. This is another patient, 14-year-old, but presented with osteosarcoma proximal humerus. This is the post-NSCT X-ray and MRI. And these are paraoperative images. These are paraoperative images. And this is a postoperative X-ray. And patient is riding his bicycle after 20 months of the surgery. Is another patient, 14-year-old boy, presented with young sarcoma left hip bone with 6-cycle NSCT. These are paraoperative images. We have done wide local excision, that is level 1 and part of the level 2 internal hemipelvictomy with fixation by pedicular screw and rods. And these are post-operative images. And these are post-operative X-ray and post-operative video after 4 months and getting adjuvant CT. So my home message is limb salvage surgery or wide local excision is the technique of choice for primary bone sarcoma. In comparison to amputation, wide local excision has same overall survival and local recurrence rate, early return to the function, higher patient satisfaction, lower energy expenditure for walking and better cost basis, and must do R0 resection when we will do limb salvage surgery for malignant bone tumor. And last of all, never forget your mentor. He is my teacher, Professor Iqbal Kabir sir. He is my inspiration for performing this ortho-oncology. And thank you very much for patience here.
Thank you, Dr. Salehin. Please stay in stage. Any question to Dr. Salehin? Tushar.
Sir, so you tell the biopsy should perform the oncosurgery. So I am working in NATO. I have forced to do biopsy for tissue diagnosis. So there is a criteria how we do perform the biopsy. So can I do the biopsy or not?
If you do the final surgery, you must do.
No,
you can do the
I
biopsy.
am not an oncosurgeon.
But you should know the proper principle of taking the biopsy, and you should.
It is the rule.
Yes.
There is a criteria that যেটা আমি করতে পারি, তাই না?
Yes, sir.
Thank you.
Any other question? I have a question to Dr. Salihin. What is the long-term outcome? Have you any recurrence? And what is the chance of infection? Or the incidence of infection and incidence of recurrence in your prosthesis group?
Thank you, sir, for your nice question. One of my students in my institute are performing the thesis of endoprosthesis in malignant bone tumor, and he have done 35 cases, and in last 2 years, 2 infection occur, 1 hip dislocation occur, and 1 local recurrence occur. Last 2 years.
Thank you very much. Thank you. Our next presenter.
Thank you. Now I would like to request Dr. N.H. Shetu for his topics, femoral neck head tunneling and arthrodiastasis of hip joint by Elizar of Fixator for the treatment of Parthis. Dr. Shetu.
Yeah, Assalamu alaikum. I am Dr. Najmul Huda, working in NATO. Thank you for giving me the space in this prestigious occasion. And I'm starting my presentation, femoral neck head tunneling and arthrodiastasis of the hip joint by Elizar Fixator for the treatment of Parthis disease. Next. Very earlier, Dr. Tariq already mentioned about the Parthis disease. So it is easy for me to pass the slide and keep the time with the allocated time. The incidence of LCPD under the age of 15 years of children, more in white and low in black, economically poor in urban environment. Boys are 4 times affected than girls. LCPD is usually diagnosed among children younger than 15 years and peak 5 to 8 years of age. Risk factors and prediction: a compromised blood supply to the epiphysis of the femoral head, and factor 5 latent mutations, hypertension in children play an additional role in pathogenesis of LCPD, low birth weight, lower levels of circulating insulin like growth factor 1. Aims of the study: contains the femoral head in situ with hip arthrodiastasis in 10 to 15 degrees abducted position and neck head tunneling with multiple smooth wires, promote the vascular circulation by Elizar method to see the ultimate outcome of LCPD. Method: number of patients 6, male 5, female 1, affected head of the femur, left 5, right 1. Age of the patient 6 years to 13 years. Place of operation in NETOR and in private hospital. Time 2019 to 2021. Diagnosis: all cases are diagnosed by clinical examination and X-ray. MRI or CT scan were not done. Clinical examination done, Trendelenburg test, Thomas test, roll test, and hip movement test. That is favor test, limitation of internal rotation and limitation of abduction. Most commonly used classification system is Herring classification. Within first 6 months of clinical symptom in the early fragmentation stage, it can be applied. It is based on involvement of lateral pillar of the epiphysis, loss of lateral pillar, height on AP view. You can see the diagrammatic picture of hearing classification. That is picture A, 3 pillar, lateral, central, medial, and group picture B, group A, that is 100% lateral pillar is maintained, and group B, picture C, that is group B, more than 50% lateral pillar is maintained, and group BC border, that is picture D, tall and narrow type is shown with slightly more than 50% of lateral pillar height is maintained on lateral base, a narrow base. And picture E, group C, less than 50% lateral pillar is maintained. That is group BC is further divided into three. That is 50% loss of height, BC1, BC2, and BC3. Why naked tunneling and arthrodiastasis? Nuno Criverio mentioned that the current research indicates that naked tunneling could be the essential in prevention of leg cup Perthes disease if used in the pre-radiological ischemic stage of the disease, characterized by hip pain and limping that can be detected through subchondral cold spot on MRI. Professor M.M. Bari mentioned in his article, Elizarov for leg cup Perthes disease, Elizarov articulated hinge dissection provides effective containment which allows prolonged remodeling while avoiding the limitations of femoral varus osteotomy, short limb, and Salter osteotomy in complete containment. Gamal Hosni mentioned that joint destruction attempts to neutralize muscular and weight-bearing forces on the femoral epiphysis, induces neovascularization and prevent head deformation. According to Pele, cartilage in the LCPD is very bioactive and tends to proliferate in unloaded region of the hip joint, and destruction obtained with the external fixator takes the load off of the femoral head, creating a space for the proliferation of the cartilage and shaping itself into the acidolar cavity. Procedure of this Elizarov technique. The patient is placed on a radiolucent table in supine position under anesthesia. After full aseptic draping, exposed affected limb using a CM perpendicular to the operating table. The affected limb is positioned in medial rotation in order to place the neck of the femur parallel to the ground. 1.5 mm K wire was passed aiming from lateral surface to the upper thigh through the neck of the femur to the fascial plate of the head. 3 to 6 wires were used in the same manner. Small, strong, stout arch, like Italian arch, was fixed to the supraacetabular region of the pelvis with 4 to 6 mm hub pins. Femur was fixed by 2 rings. One is placed at the middle and distal third junction of the thigh, and other ring at the distal to the distal third. Now, femur was fixed with Italian arch of the pelvis by 2 hinges and with medial bar. Hinges were placed at the level of center of the head of the femur. The hinges are fixed at 10 to 15 degree abducted. Initially, 2 mm destruction was given for arthrodiastasis. Further destruction was given gradually later on if needed. Keeping the frame for next 6 to 8 weeks with meticulous follow-up at 7th day, 15th day, 13th day, 42nd day, and so on. Case illustration. Jayed, 8 years, right femoral head Perthes herring type group C. After operation, you can see here, and removal of the fixator and applied fixed striker, the abducted position, and before operation and after operation. This picture was taken after 6 months of operation. Junaid, 7 years, left femoral head Perthes herring type group C. After fixation and about 6 months, there's 8 months of the removal of fixator. An Ashraful 8 years male, LCPD, left femoral head, herring type BC2, and you can see, and before operation and after operation, and real 6 years, LCPD, left femoral head, herring type BC1, and after operation, and 6 months after the removal of the fixator. And this is Fatima, 13 years, LCPD, left femoral head, herring type C, group C. And after fixation, and removal of the fixator, applying the abduction base or Scottish Rite base, and before operation and after operation. And you can see here, and Raj, 6 years male, LCPD, left femoral head, herring type PC3. You can see here. And this is 4 months, 6 months after the removal of the fixator. And right one is about 1 year after the removal of the fixator. And you can see about 1 year after the removal of the fixator. And now the patient.
Please make it short. The time is over.
Result, 2 cases of LCPD got the excellent result. 3 cases of LCPD radiologically shows improving the head congruency, but clinically hip movement still limited. 1 case radiologically shows not satisfactory improvement of the head, but hip movement gradually regained without pain. Conclusion, minimally invasive procedure, arthrodiastasis with neck head tunneling by Elizarov method is an effective procedure for the treatment of LCPD. It maintains the anatomy of the hip joint. Arthrodiastasis by Elizarov method provides a way to bypass loading forces of the joint, which negates the harmful effect of stress on articular surface, thereby promoting healing of the areas of the necrosis. Limitation, very small sample. Follow-up period is very short. Sometimes patient cannot get the proper physiotherapy. The stool bar classification was not done. And thank you.
Thank you, Dr. Nazmullah Shetu, for your nice presentation. Now, I would like to put your questions to Dr. Shetu, the audience, please. Any question? Dr. Kaisur Rabbi?
Assalamu alaikum. Yes, sir. So what is the minimum age and what is the maximum age you can do arthrodiastasis in case of LCPD?
Excuse me, again, I will question again.
সবচেয়ে কম বয়স কতটুকু হতে পারে আর সবচেয়ে বেশি বয়স কতটুকু?
Actually, paper shows that at the age of below the age of 6 years, the result is very good, excellent result. After the 8 years or 9 years, the result is unpredictable. Paper shows that.
Yeah, I know that. Paper shows that the results are unpredictable. But
my sample is very short, and I'm doing only 1 year, so I cannot show the ultimate result.
Thank you very much.
Thank you.
Another question?
Yeah. Dr. Shetu, how much is the acceptance? Did you have any measure that patient has accepted this device? You know, putting a Elizarov in leg or thigh is one thing, and putting in hip is another thing.
Actually, after the application of this fixator, pain was elevated, so patient acceptance is very good.
Pain elevated or?
Elevated.
Oh,
elevated.
One more thing. did you face any stiffness of hip or anything like that after the
Yes.
removal?
After removal of fixator, there is some sort of stiffness. So physiotherapy must.
Thank you.
Thank you.
Thank you, Setu, for
Yes,
nice
sir.
presentation. I have one question that how much restriction force do you apply during your arthrodiastasis? And if it is so that you are not measuring the pressure inside the joint or any other means, if we put only the K wires and keep the patient on traction, will it work?
Oh, thank you, sir. Good question. Actually, we always see the under the C-arm, we should not break the Shenton's line. You should not break the Shenton's line. We keep the joint arthrodiastasis to maintain the to keeping the Shenton's line intact. No, no. Distortion is the main key points here for the head regeneration. It is the main factor. So, paper shows that 2 to 5 millimeter maximum diastasis can be applied. Not more than that. 5 millimeter.
I think question is over.
Thank you, Dr. Setu,
Okay, thank you.
for your brilliant presentation. Our next speaker is Dr. Sandeep Patwardhan. His topic is 10 commandments for tense nailing. I want to say something about Sandeep Patwardhan. He is one of the renowned pediatric orthopedic surgeon in the subcontinent. Now he is Secretary of Paediatric Orthopaedic Society of India. He is very good friend of Bangladesh Paediatric Orthopaedic Society. Really, he helped us many times. He many times visited our Bangladesh and delivered his lecture, teaching us, his nursing us to build this Paediatric Orthopaedic Society. We are grateful to him. Let's give that.
Thank you very much, sir.
For your help.
Can you hear me? Hello, can you hear me?
Are you?
Hello, I would like to thank the POSB for this great opportunity. And I'm so happy to be here with all of you. And I listened to the earlier two presentations, and I'm really amazed at the quality of work that is happening in Bangladesh. Congratulations, Dr. Sarwar and the entire POSB team for bringing Bangladesh to the forefront of pediatric orthopedics. With these few words, let me dedicate my talk today to Professor Samirul Islam. And in his memory, let me talk to you about the 10 commandments for tense femur. The first commandment that I want you to remember is thou shalt understand the concept of tense. Very often we see people, even in our country, who talk about rush pins and Ender's nails. And they say that we have been using these for years. These are elastic nails. So how are they different from tense? What you should understand about tense is that it is like a safety pin. It's an elastic stability with a good purchase at the metaphysis in the proximal region and the distal region, which is pre-tensioned, right? So you have two pre-bent elastic nails which are inserted from either side of the metaphysis. Something like this. You bend the nail with some principles, and when you put it in the canal, it will deform the canal in one direction. And then you use another symmetrically bent nail of the same diameter, put it from the opposite side. It will tend to recoil and deform the bone in the opposite direction. And coupled with each other, now these two will give you an excellent 6-point fixation with a tensile stability, which allows you immediate mobilization without any external immobilization. So this is 6-point fixation. The second commandment you should know is thou shalt choose the correct indication. So don't use it for wrong indications and say that the nails failed. What are the indications? Mid-diaphyseal fractures, fractures which are transverse or short oblique with minimal comminution. children between 5 years to 12 years, and who are not weighing more than 50 kilograms. Heavy children, adolescent children, it is not a suitable implant. The classical indication is something like this: 8-year-old child with a mid-diaphyseal transverse fracture, where you will get excellent stability. Relative indications like subtrochanteric, supracondylar, and comminuted fractures, the elastic nails can be used with modifications. The third commandment is, thou shalt understand the nail and follow the bending principles. Don't do what feels to your mind. The nail size is the first. If you pass too thinner nails, they're easy to pass but will not give stability. If you use too thick a nail, they're difficult to negotiate. So what is ideal? You must use a nail which will occupy 40% of the narrowest canal diameter at the isthmus. And 2 nails are used, so it will occupy 80% of the canal. So the rule is between 60% to 80% of canal fill of the inner diameter. So measure the inner canal diameter at isthmus and multiply it by 0.4, right? That will give you the exact diameter of nail that you must use. Keep the nail on the patient's thigh and take a Siam shoot and make sure that 2 nails are occupying 60 to 80% of the canal fill. Commonly, the femur will need 3 to 4 millimeter, tibia takes 2.5 to 3, and forearm upper limb is not more than 3 millimeters. Second principle is always use same size nail because you need balanced forces. If you use one nail which is thick and one nail which is thin, you will end up causing an imbalance of forces, and this will not work like an elastic nailing system. Third point is, where will you bend the nail? The bending of the nail is in surgeon's hand, and the apex of the bend has to be exactly at the fracture. So with the Siam shoot, make sure that your nail is at the apex of the fracture, and then bend it symmetrically on either side, such that the height of your bend is 3 times the inner diameter. So this is how the nail should be bent, not what is given down, otherwise it will cause translation. And the amount of bend is 3 times the inner diameter. Okay. So the apex or the height of your bend should be 3x or 3 times the inner diameter. And the choice of nail should be 0.4 into diameter, which means 40% of the canal fill. So this is the amount of the bend that you must have. And you must do symmetrical bending so that both nails are now matching each other, right? If you do not do smooth bending or bend at the ends, then you might have a deformity and elastic stability may not be adequate. So uniform bending is important. Fourth principle is, thou shalt make an adequate entry point. So don't make small incisions and try to be percutaneous, because when you try to remove the nails, the nail will need a larger incision to remove, and the purpose of cosmetic surgery is lost. So make an adequate entry to begin with. Medial entry should be 2 finger breadths proximal to the physeal plate, and with an adequately large awl, make the entry points. Make sure that you pass your nails to the fracture and don't advance one nail. If you rotate the nail wrongly, you will irritate the suprapatellar pouch, and if you leave the nail too long, you will irritate the ligaments. So make sure that your entry is far away from the physis, far away from the suprapatellar fold of synovium, and it does not irritate any ligaments. If you are too close like this, you may end up causing growth-related issues and physeal arrest. Fifth principle, thou shalt advance the nail correctly. So when you enter along the curvature of the nail and then turn it around so that it faces the medullary canal, and then gently advance both the nails. Use 2 chucks, do not hammer, avoid excessive rotation. If you keep on rotating, you end up creating what is known as spiraling or snaking. So this spiraling or snaking, which is multiple, you will get crisscrossing, which takes away the elastic stability. So don't keep on rotating the nail 180 degrees all the time. Just advance it by gentle movements. Sixth commandment, use proper reduction maneuvers. You can use a fracture table if you have one, or you can use an ordinary fracture radiolucent table with traction manually. Make sure that the fracture is distracted when you advance your nail. And You can use the F tool, which is available with the set, so that you can achieve reduction with your other hand for translational correction. You can use the pins as joysticks or reduction tools so that the nails are aligned when you are passing the nails. You can use the hockey stick bend of the nail as a reduction tool so that you can get the fragments well aligned. Seventh commandment, thou shalt maintain length at all times. So length unstable fractures are not good for doing these procedures. So example, where you have spiral fracture or you have a third fragment which is large and comminuted. Now these thin nails were passed and you can see that it has collapsed and the nails have backed out. In such situations, you will have shortening, nail protrusion, knee irritation and complications. To avoid these, you can use end caps if they are available. So with these appropriately sized end caps, you can prevent back out of the nail. It is like locking the nail at the metaphysis and prevent it from backing out, especially when the fracture configuration is comminuted or long spiral. Or we use a trick which I have popularized now in many cases. You use a mini fixate
Recording in progress.
Thank you. Any question? Thank you, Sandeep, for
Thank
your
you, sir.
nice presentation. And
Thank you, sir. Thank you, sir. I'll be back at 3 o'clock. Thank you.
Sandeep Pardwan, for your nice presentation. Now I would like to request Dr. Muhammad A. Arifudjaman. His topic is result of Elizarov external fixation assisted correction of pediatric foot deformity in secondary causes. Please, Dr. Arif.
Thank you, everyone. At first, I want to express my gratitude to all the freedom fighters. For them, we are here. We are deliberating our space in this Liberation War Museum Hall, and also express my gratitude to POSB for their tremendous job arranging this situation, this nice conference in COVID situation. And everybody know that I am from Kustia Medical College, and I am doing Elizarov. And today my topic is result of Elizarov external fixator assisted correction of pediatric foot deformity, especially the secondary cases. So far, you know that the neglected clubfoot is decreasing in prevalence for last few years. Everybody know that a successful clubfoot program is the main cause, but the secondary causes, the neuropathic causes, the hemangioma, intermuscular hemangioma, and the pediatrics, very difficult post-traumatic foot deformity causes are still need to care for some extra type of technique like Elizarov. And this is my disclosure. And my team is Dr. G. Moni, Dr. Malik, Dr. Rashid Hassan Rani, Saidul Islam, and Ali Haider. And foot is a masterpiece of engineering. And if you learn the anatomy of foot and see the anatomy of the foot, every bones are three-dimensionally rotated. The metatarsal heads are not in same position in all the cross-section. The base are not same position. Sometimes the metatarsal length is different in different direction. So during Elizarov fixation, you have to acquire all the things and put the wire safely. And this is today the presentation is on pediatric age group. So I do X-ray, normal X-ray, just mentioning how the epiphysis and the length of the metatarsal that are enhanced in different manner. And even in deformed foot, all the things are more deformed and more disorganized. So all the things should keep in mind before putting the wires. You all know that is a safe zone or the wire direction in Elizarov fixation. And when you put the metatarsal wire, it may not purchase all the wires because I have mentioned the different position of the metatarsal. And another normal parameter and center of rotation. You note that center of rotation of the ankle is just below the two tip of malleolus. And another is what is the natural relationship of the normal foot with different angles and parameters. Usually the calcaneum is 28-degree angulated calcaneal axis with the horizontal plane. And also talus is 25-degree angulated. And foot and metatarsal angulation is around 120-degree. This should be restored during the correction of the foot. And what are the changes and associated pathology in deformed foot? The bony changes, abnormal talus shade, soft tissue construction contracture is there, fibrosis, and also there is the issue of LLD. Skin changes, adaptive changes is there, and associated hip-knee dynamics. The hip-knee dynamics is very important in case of correction of CP foot deformity. What should we label the syndromic foot, like the neuromuscular causes, the cerebral palsy, the hereditary sensory motor neuropathy, spina bifida, the arthrogryposis multiplex congenita, and the vascular causes, the calcified hemangioma. I have several cases of this series, and I want to share my cases with you. And cerebral palsy, I already told that there is true equinus and false equinus. I do not want to elaborate this. the hip knee ankle link in CP. This should be keep in mind before the correction of the deformity. And this is a, I want to just skip, this is a CP patient and with a foot equinus deformity. And it is a very close view of the deformity. And in neuropathic cases, you may need some secondary procedure. Today, I am focused only just elisera of correction of the foot deformity. The secondary procedure are planned on later on. And this is my frame. And every time when we correct the deformity, there is some chance of clawing of the toes. I usually put this type of soft padded papers or paper padded elastic things to keep the foot aligned all the time, and especially at the night time. And the distraction rod placement in equinus deformity is very important. Every time in elisera of correction, you may dislocate the talus anteriorly. So never dislocate the talus. Sometimes you may need to check the X-rays, and you have to put the distraction rod in elisera ring obliquely for prevention of these causes. And this is my happy patient in our ward. And just after the putting the ring, and after correction, gradually correction, and patient before the removal and after removal, the plaster cast is given, and patient have the full correction of the foot. And this is the patient walking like that. The video is distorted, and patient with some orthotic device. In our situation, orthotic device is very difficult to get. We put some modification from the local cobbler, and the orientation of the photo is, I am sorry for that. And this is also, we check the knee and hip. I already told you that the patient link joint, knee and hip consideration is very important for doing this type of correction. And this is another patient with CP correction, and this patient have the clawing, and I put the metatarsal wire for correcting the clawing. And also we put the locally made orthosis with a very long anterior sole, because anterior sole, long anterior sole will increase the lever arm and will overcome some degree of the weakness in the anterior muscle after the correction. And hemangioma, I want to go very fast. Why hemangioma cause the contracture? Abnormal blood flow, thrombus formation, phlebothrombolitis, the rupture of the hemangioma, recurrent hemorrhage, and secondary hemorrhage, fibrous proliferation, calcification, muscle contraction is there. It is very rare case. Hardly I do not find any supportive journals or articles. I got a book from the China, the Quincy, the greatest elisera surgeon in China. He have some series of hemangioma intermuscular in origin and involving lower limb, causing the foot and knee deformity. And this is the patient I compare with the normal X-ray, and this is other for excluding the fibrous ossification. And this is the close view. And patient, I have put the also the knee frame and also the leg frame. And the patient in frame and gradual correction is there. It is very difficult because in hemangioma, you know, the chance of bleeding and other complications is there. So you have to do very minimally and fine thin wires. And this is the X-ray of correction and patient after correction. And this patient have LLD. I have to address the LLD later on. And this is how corrected foot is there. I already mentioned that different planes and different parameter by which the correction should be encountered. I want to escape these videos. And hereditary motor neuron disease, I have treated 3 patients of hereditary motor neuron disease. You know that hereditary motor neuron disease can be 1 to 7 types. And usually it is before deformity appears before 10, and sometimes the lifelong. The muscle atrophy, higher foot, hemato, foot deformity, and foot scoliosis are there. And this is the patient with equinovarus deformity, with weakness in the muscles and clawing of the foot. And this is a close view. And there is a neuropathic ulcer in this patient. And we applied the elisera and gradual correction. And this patient also needs some secondary procedures for stabilize the foot later on. And you see that the neuropathic ulcer almost healed after the removal of the ring. And this is also the video. This patient works with a very good freedom. And the child with severe contracture cases. It is 21 years old childhood deformity cases we operated at the 25 years of age, and this is correction, full correction is there. The deformity is not a problem with Elizarov. Even you do not need any type of osteotomy during the correction. Only the distraction you can get all the type of correction. And this is Elizarov birthday gift from my kids for Elizarov pictures and the tree with Elizarov. Thank you all. And this is a very colorful ward in pediatrics orthopedics ward in Kustia. Thank you all.
Thank you, Dr. Arif, for his nice presentation. Dr. Arif is working. We are from Dhaka, but he's doing well with this Elizarov thing. Again, thank you, thank you. But if anybody have any question, I shall request that you will ask the question to Dr. Arif, and please know your answer by personal communication because our time is limited. Thank you.
Thank you, sir.
Thank you, Dr. Arif. Now I would like to request Dr. Kim. Please connect.
Professor Kim has sent us his recorded lecture from the South Korea. So we are going to play it right now. Once the recorded video has been totally completed by his playing, then he will join us. He has already joined us in Zoom for the question answer session. So please let us see the video presentation first, and then we will go for the question answer session for Professor Kim. Thank you.
Good morning, everybody. I'm Hyunwoo Kim from Seven Children's Hospital, Seoul, South Korea. And today I'm going to talking about the timing and types of surgery for residual hip dysplasia, which is very difficult issues. So first of all, you need to the so-called loyal patient. Is the parent responding appropriately according to your treatment philosophy? And also, how do you judge a satisfactory hip development? And lastly, when do you intervene again? When failure to improve or when actual deterioration of the hip development. This is a natural history of the DDH, a case. Even though the patient has a good acetabular and femoral side development, after 7 years later, at the age of 15, we have no subluxation but still dysplasia or poor acetabular coverage. We do not know the fate of this hip in the long run. So this is a case of the DDH at the time of, after 2 years, 7 years later, I have done the Solto innominate osteotomy for treat the residual dysplasia. At the follow-up, we can see the good acetabular remodeling and the femoral side is almost normal. But we do not know the fate of this hip in the long run because as I previously shown before, so we need to follow up the patient constantly. But we can have these cases. I have done open action at the age of 1 year, and this is 2 years and 5 years after the open action. We can see the acetabular dysplasia. But I just continue to follow up the patient without doing anything surgery. And we can see beautifully developed acetabular. For example, at the time of this age, for example, in 3 years, 8 years after the open action, many of you have like to do some surgery for femoral side or acetabular surgery, but we do not know that. This is a 5 years old DDH, which is a neglected cases. I have done shortening and variegation osteotomy and femoral side osteotomy, but still we have acetabular dysplasia probably caused by resorption of the bone graft. And finally, the right side good, the left side is no subluxation, but the poor acetabular coverage. Probably he had a high instance of osteoarthritis in the long run. So you will be facing the patients with these problems. With the femoral and acetabular dysplasia, and some patients have avascular necrosis or some called the proximal femoral growth disturbance, and also the patient with limb length discrepancy with or without ABN and overgrowth. But unfortunately, we can see actually encounter cases with concomitant all of these problems. That's the problem. So this is a case of DDH. This one has open reduction, and he has a larger femoral head, probably due to increased vascularity abdominal reduction, but still acetabular dysplasia. So I have done a procedure to treat acetabular dysplasia, but this patient have the overgrowth of the femoral side. So this is 9 years of age. We should do something for the limb length discrepancy in the field of the poor acetabular development, even at the time of the acetabular remodeling. This is a case of DDH completed by limb length discrepancy and dysplasia. So this is follow-up, 2 years follow-up, and 3 and 2 years follow-up study. So you can see the femoral occiput nucleus is small, probably due to avascular necrosis of the femoral head. And if you continue to follow up the patient, he has a sign of femoral side poor development, which causes coxavalvular deformity. Also, you can see the poor teardrop figure development. And if you follow the patient, and you can see the teardrop widening and increased coxavalvular deformity and shortening of the femur. So frankly speaking, I should have done something at this stage. But I hesitated to do a femoral side osteotomy or combined acetabular procedure. Anyway, this patient, the poor acetabular development, probably we need to do a valgus osteotomy plus acetabular procedure at the time. So how to follow up the patient? So frankly speaking, the procedure, the type and technique of procedure performed depends on the surgeon's preference. But the decision making is very important as to when to do surgery, often a bigger issue as to what to do. So we need to back to the basic principle DDH, the generality in terms of treatment goals in DDH, which include concave shape of the acetabulum requires presence of a spherical femoral head, and also the acetabulum has a potential for development for many years after reduction. But the bottom line is the hip should be reduced and the full range of motion should be maintained. Only at this time you can anticipate acetabular remodeling and femoral side remodeling. So this is a case of DDH and crow reduction. And you cannot see any femoral side abnormality, and you can see the slowly decreasing acetabular index over time. This is perfect hip. This is a case of open reduction, and there's 1 and 9 years after surgery. You can see the larger femoral head because of the open reduction, but no subluxation, Schwanter's line intact, but the acetabular dysplasia. If you follow the patient, you can see some increase in acetabular index. You can see a second occipital center here, and now it's very good. So even though at this time you may consider as the procedure, but we have no femoral side dysplasia and we only acetabular side dysplasia. So at the time the patient is with full range of motion and spherical femoral head. So I just waited up. So this is another case of DDH treated open reduction. This is 3 years, 5 years later, the only open reduction. You can see the larger femoral head, but the spherical and still acetabular dysplasia. I decided to wait more. No avascular necrosis, and dysplasia is a little bit remodeled. And finally, at the age of 13 and 10 years age, the femoral head is good and almost perfect normal hip. But we do have a poor stability even after open induction. This is a case of the acetabulum dysplasia. This patient has a poor range of motion, especially adductor tightness. So I continue to teach the parent to the adductor stretching exercise. The acetabular, we have still acetabulum dysplasia. But even after continued follow-up, I cannot see the acetabular remodeling, satisfactory remodeling. And finally, the patient has a subluxated hip. The shunter's line disrupted. Acetabular side, no change. So we should do something because poor range of motion. So we cannot anticipate good acetabulum remodeling in the face of poor range of motion hip and subluxation. So we should do something for this patient. Further, in the older children, we can see many patients of femoral dysplasia in addition to acetabulum dysplasia. This includes increased anteversion, avascular necrosis of the femoral head, and coxa valga and coxa vara. As you know, we have a growth plate. This is a femoral head. We have a growth plate here. The growth plate is composed of the greater trochanter and femoral head. Also, we have a growth plate in the femoral neck side here. So if you have a hip damage in the central side, this results in true coxa vara. If you had a lateral growth disturbance, you can see the subcapital coxa vara. If you had a medial side growth plate injury, you can see this kind of deformity. So this is a typical case of proximal femoral growth disturbance, especially lateral side. This lateral side growth disturbance is the most common type of ABN after treatment of DDH. So intuitively, you may think that this femoral head causes a continued coxa valga deformity and acetabular dysplasia and subluxation. But we have many cases of type 2 ABN lateral growth disturbance with good acetabular remodeling. So we have two types of acetabular remodeling even after lateral growth disturbance. Back in 22 years ago, when I was in our study, I studied the growth disturbance, the effect on the acetabular remodeling. The conclusion was it is important to monitor acetabular development after reduction rather than search for radiography changes of the physical rest, which is very difficult to detect in younger children. This is a case of a good acetabular remodeling even after type 2 ABN. So you can see the reversed growth plate inclination, but no subluxation, acetabular dysplasia. I continue to grow because of femoral head shape is just normal, even with subcapital coxa valga, and he has a good range of motion. I continue to grow and continue to follow up the patient. Finally, after 13 years of age, at the time of the growth plate closure, we have almost normal hip. But this is a case of the lateral growth disturbance causes a true subcapital coxa valga. So we have coxa valga deformity, and so I have done the epiphyseal disc and salt intermittent osteotomy. So finally has a very good hip development. And lastly, I want to show the cases with shortness of the affected femur or overgrowth of the affected femur. So this is a case of open reduction. I have done the open reduction plus femoral derotation shortening osteotomy. So we can see the good developing acetabulum. The patient has a limb length discrepancy and general valgum, and I'm concerned about development of the residual hip dysplasia caused by this femoral side deformity. So I have done the first the correction of joint volume, and then I have done the limbless stress occupancy correction. So finally, he has a good range of motion. So the timing and type of surgery for the raised hip dysplasia is a very difficult issue, but I hope that my lecture gives you a more clear insight for your future treatment philosophy. Thank you very much.
Thank you, sir, for your nice and brilliant presentation. Now, just any question to sir, please? Bobby, Dr. Bobby.
Good afternoon, sir. Since I last met you, sir. So, from your lecture, I just have the impression that as long as joint space and a good range of motion and space is maintained, so even if it is looking that it is going to subluxed anytime, I should wait. Is that correct, sir?
I'm sorry, I cannot hear you. So please loudly.
So my first question is, from your lecture, I have the impression that as long as the joint range of motion is okay and the patient is painless, even if the X-ray looks that acetabular covering is not good enough, I should wait.
But the bottom line is you should have a good range of motion, no adductor tightness, and also you have no femoral side deformity caused by ABN or proximal femoral growth disturbance. But I don't think you need to just wait over the age of 8. So I would say age of 8 is a kind of watershed age. After age of 8, I don't think you can anticipate good acetabulum remodeling, even with a good range of motion and no femoral side deformity. So I would recommend you wait until the age of 8. Also, after age of before the age of 8, you can see the a little bit simpler acetabulum procedure, just like a DEGA. DEGA is a very simple procedure, but if you do have a acetabular dysplasia or subluxation at the that age, you should do more complicated procedure. So the bottom line is good range of motion, no femoral side deformity, but you should wait until the age of 8.
Okay, thank you, sir.
That is my recommendation.
And my second question is, if I see in my successive follow-ups that after the DDH operation, even after 4, 5, or 6 years of age, if I see that early radiological and clinical signs of avascular necrosis is taking place, what can I do to prevent that avascular necrosis? Like for an adult, we have some options like core decompression or something like that. Can we do them those procedures for a operated DDH patient who are developing AVN after 4 or 5 years of age?
So I would say the avascular necrosis after treatment of DDH is a little bit different from that of leg prosthesis. So DDH, the AVN after DDH is sequelae of the damage during the very early stage of disease. For example, one year after the treatment. Okay, so but the problem is many of the AVN, especially the type 2 AVN lateral phalangeal growth arrest will be evident very late period. So that's the problem. So, and that's why I continue to stress that you need to follow the patient at the age of 8. But I don't think you can apply the prosthesis principle to the DDH with AVN. You understand me? Yeah.
Question, and thank you to Kim for your answer.
Thank you, Professor Kim. So, we do up to 20 to 30 degree of varus for the need of stability. Is that sometimes you might have to do more varus to have a stable reduced hip? Highest amount of varus you do.
I think that the textbook wise, okay. So many of the surgeons to recommend femoral varus osteotomy before the age of 4, because we have 3 or 4 years to the age of 8. So I don't think the degree of varus angle at the time of varus osteotomy it is not a big issue. But the priority is to you want to shoot the completely concentrically reduce the hip. Don't rely on the varus angle. Okay, so if you do too much varus, and also the patient will complicate with the AVN at the later stage, the varus deformity will not resolve. Okay, so the problem is AVN after DDH is many AVN type of DDH will be apparent, will appear very late stage of the disease. That's the problem. So, frankly speaking, you may see, you remember, I present one case of coxa valga deformity and AVN. I didn't do the varus osteotomy because I do not know. I don't feel confident about the reversing of neck shaft angle even after varus osteotomy. So that's my perspective. That's my experience.
I have one question.
Okay.
Thank you, Professor Kim, for your nice presentation. In your presentation, you have shown like if the head is not covered, like 40% outside the acetabulum, and you have waited for a few moments whether the acetabular dysplasia is gonna change itself to cover the femoral head. Do we have any plan like this percent of femoral head outside acetabulum and we should go for early acetabuloplasty? Like if the head is almost 40% outside acetabulum, we should go for acetabuloplasty, and we should not wait in this patient for 8 years for planning any operative procedures.
I'm very sorry. I don't clearly understand your question. Your question will be probably if we have some early stage of more centralization femoral head, we can anticipate as a remodeling. That's your question?
My question is, when femoral head is okay, but the acetabulum is there, and what we have seen in your x-rays, like 40% of the femoral head is outside acetabulum. In these cases, do we need to wait, or we should go for early planning like acetabuloplasty, that may be DEGA, or in some other options we have?
Frankly speaking, I think that depends on your preferences. Okay, if you more like the more aggressive to acetabular procedure, you can do that. But the bottom line is when you think of the procedure, any kind of recurrent procedure, if you think the both sides, if you hesitate to the femoral side procedure or acetabulum procedure, but the real goal is acetabular development. So I strongly recommend you better do acetabular procedure, Ortho, DEGA, triple, any kind of that. I don't like the femoral side procedure. Femoral side procedure I think, is unpredictable.
Thank you, Rabbi.
Thank you very much.
Thank you, Professor Kim. You are our great friend because many times you have visited to Bangladesh and you are helping us to train our surgeons also. We are grateful to you. Thank you very much.
Thank you.
Now I request Professor R.R. Koiri sir to start his interactive session. Professor R.R. Koiri is President of Bangladesh Orthopaedic Society. He is renowned orthopedic surgeon of Bangladesh, and he was the president of Bangladesh Orthopaedic Society. He was ex-professor of NITOR. He is our mentor. We should congratulate Professor R.R. Koiri.
Thank you for the introduction. I have 12 minutes time to discuss few cases. early management of the congenital deficient limb in infant or children. This is a very serious problem. I will present some of the cases, only the early management, because when a parents come with their child, deformed limb or very short limb, proximal femoral deficiency or deformity in the leg with short limb, the first question they ask whether my child will be able to walk in future and how we manage early. I'll discuss some of the cases. This is the child with fibular hemimelia. सुना जाता है ना? अच्छा, point of fibular hemimelia with short limb. And can you think that this child can walk? If you make him walking, he will improve his psychology, and not only the child's psychology, parent's psychology as well. So at this stage, no operation can be done before 6-7 years of age, and you cannot make the limb normal. But with the help and braces, you can make the child walk. You can see this is the child walking with the brace. And child is happy, parents are also happy. Next case. This is another child with short limb. This is the brace I have designed by the Brooklyn Center. This brace has got two parts. Here this part I wanted to use as weight bearing. Even if it is deformed, this part of weight bearing is very helpful because this has got the proprioceptive sensation, and this helps in growing the femur as well as the hip and everything. So this is the modified brace with lengthening. And this is the end of this first part, and this is the extension of the second part. And these childs always wear a pajama, you know. And I have patients of 6-7 years of age going to school with these braces. She is a bit hesitant, but she can walk. আমি প্রশ্ন দিব 4-5টা প্রেজেন্ট করে নিই তারপরে। This is another child with fibular hemimelia with about 8-inch short limb. Usually the parents told me that the child, even in the morning, when they wake up from the bed, they get their brace and wear themselves, and they come out from the bed. This is another one. This is a bit modified. Every brace is a bit modified. This is a bit modification that this is not a very deep foot, so very small area for the foot, and then extension. video taking was not planned, it was just in the outpatient chamber. So taken by the mobile. But I want to show that these childs are very happy to work and their childhood development of their psychological development as well. This is another case, fibular hemimelia with short limb. This is the brace. And we have taken X-ray of the hip. Many of the cases, the development of the hip and the limb is improved after weight bearing. This is proximal femoral deficiency. There is absent of the proximal third of the femoral head, neck, as well as up to the mid-sept. Now, do you think that this child will walk with brace? Practically no hip, but still the child can walk. So these are the all about this congenital limb shortening with braces. Any questions about these 3, 4, 5 cases? No, upper limb not.
It's the lower limb.
It's a lower limb.
Lower limb.
These are the lower limb cases. The idea of developing this brace is that if the child starts walking, they have parents become also happy. Yes, my child is walking now, at least with the brace. And after, what is the next plan? Next plan is after 7, 8 years of age. Say after 7 or 8 years of age, I will try to lengthen. I will try to lengthen the limb, and I may go for the even some cases of the distal part amputation with the limb. But if you wait for the 7, 8 years without walking, the child morally will not develop as well. And many of my these children, I have only 5, 6 cases I have shown. But by now, within last 5 years, I have many cases, more than about 16, 17. And many of them are going to school with পায়জামা পরে যায়, এমনকি ক্লাসমেটরা বুঝেও না যে তার পা নাই, and they are very happy. So this is the way you can initially manage the cases.
Could you please, sir, excellent braces are there. So, sir, I want to ask you, do you have any, do you change the brace according to the age, development, according to the development of the child? You need to change the brace, or you have some mechanism to increase the length of the brace?
Oh, the same brace, they usually repair and increase the length. The not that costly. This is a Brack Limb Center. I have arranged with them. They reconstruct. Every 6 months, they have to change. And they increases the distal part, they remove and increase the length. They repair. Sometimes the child grows, it does not fit actually, so you have to change the brace. But it is not very costly. 2-3 হাজার টাকার মধ্যে হয়ে যায়, maximum. This is. Can I continue more? How much time I have?
One question, sir.
Thank you, sir, for your presentation. Regarding the time of surgery, you have mentioned that before 6 years, surgery cannot be done in this patient. But we have done 1 year and at the age of 1 year and 1.5 year, and it blended the bones nicely.
Yes. Actually, Elizabeth surgeons can do excellent job, but I am not an Elizabeth surgeon. I got your point. You can do it 1 year, but before walking, you can lengthen the limb. But if you are an expert Elizabeth surgeon, yes, you can do that. But I have got no experience.
I think sir has shown that there's the alternative way how to rehab the patient and how to go for it.
Next, because you have to say at 6-7 years of age, I am very comfortable to doing the other things. Even the anesthesia is not that easy for a big operation. Anesthesia is not easy.
And maintenance of Elizabeth also.
Thank you for a nice presentation. Sir, in case of proximal femoral deficiency, how many days, by how many years you will continue this type of device?
How many years? I have to follow up the case and see the growth of the proximal part. Proximally, there is deficient, already. Yes, there will be a pseudoarthrosis and this child will link probably the leg length equalization in any way. Probably we will not be able to reconstruct the hip. The last child I saw. So these are rare cases, but to me, as far as I go through the literature, you cannot reconstruct the femoral head. Probably we have to go for the any type of prosthesis or total hip replacement like that later on.
Okay. Thank you, sir. Thank you, sir, for your nice presentation and deliberation.
Can I continue for 2-3 more cases? Do you have the time? So can I 5 minutes more?
Sir.
So this is the case of chronic osteomyelitis with gap non-union of the radius. Because this can be managed, yes, there are many ways of management as this one. You can go for the Elizabeth, but the simpler way I usually do is to resect the part and give a fibula graft. I can show you the result. That's enough. This is the fibular graft with a simple KVR fixation. KVR has gone through the growth plate, but a simple 1.5 mm or 2 mm KVR will not disturb the growth plate. And fibula is almost incorporated. And it takes about 6 months time to regenerate fully. This is another case. 3 years old girl with history of acute osteomyelitis. This is at 2 months. This is at 4 months. This is at 6 months. And this is after 1 year. So this is the sequelae of osteomyelitis. This is 1 month post-op by a grass nail and a fibular graft. This is the fibula. At 3 months, I thought the fibula is absorbed. It is not, but I continued a simple brace. And at 5 months, the fibula is regenerating. At 8 months, it is more regenerating. And at 2 years post-op. Still, now we are 26 months, we have removed this last nail by a simple incision by local anesthetic. So this is the follow-up reconstruction at 26 months by a fibular graft. This is another case of on the previous one was the radius was shortened, it is the ulna is shortened. Ulna, this is the post-osteomyelitic. This is the ulnar reconstruction by a tubular graft. At 5 months, it is incorporated. At 6 months, I have removed the nail. The radial head was long enough and dislocated previously. So we have to lengthen again. And lengthening, I usually do by uniaxial fixator. By osteotomy here, and I will lengthen the ulna later on. This is the regeneration of the fibula. Fibula, if you take the fibula subperiosteally, it will totally regenerate. So the parents sometimes ask whether the fibula will be there or not. So this is the result. This is my favorite subject, Spontasia. The way I do is I bend a plate. Here only you can see that only 20-degree bend of the plate, open reduction by a separate approach for the radial head, no reconstruction of the annular ligament. I usually take the advantage of the capsule, tighten the capsule and the annular ligament, remnant of the annular ligament. I always do the open reduction by a separate approach and ulnar osteotomy by a separate approach. And ulnar osteotomy and temporary fixation. This transcapitular fixation is usually now I keep it for 2 weeks till the removal of the stitch, and at 2 weeks I keep it subcutaneously. Initially I thought that the subcutaneous will be chance of infection, but many cases, in case of supracondylar fracture, we keep the K-wire outside. So I keep the transcapitular K-wire for 2 weeks, immobilize it by cast, and at 2 weeks remove the stitches, remove the K-wire and put the cast for another 2 weeks. At 4 weeks, keep movement. This is the result. At 6 months, this radial head is intact, and you will remove the implant within 1 year time, because the bone grows and it becomes difficult to remove. This are the other cases. This is a congenital, the valgus deformity. Here you can take the advantage of growth modulation. This is the growth modulation.
Congenital spinal deformity, where a section of a vertebra fails to develop, typically resulting in a wedge shape. The condition can cause the spine to become unbalanced and develop a curve, resulting in scoliosis or kyphosis. The severity of the hemivertebra is dependent on its effect on the spine alignment. This is the case. You just see, presented with the history of back pain, radiation, both lower limbs, gait disturbance, and knee extension was only 4/5. You just see. With this, দেখানো যাচ্ছে না বোধহয়, with this pointer. Scoliotic deformity was 40 degree and kyphotic deformity was 25 degree. You just see. Single congenital anomaly causes 2 deformities in a sagittal plane and in a coronal plane as well. How can we reach the diagnosis? Again, I'd like to do some MRI. You just see how much rotation of the spine, how much rotation at the level of the lumbar too. And this is the CT scan. You just see on the opposite side, there is no pedicle, nothing else, no bodies as well. With the complaints and investigations, it's a case of kyphoscoliosis due to congenital hemivertebrae. Now, what are the surgical options for correcting this deformity? Surgical, there are many modalities, that is vertebral column resection or shortening by the hemivertebral resection, that is vertebral VCR, and resection and reconstruction of the hemivertebra by the iliac crest graft or mesh case with bone graft. I did VCR of L2. This is the perioperative view. And after correction, you just see only 4 degrees scoliosis is remaining and kyphosis is totally corrected and patient is on 10-degree lordosis, which is the normal lordosis at the L2 level. The alignment is perfect for that patient. Now I am showing another case of spondylolisthesis. This is the pediatric spondylolisthesis. You know, dysplastic variant. Investigate by the history, examination, and many things, and investigation as well. And this is the X-rays preoperative, and this is dynamic X-rays, MRI, that all you know. With the findings and investigation, it's a case of dysplastic variety of spondylolisthesis with neurology. Now, what can be the surgical option? I do prefer posterior lumbar interbody fusion for this, and after surgery, the patient is now okay. It's a prospective study started from 10 to 21. That is, it is 12 years time. With this source, in a group A, there is scoliosis on 35. In a group B, VCR vertebral column resection was 15. In group C, dysplastic spondylolisthesis, the number of patients is 50. I will not go details about the results, but there are some complications. 10 patients presented with screw breakage after 12 months. 7 patients presented with rod breakage after 3 months, and which was corrected by revision surgery. 9 patients had superficial wound infection, which was treated by proper antibiotics. I will not go details about discussion because running shortage of time. I cannot compare with other studies as well. I have also. Conclusion, with all the consequences of the addressing the pediatric spinal deformity correction, it can be concluded that it's very challenging to treat. But if we assess all the things very meticulously and do surgery very cautiously by the skilled surgical team with adequate OT facilities, this challenge can be overcome very nicely to give healthy and prosperous life for the affected side. Thank you all for patient sharing.
Dr. Anwar Islam.
Very good presentation.
Dr. Anwar Islam is the Secretary of Bangladesh Spine Society. He is doing very nice work in the pediatric spine. We congratulate him. Next presenter.
Dr. Monurujjaman, please come to the dais. Pediatric musculoskeletal ultrasound, a practical perspective.
Dr. Monurujjaman will be the last presenter of this session, and another presenter is Dr. Qazi Shahidul Alam Bobby. He will present his presentation in the next session, please, because it is the lunch period. We have to curtail this time. Thank you very much. Monurujjaman, you have to present it within 8 minutes.
Thank you, sir. Honorable Chairperson, my distinguished delegates, national and foreign country, and my teachers and colleagues. Assalamu alaikum. It's my privilege and honor to be here, especially in this special events, the 8th Paediatric Orthopaedic Society of Bangladesh. Now, actually, the muscular ultrasound is we are using and very fond of doing our daily practice. Someone called the 6th finger or the 3rd eye or the pen or stethoscope of the clinical examinations. And the easier muscular ultrasound is evidence-based, and definitely we actually already used to practice in the developed country last about 20 to 25 years. But in our country, we are practicing last about 7 or 8 years. And many articles and research are already published and going on. And in comparison to MRI, actually it also equivalent and sometimes maybe it's superior to the MRI in terms of vascularity and the dynamic assessment. And the MRI also superior to the ultrasound in respect of the erosions and also the bone edema or the internal structure of the bone. So the other imaging regarding the in comparison to X-ray, MS ultrasound also shows the soft tissue echo, especially we can delineate with low cost and also without having any contraindication like claustrophobia in MRI and high resolution, etc. Now, so why we do actually the 19 regions, actually the neuromusculars and USPRM recommendations for the physiotherapist practice, and also it including the residency training. Now, introduction to MSK ultrasound, it actually not in miniature of adult muscular ultrasound. It's actually monitored the changes of the developing the muscular ultrasound in the in the child, ability to visualize the highly cartilage profile to epiphysis and enthesitis, and primary imaging modalities in infants with actually DDAs. And spectrums, actually the cartilage, the synovium, the muscles, tendons, ligaments, joints, bones, peripheral nerves, and vessels. Now the cartilage, we actually, this is very important in case of child because this cartilage actually marches with the tendon attachment, and also the echo looks like the same, anechoic, the hypoechoic, and also the apophysis and epiphysis also merge with the cartilage. So for the beginners, may sometimes confuse with the joint fluid or versa. And also in the vascularity, before the 10 years, the vascularity actually more increase in case of child. So don't think as an increased vascularity like this. The bone erosion is also important in juvenile idiopathic arthritis because especially in the early RA or the different juvenile arthritis, that may shows the erosions even in the normal X-ray. So it will help in predicting the diagnosis, also the predicting the prognosis. It also the different scoring system also. And the synovitis is also another important issues to detect the sign of the joint assessment. The synovitis include the synovial fluid collection with the synovial hypertrophy. So when the hypertrophy synovial with increased vascularity, we actually call the synovitis. It's also have 3 grading system, 1, 2, 3. And you see this is a synovium. This is a hypoechoic and non-compressible, and there's actually within the joints. And you see the increased vascularity. The enthesitis, where the tendon, ligaments, and the fascia and the joint capsule inserts into the bone. And the 2 types, the dense fibrous and the fibrocartilage attachment of the tendons or ligaments. And it's also important to diagnose in the juvenile idiopathic arthritis, especially enthesitis related SPA. And you see the vascularity also, especially the peritendinous, the vascularity is also normal below the 10 to 13 years child. And tendinosis also we found in the increased swelling of the tendon, especially during the playing field or after the injury in the sports field. And in muscle also some neuromuscular disorder and the myopathy also special finding we found some hyperechoic changes in the muscle, also some fat replacement in the muscle, and also some increased number of perimycial septa. The nerves also we can seen by the high resolution using the ultrasonogram by seeing the honeycomb appearance of the nerves. You see the honeycomb appearance, and also there is a perineural sheaths and also the inner structure. And in case of neuropathy, we found there is a swelling, like you see the HMSN, and also the entrapment neuropathy. Also, you can see the swelling of the nerves before the entrapment, and also we can see the sequelae. And also we have intervention also help to detect using the ultrasound. And EMG using the UMG, the ultrasound sensitivity also increased up to the 98% in case of to diagnose the entrapment neuropathy. Now the DDS actually you are also practicing, and also the many discussion I already run by different speaker today's in sessions. The 2 to 6 per 1,000 live births and the autolines and Barlow's test actually confirmed. And in X-ray there are different imaging and lines, but it actually helpful not in the very early stage. So the ultrasound actually very much effective, especially after 2 weeks to 8 weeks. And the American Academy of Orthopaedics and the American Academy of Pediatrics and also American Institute of Ultrasound in Medicine, they recommend actually this muscle ultrasound. And in Europe they use the graft method, and in the USA they use the Herx method. The graft method actually the hip flexor, the hip flexor. The graft method actually in Europe we use the static position by in the lateral decubitus position, and we can see the gluteus medius minimus and the acetabulum labrum and the fibrocartilaginous. You see the fibrocartilaginous labrum and the bony rim. And when DDS is actually the subluxed or the dysplastic hip, it actually goes upwards, and there is a alpha angle. We actually you see we actually measure the alpha angle and the beta angle. This alpha actually also measure here. This alpha angle actually the reduced during when the head is actually upwards. The beta angle is increased in DDS. And initially the subluxed hip actually you also can diagnose in the early stage without DDH. And we can also follow up by giving the pelvic harness. You already practiced this in especially pediatric orthopedic. You see the follow-up assessment of the image ultrasound very much help whether it's actually the corrected or the prognostic helping. You see that within 12 weeks it is actually corrected. This subluxed hip actually corrected in the normal position. Here is the triradiate cartilage already actually near to there is a femoral head. There is an anossified center. This you see this acetabulum. The promontory actually become normal.
1 minute left, please, Kamujam.
Okay, sir. So this is another the Osgood-Schlatter disease. You see, there is early stage when there is a X-ray is normal. With the early stages, Osgood-Schlatter can also diagnose in the post-traumatic knee injury, and some scenario you see in case of ultrasound, we see the dermis, substance tissues, fat, muscles, and the conjoint tendons. And you see these moral level relations in the adductor thigh. This is a mycelia also begins in post-traumatic hip, and this is the foreign body. You see these are in the foot. This is actually this is a hemangioma, and there's a clearly seen the artery and the venous flow. You see this is the case of the tibialis anterior rupture with the herniation into the subcutaneous fat. These are also the sternocleidomastoid muscles. There is a fibromatosis coli. This is a septic hip, and you increase the collections in the anterior recess. This is another the fibular subperiosteal abscess in osteomyelitis, early osteomyelitis. This is also the early leak eviction in the toxic myositis in the adductor thigh. There is another scenario of there is a knee arthritis in JIA, and there is also the malformations, arterial malformations here. And there is also some tumors. There is a neurofibroma. There is a dermis tumor. So we can also delineate by seeing the different patterns of vascularity, the covering basal tissues. We can recommend the further imaging and the testing. So in summary, note the unique feature of pediatric development. The cartilage decreases with advancing age, and the Doppler may be the normal in growing children. Less than 1 millimeter is not considered bone erosions. Synovitis incompetent to synovial fluid clearly delineated. Differentiate enthesitis and the tendinosis, and muscle decrease with usually echogenic. And the pediatric ultrasonogram is the primary diagnostic tool for DDH and used to monitor development changes in children, and can detect the subclinical changes structurally. Used to monitor the effectively of therapeutic interventions. Can be used side by side other modalities, MRI, CT, and EMG. So we are actually using some sonogy interventions, and also some neotechnology, and also ultrasound guided PRP or the defense. It's my training in the Taiwan. And also I grateful to the Professor Jagir sir in the medicine. So he also helped to practice ultrasound. So it's a privilege for me in Dhaka Medical College. The ultrasound machine also installed it. Here we are also practicing both adult and pediatrics childhood. Thank you very much. Thank you, sir.
Thank you, Moniruzzaman. Dr. Moniruzzaman is Associate Professor of Physical Medicine. He's working in Dhaka Medical College. I have seen him. He's working in pain management, musculoskeletal ultrasonography, and also in the PRP management and stem cell therapy. He's multifunctional, multidirectional work he's going on. He's doing well. Thank you for coming us. And we have got the information that in orthopedic surgery, there is role of ultrasound except this MRI, X-ray, CT scan. Thank you very much for coming with us. আমি একটা জিনিস বলতে চাই, আমরা সবাই জানি আসলে যে কোনো অনুষ্ঠান হলে দেখা যায় যে প্রধান শিল্পী যিনি থাকেন ওনাকে সবার শেষে দেওয়া হয়, আর প্রথম বাচ্চা শিল্পীদেরকে দিয়ে শুরু করা হয়। আমাদের এই অনুষ্ঠানও কিন্তু আমরা সেভাবে সাজিয়েছি। আপনারা লাস্ট সেশনটা মিস করবেন না। আমাদের লাস্ট সেশনে আমাদের প্রধান শিল্পী মানে আমাদের হেভিওয়েট শিল্পী যারা সবচেয়ে ভালো স্যাররা আছেন তাদের প্রেজেন্টেশন আছে। তাই দয়া করে আশা করি আপনারা সবাই এরপরের সেশনটাই জয়েন করবেন। ওখানে তরল নাগদা আছে, সঞ্জীব পাটবর্ধন আছে, প্রামাল নায়ক আছে, আমাদের আর কয়েরি স্যার আছে এবং আমাদের সেক্রেটারি সারোয়ার ইবনে সালাম আছে। সুতরাং ওইটা হবে খুবই একটা ভালো সেশন, দয়া করে সবাই অ্যাটেন্ড করবেন।
ওখানে ডক্টর ববির আমাদের প্রেজেন্টেশনটা আমরা শহীদুল আলম ববি, আমি তার কাছে সরি ফিল করছি যে আসলে এই সেশনটা আমাদের এখন আমরা লাঞ্চে চলে যাব, আমরা ওই সেশনে এটা আমরা ববির কাছ থেকে আমরা চেয়ে নিচ্ছি। ববির প্রেজেন্টেশন ভেরি গুড, ইজ এ গুড স্পিকার এবং আমি জানি তার প্রেজেন্টেশন খুব ভালো হবে। তো সবাইকে অনুরোধ, আমরা এখন সকলে লাঞ্চে সবার কাছে অনুরোধ, আমরা সকলে 3টার সময় জাস্ট আমাদের পরবর্তী সেশন 3টা, সবাই একটু অনেকে আগে চলে গিয়েছে, আমরা জাস্ট গিয়ে 3টে চলে আসবো,
আমাদের
সেশন শুরু হবে।
পেপারও আছে ওইটাতে, সুতরাং আমরা সবাই অ্যাটেন্ড শুনবো আশা করি।
ডক্টর দীপক ওটা আছে কে কে?
ওখানে আছে ডক্টর
সৈয়দ আহমেদ,
সাইদ ভাই, ডক্টর সাইদ আহমেদ এবং ডক্টর কামরুজ্জামান। থ্যাংক ইউ ভেরি মাচ। Hey, hello, Dr. Naik, sir. Are you there? Sir, can you hear us?
Yeah, I can hear you well.
Okay. Okay. Can you talk little more?
Sorry?
Sir, can you talk little more? We are going to check your voice and audio.
Okay. Yeah. Am I audible now?
Yeah, you're audible now.
Okay. So you want me to share my presentation and check?
Yeah, please. Could you share your presentation right now?
Can you see that?
Yeah, we can see you.
Okay.
Thank you. So,
okay,
lunch break at 3 p.m. Right now in Bangladesh, it is 2:37 right now.
Yeah. Okay.
And we are on break till 3 p.m.
Okay. So you want me to start at what time?
We want to start at 3 after 25 minutes.
Okay. So message me 10 minutes in advance and I'll log in again. Okay.
Okay.
Okay. So Indian time, you want me to be there at it is 2:08 now. So I'll join again at 2:38 after 30 minutes. Okay.
2:38.
2:38 India time. Okay. Okay. Fine. See you then.
ব্যাকগ্রাউন্ডটা দাও, ব্যাকগ্রাউন্ডটা দাও। হ্যাঁ, দাদা একটু সামনে আসুন দাদা, ওই লাইটটা পড়বে। হ্যাঁ,
So when you have irreducible supracondylar fracture, these are the techniques we use. We use traction, we use translation, and when nothing works, we use what is known as Wilking maneuver. Now, there are times when none of these things work, and then we call it as irreducible supracondylar fracture. And when you have exhausted every trick upon your sleeve, there are four things which will come to your help. One of them is joystick maneuver. The second stick is using a suction tube, very simple suction tube to reduce the supracondylar fracture. The third sort of trick is using intrafocal reduction. And when no other trick works, you can use an open reduction for these cases. So I'm going to show you these through four cases very quickly. So first thing is joystick reduction. What is joystick reduction? In joystick reduction, as I have shown here, you enter a pin in the distal fragment, use it to maneuver the distal fragment as you would maneuver in a gaming zone, and then pass the wire. So this is a typical fracture which will require a joystick reduction. Now on AP and lateral, this fracture seems to be a normal type 3 supracondylar fracture. But when you try to reduce it, this is what happens. When you flex it, you can see that the distal fragment goes in flexion. And this is a problem. This is a fracture which is different. It is not type 3 fracture. If you can see on a lateral view, there is also a rotational instability, which also makes reducing this fracture very, very difficult. So this is now classified as type 4 supracondylar fracture, which is unstable in flexion as well as extension. And it indicates large amount of soft tissue involvement. So what we do in these cases is insert a K-wire into the distal fragment in extension. Put it in the direction of the distal fragment. And then rather than flexing the elbow, you flex the joystick and get the reduction. You can use this to translate. You can use this to rotate. You can use this joystick to cause angulation changes. You can pass even 2 joysticks. It's up to you. And then once the joystick is passed, the same joystick is passed on to get a temporary reduction. And then you can pass a few more wires to stabilize this fracture. Know this technique because it will come to your use in a difficult case. The second technique I'm going to describe is use of a suction tube to suck hematoma and stabilize proximal fragment. So what you do with the suction tube is make a small anterior nick, suck out all the hematoma, and then once you suck out the hematoma, the tension in the supracondylar area becomes little less, and then it becomes easy to then give traction to the distal fragment and push the proximal fragment posteriorly in order to get reduction. And once you get a reduction, you hold it and then pass a K-wire to fix it in a closed manner. So this was a pink pulseless hand, a child with a pink pulseless hand. You can see that there is a ecchymosis near the anterior crease of the elbow joint. And also you see the medial spike is very, very prominent. So this is the patient which is very difficult to reduce. All the signs, when you have all the three present together, it's very difficult and you have to be ready for an open reduction. And massive swelling, oblique fracture pattern, and occluded vessels, which made the reduction very difficult. So what we do in this patient is use this method, which has been described from Korea. And Dr. Kelly has been part of this method. Indian pediatric, what you do is make a small nick, suck out all the hematoma, and using that suction tip, proximal fragment is pushed distally. You also use a joystick maneuver here. I am using 2 joysticks plus a suction tip here. So all the sticks in my tricks I am using, and then you reduce it, get rotational alignment, get alignment on AP, and then you pass multiple K-wires in a divergent fashion to stabilize that fracture. So this is difficult to reduce. It indicates a severe soft tissue injury, and it takes a longer time to get range of movements. So these are not the patient which will get good range of movement in 2 to 3 weeks or 2 to 3 months. They may take up to 5 to 6 months to get good range of elbow movements because of the associated soft tissue injury. The third technique I'm going to describe is known as intrafocal reduction. And what you do is use a curved artery forceps. So this is a curved hemostat which you put into the fracture site and then use that to reduce the fracture. So this was a 10-year-old child with 2-week-old supracondylar fracture. And, it had a small abrasion, and it all indicated that this was a difficult reduction because it was an old fracture and a difficult fracture. So what we did in this child was used an artery forceps and put it through the fracture site and levered it. So you turn around the artery forceps now 180 degrees and lever so that the fracture gets reduced. And once you hold the reduction, then you pass a K-wire to stabilize that fracture. So this is actually seeing this procedure under image intensifier, my hemostat going into the fracture site and then turning it around 180 degrees. I found this to be much easier than using just a K-wire or any straight instrument. A curved instrument makes it easier for the anterior spike to be reduced well, and then it really levers and causes an intrafocal reduction. I'm also using one more stick here. If you notice, I am using a stick proximally. So I'm using a K-wire here, proximally here, to control the rotations. So, multiple sticks can be used to cause rotational alignment and translation in patients with irreducible supracondylar fracture. So this was the reduction, fixation, and then multiple fixations to reduce it. Now, when none of this works, always you have to be ready for open reduction. So this is a child who came after 3 days, a supracondylar fracture, swollen elbow, and a medial spike. Now, this child was referred from outside Bombay, had a pink pulseless hand and anterior interosseous nerve palsy. So when you have a vessel injury with a nerve injury, you have to realize that both of them could be involved, and one should not try a reduction, close reduction in these patients. So in this patient, what we did is tried an open reduction through anteromedial approach, exactly where the spike was situated. So when we opened, immediately we could see the spike which was poking through the subcutaneous tissue, and the nerve and the vessel both were entrapped in the fracture site. So if I tried the previous 3 maneuvers in this patient, I would have ended up damaging the brachial artery and the median nerve. And it was good that we opened this fracture and then fixed in a closed manner. And then what is important in these kind of patients is to do a fasciotomy, because you don't want to cause compartment syndrome in the fracture which are open reduced. So this is the post-op result. And this patient also took a little more time to get range of movements. They don't get range of movement by 3 to 4 months. They will take 7, 8 or 9 months to get good range of movements. So, in terms of what Dalai Lama said, it means in terms of wisdom and inner strength is often that of greatest difficulty. So when you have simple supracondylar fracture, it does not enhance your wisdom. It doesn't enhance your strength. It does not enhance your skills. So you must pray to God that, God, please send us a difficult supracondylar fracture once in a while so that our skills can be enhanced and we can use these different tricks with the sticks to reduce this fracture. So thank you very much again to POSB for inviting all of us here and making us a part of this memorable conference. Thank you very much.
Have you any question? It's now open for question.
Sir.
Yeah, Samar, yeah, thank you. Yes, I can hear, I can see you, yes.
For close reduction, how many days old patient you would go for close reduction? Is there any limit? Say, I won't go beyond 7 days, 5 days, 10 days, whatever. Days, whatever.
Yeah. Sarwar, this question is similar to how many days quarantine after COVID infection. Say anything similar to that. You should go by mobility and not the duration. If supracondylar fracture is mobile, you can attempt a reduction even after 10 days. But if supracondylar fracture is healed, it's showing callus, there is no mobility, it's better to leave it alone and then attempt osteotomy if there is a deformity at a later date. But in many cases, supracondylar fracture, it is possible to get a good sort of a reduction even on day 5, day 7, and in this case which I've shown on day 10, if there is mobility.
Thank you.
What will be the diameter of the K-wire for doing the reduction?
So, okay, so I'll tell you. For doing the reduction, I use 2 millimeter K-wire. 1.5 is too thin, 2.5 is too thick. Again, it depends on the age of the patient. In older children, I may use 2.5 or 3. In younger children, I use 2. Now, one more trick sort of I'm going to share is when I fix the supracondylar fracture, I use different size wires for medial and lateral fixation, because then on the lateral view, you can differentiate, which wire is what. Otherwise, it leads to a lot of confusion when you take a lateral view. So it's good to have different size wires to be put in the supracondylar fracture for fixation. And for reduction, I use 2 or 2.5 size K wires. Suction tip is the small suction tip which we use for pediatric hand cases. And the hemostat is a mosquito forceps, the smallest one which is available, I use.
I have a question, sir. Sir, thank you, sir, for your nice informative presentation and knowledge. You are a very good teacher, all of us. And my question is that, what is your tips during seeing the lateral view in perioperative situation?
So you want your question is, how do you take a good lateral view, or what do you see?
In
Can you just make it a little more clear? I'm not able to.
Yes, sir. You got right. What is your tips regarding the seeing lateral view in?
Okay. So I'll tell you 2 tips how to take a lateral view. There are 2 ways to take a lateral view. One is moving your elbow, but when you move the elbow, you lose the reduction. So a better way to take a lateral view is to move the C-arm and not the arm. That's the first tip. And second tip, the proximal and distal diameter should be same. The second tip is that there should be no spike in the distal fragment or proximal fragment. That's the second tip. And the third tip for assessing the lateral thing is, you see an hourglass shape in the distal humerus. There is a, like how you have teardrop in the acetabulum, you have hourglass shape which is there in the distal humerus. And that hourglass shape should be maintained. And if that hourglass line is maintained, you know that your rotations are correct. So these are the 3 tips I use on the X-ray to determine if my rotation is correct or not.
So sometimes we do a external rotation of the shoulder joint to see the lateral view of the supracondylar fracture. What is your comments about that, sir?
Yes. Yeah. So when you externally rotate, the problem is the only pin you can put is medial pin. When you externally rotate. So when you put a medial pin with external rotation with elbow inflection, there is increased risk of injury to the ulnar nerve. So I generally tend to avoid that. So, rather than moving the shoulder or arm, I move the C-arm, rotate the C-arm and try to see the lateral view. It is a little tricky, but you have to train your radiology technicians to take a very good AP and lateral. And I make them practice 3 times. Once before the patient is scrubbed and draped, so that I know that during the surgery, there'll be no hassle. Rather than getting irritated at the time of fixing, it is better to teach your radio technicians before the surgery starts.
Thank you, sir.
Thank you. I hope that answers your queries. Thank you.
We usually do 2 lateral K-wire. Do you prefer 1 lateral K-wire and 1 medial K-wire? The prospect is more stable.
Yes. Those are sort of ability pins, or you put 2 lateral and 1 medial pin in all these patients. This is not my protocol for a normal type 3 supracondylar fracture, where reduction is easy. I will put 2 lateral pins. But in these difficult ones, I put either 3 lateral pins or 2 lateral and 1 medial pin. Yeah, thank you.
Thank you, sir.
Okay. I'll wait for Premal's lecture. Thank you.
Now, Alakata approach to lateral condyle non-idiot in children. Dr. Premal Naik. Right.
Yeah. Thank you, Chairman, sir, for your warm welcome. May I start now? Am I audible? Am I audible now?
Yes.
Okay. So I have chosen two relatively less discussed topic. One is a lateral condyle non-union and then radial club hand. So before we move on to anything, let us recapitulate some definitions according to the latest book of Rockwood and Green. A delayed presentation of lateral condyle is one in which you see the fracture between 3 and 12 weeks of injury. Another definition which is very similar is a definition of delayed union, where you find that the fracture fragments are in satisfactory position, but there is no proper union at the metaphyseal fragment. And when the same duration takes place more than 12 weeks, we call that non-union. There, the fragment may be displaced or may not be displaced, but if you do not have any union by 12 weeks, we call it non-union. Causes of non-union worldwide are basically of two types. More so in India and Bangladesh, which are developing countries, that patient factor is more common because there's a lack of awareness. Many patients go to bone setter treatment or a local native bandage, and there are lack of medical facilities, so they tend to go and seek for local treatment. It has been very well known that even in Western countries, there are many doctors who fail to diagnose the severity of the fracture, and then they do not give proper treatment, and hence there is a delayed presentation of lateral condyle and lateral condyle non-union in fractures of lateral condyles. Lack of proper follow-up protocol, in which the displacement of the lateral condyle fragment is also one of the major cause of delayed presentation. There are no definite types of non-union, but looking at my collection of non-union cases, I could identify 5 different types of non-union. The first is delayed presentation. We can call this as delayed union also, in which the fragments are in place and they present to us between 3 to 12 weeks. Non-union are the similar cases which present to us after 12 weeks. Non-union, which is there, but it is in unacceptable position. So when the lateral condyle fragment is totally displaced and rotated, and the child comes to you after 4 weeks, you will call this as a non-union in unacceptable position. Sometimes the children miss the bus, where they come with gross deformity, but the growth plates are open. And sometimes they wait all the way till they become adult and they come to us mainly for ulnar nerve symptoms or lateral side laxity. So we are going to define these 5 types. We are going to see what are the symptoms and how do we tackle that. Let's look at the first type of delayed presentation or delayed union situation. Here the fracture site would be painful, still tender, swelling in the elbow may be present, and movements are always restricted because of the pain. This 7-year male fell from a bicycle, had an olecranon and lateral condyle fracture, who was initially treated by orthopedic surgeon in back slab and found that 2 weeks later the fracture was displacing and was referred to me. If you look at, there's a significant swelling because it's a dual elbow injury, and the treatment here can be simple. One can treat this with percutaneous K-wiring and you can use cutaneous screw fixation, whatever is your choice. This is a 6 months follow-up of the same child with excellent functional result and good union of the fracture. The technique of percutaneous screw fixation is there on YouTube, on my YouTube channel. You can search Premal Naik on YouTube and be able to see this technique there. Another situation which is type 2 non-union in an acceptable position. Here the fracture site is generally not tender because it is generally more than 3 months. Elbow is not swollen now. Movements may be full or may be restricted. If you see the child at around 4 months, it will be restricted. But if you see the same child at 8 months, you will have good movements. Movements are painless in the available range and deformity may be present. It may be varus it may be valgus. It can be either of that. Let's look at this example of 2-year female who presented to me with 4-month-old injury. I had advised them surgery. But they refused to come to me and came back after 6 months. You can see here that in this child, there is no valgus, but there is a varus. So for this, when I referred to literature was saying that you can do in situ fixation, or you can do peg grafting, or you can do open reduction internal fixation. But I had used some other technique, which was later published with this restriction movement. What I did was, I did pass a percutaneous K-wire then did an arthrograft. Another supplementary K-wire was fixed, and the first K-wire was then replaced with 4mm CC screw. This is 2 months follow-up of the child. This is 6 months follow-up of the child with excellent resolution of movement. This is at the time of removal of implant where full function was achieved. There are 2 papers which have talked about percutaneous screw placement in delayed presentation and delayed union till date. Taral, me and Sandeep are compiling our cases. We have a case study of about 17 cases which we are going to present soon with our results of percutaneous screw fixation, avoiding a major surgery for a simpler non-union of lateral condyle fracture. The third non-union is non-union in an acceptable position where percutaneous techniques will not be possible. Here the fracture stripe won't be tender, elbow is generally quiet, movements are restricted because lateral condyle is generally flipped or rotated. Movements which are in the available range are painless, and deformities generally may be present, may not be, but it is by and large valgus. Let's look at an example of this 8-year male who presented to me in 2014. Had a significant restriction of movement on presentation. Child was treated with anterior approach by open reduction and internal fixation. This is post-operative at 6 weeks. This is 6 months follow-up. There is a significant flexion deformity. Flexion is not improving. And if you look at the union is good, but unfortunately, the child has developed avascular necrosis. This is 8 months follow-up. The movements did not improve at 1 year. Child was lost to follow-up, but presently came back to me 4 years later with full function. The X-ray still showed that there was an avascular necrosis. So avascular necrosis with an anterior approach is not described, but it is possible. Now, Taral and I both have moved to posterior approach. Posterior approach has been traditionally blamed for vascular disruption, but if you are careful in dissection, you can get beautiful view of the lateral condyle fragment from posterior side. You can align the articular surface much better, and with judicial dissection, you can get away without any avascular necrosis. This 5-year male had this type of fracture, presented to me 4 months later. The child had significant restriction of movement, but there is a valgus and movements are painless. Again, the technique of posterolateral approach is uploaded on my YouTube channel. You can see there. This is a 2-month follow-up of the child. This is at the stage of wire removal, and this is 7 months follow-up where there's a beautiful restoration of movement and no pain. Type 4 non-union is a non-union with valgus deformity in a growing child. Here the fracture site is not tender, movements may not be restricted, they are painless, and there is always cubitus valgus. This may be the amount of valgus deformity. There will be some flexion deformity, but further flexion is generally restored, and this is the amount of deformity and the cause of deformity. So let's see how can we proceed in such circumstances. What we need is, first is a clearance of metaphyseal site. This is the site which needs to be cleared. And we need to arrive at what is called by Dr. Roy as functional alignment or a functional reduction. So first, we separate the distal fragment and do drilling at the metaphyseal site on either side. Once the metaphyseal site is freshened, it is temporarily fixed with 2 K-wires, one along the articular side and one along the metaphyseal side. The metaphyseal side wire is then replaced with screw, and then the deformity is corrected by doing a horizontal osteotomy. Angulation and translation is then done. Once the translation is done, the fixation is done with a plating above the screw exit. Bone graft is then added at the site of fracture site. This is the final fixation. This is the union at both the site, and this is the functional result at 6 months. Type 5 non-union, in which significant valgus deformity, you generally see this person in very late maturity because they have either valgus instability or more commonly have ulnar nerve palsy. Here the cubitus valgus is always present. Ulnar neuropathy or valgus instability may be present. Movements may or may not be restricted, but they are painless. This 24-year female presented to me with cubitus valgus. She had a full range of movement, but had a valgus instability pain. And in addition to that, she had terminal restriction of extension on the left side, and she had Fromet sign positive. She was treated with ulnar nerve transposition as well as in situ fixation of the lateral condyle, and she is now relieved of symptoms. So whenever you want to get your lateral condyle non-union things right, what is a very, very important thing is one must treat small loss of movement for the lateral stability and to prevent progressive valgus. One must catch children early so that we can get away with simple percutaneous fixation, because when we are dissecting a lot, we end up in fibrosis and losing elbow movements. Whenever you have a delayed union presenting after a long time, don't try to be anatomical, try to be functional. Fix the piece in such a position where you get full range of movement per-operatively. The lesser dissection gives better results. Please remember the patients don't look at x-rays. What they need is stable elbow, good movements, and minimal or no deformity. And I'm hopeful that after going through this presentation, you will never end like this. This is a child who presented to an orthopedic surgeon who, in zeal of getting excellent reduction, did significant dissection, and this child ended up with myositis ossificans with zero movement at the elbow. Thank you very much again for your invitation and patient listening.
Please ask for question. Is there any question?
Yes, sir. Good afternoon, Premal.
Good afternoon.
When there is valgus and ulnar nerve palsy,
yes,
valgus supracondylar correction, the orthopedically gradually the ulnar nerve will be okay, or you want to transposition the ulnar nerve?
No. So whenever I am doing a cubitus valgus correction, I do not transfer ulnar nerve. But when I am doing an in situ fixation, where I am not correcting valgus, as I showed the last case, in which she did not want a major surgery. So what we did was just ulnar nerve transposition and in situ fixation to avoid lateral instability. She was not much bothered about deformity. So I think it is very important that when there is a long-standing non-union, we must discuss with the patients what do they want. Do they want a major surgery or they just want alleviation of symptoms? So only ulnar nerve transposition can also be done. But since you are dissecting there, it may be a good idea to just locally scrape the area, put 2 screws so that in future valgus instability does not come in that way. Since you are just at that point of time operating a person.
Any other question?
Thank you, sir, for your nice presentation. Sir,
Thank
I
you.
patient who have the malunion at the lateral condyle, and patient came to me 3 to 4 months later, and I saw that there is a gap between the trochlea and capitulum, but the capitulum is connected to the lateral border of the humerus, and there is a gap. In radiology, there is the alignment is more or less good regarding the radial head. What should we do in this situation, sir? When there is malunion?
So that's what I said, that since 2013, we have studied, we have compiled our cases in which we have done percutaneous screw fixation. So what you can do is the metaphyseal part of the fragment you can catch with a 4 millimeter cannulated cancellous screw. Give them plaster for about 2 to 3 weeks. And gradually, these children will months. This technique has given us almost 100% success. After 8 to 9 months, that is, it is said that in one of the papers that after 255 days, the chances of union become less. But that period is not very critical. If the alignment is good, if the movements are good, it has portion of metaphyseal bone, which is a wonderful trick in which you will be doing this percutaneously, and you will get away with a wonderful result in a small scar.
Thank you, sir. I have a question. So sometimes after operative period, after a long time, we are not getting any amount of elbow flexion or extension in a post-op patient. How long should we wait in pediatric age group for getting that movement? Or should we intervene by any physiotherapy or just patient education?
So if you are confident on your dissection and tissue handling, your movements will come back unless there is some complication or post-operative infection. So if I have done the job and if I am confident, because I've seen that sometimes there is a sudden improvement in movement. Sudden improvement starts after about 8, 9, 10, 1 year. So there are many patients who did not, and I don't have a great experience and great results after doing elbow arthrolysis. So examination under anesthesia, stretching, GA cast is something what I do if I don't get extension. And I have generally resorted to more than functional range of movement has been achieved in almost all cases.
Thank you, sir. Thank you very much. Any other question?
So I think I need to go.
Sir, I have one question. You have mentioned that it is better to go through the posterior approach. What approach during your posterior exposure? What muscle plane do you use to save the posterior blood supply to the distal fragment, lateral condyle? Thank you.
So when we do lateral approach, what we do is we just lift the triceps from the metaphyseal site, and we take direct entry in the area or the fracture area, so that there is no handling of a fragment. And if you have to handle the fragment, you can use a joystick rather than cutting any soft tissue over the fragment. What we do is we just use a joystick and align the fragment and fix the fragment. That is how you can get away without doing any soft tissue damage to the lateral condylar fragment. You can watch the video which is uploaded. For lack of time, I couldn't show you detailed dissection technique of posterolateral approach. Second presentation as well. So I'm taking you away from the pediatric trauma and take you to even rarer condition, which is radial club hand. Why I got interested in this condition was that when I became a pediatric orthopedic surgeon and came to Ahmedabad and met plastic surgeons to come and help me with these cases, all of them refused. They were not much interested in doing this. So I embarked on the journey of treating these difficult cases. The radial club hand or radial hemimelia, or what is also known as congenital radial deficiency, is one of the most common congenital longitudinal deficiency with slight male preponderance, and it comes with multiple syndromes. So you must know at least these 4 syndromes, and you must diagnose these syndromes before you embark on any treatment, because say like Python is any life expectancy is very less, and timely treatment can create wonders. This is the classification which is most widely used. It's by Bain and Clark, where type 1 is a small radius and type 4 is complete absence of radius. There are multiple treatment options. Recently, in a webinar at POSI, we found that only soft tissue release is being tried at few centers in United States. But the most common treatment, what we have learned and what we do is centralization of carpus over ulna. Another slight change in the technique to radialization, and Dror Pele has familiarized us with ulnarization, but it's its own problems and it is not gaining much repute. So centralization being one of the most common treatment, it was first described by Saib, and preservation of distal ulnar physis was first recommended by Leach. Before that, people used to sacrifice distal ulnar physis to variable extent. It was the Bine and Watson who advocated that not make any carpal resection, and therefore they advocated that we must use soft tissue destruction. This is generally performed more commonly by plastic surgeon and hand surgeons. In our country, there are a lot of pediatric orthopedic surgeons who also perform this procedure. So in centralization, it is not only the bony surgery, but the most important thing is tendon transfer. We transfer flexor carpi ulnaris to extensor carpi ulnaris, and also transfer, if available, extensor carpi ulnaris to extensor carpi radialis to extensor carpi ulnaris. There are more and more variations in the technique. There are people who use distraction. There are people who do not use. There are people who use various type of incision, and I'll take you there in a nutshell. I use soft tissue distraction whenever I feel that the carpus cannot be passively put over the ulna easily in my clinical examination. My preference would be, and we have to do very gently, otherwise distal ulnar physial separation is sometimes seen operatively. Multiple incisions are used, straight, curved, Z-plasty, but what I have started preferring is the bilobe flap if I do not do distraction. There are two different types of bilobe flap. One is a dorsal, one is a volar, which is being recently described. The dorsal, which is more common and known by Ivan's name, that's called Ivan's bilobe flap, is one of the most common incision which we use for radial club hand. My old data which I presented about 7 years back, in which I had 22 cases of radial club hand, mainly of type 3 and type 4. And I'll show you what surgical steps we do when I perform centralization with ulnar osteotomy. Jess fixator was used in 8 patients of my 22 patients which we had used. Dorsal A-shape incision was used in cases where distraction was used, and in other cases, Ivan's bilobe dorsal flap was used in 15 extremities. First, what is done is horizontal part, anterior part of incision is taken, median is released in carpal tunnel, and flexor carpi radialis tendon, if present, is harvested. Then on the dorsal side, extensor carpi ulnaris tendon, the first harvested and tagged, and extensor digitorum communis is retracted and the wrist capsule is opened. Once the capsule is opened, ulnar physis is exposed all around, and it is preserved and capsule is separated all around. Then a retrograde K-wire is passed from carpus to the third metacarpal and brought out of the head of the metacarpal and then brought out to the level of the wrist. But then a tract is created in ulna for the wrist K-wire to move further. The K-wire which is passed to create a tract is then removed, and it is replaced by the K-wire which is coming from the third metacarpal. Then it is proceeded to the apex of the ulnar deformity. A small incision is made in ulna subcutaneous. Osteotomy is performed and the same wire is then introduced distally, and the alignment is secured. After this, the wrist capsulorrhaphy is done. Extensor carpi ulnaris is tightened. Flexor carpi ulnaris is transferred to extensor carpi ulnaris. And if flexor carpi radialis or extensor carpi radialis is available, they are also transferred to extensor carpi ulnaris. After closure of bilobe flap, the hand looks somewhat like this. And after follow-up, it looks somewhat like this. Post-operatively, 1.5 months plastering is done. And polycization is done if patients agree after about an interval of 6 to 12 months, I could do in 6 patients of those 22 patients presented. We had about 20 months of follow-up then, and we had a significant reduction of wrist forearm angle as measured like this from preoperative 41 to postoperative 13 with a p-value of 0.0001. We had a significant correction of ulnar bow in both AP and lateral view from 28 to 8 and 24 to 9 with a significant p-values. We had a very good ulnar hypertrophy from 45% to almost 60% with a significant p-values. We had our shares of complication. 2 patients developed marginal skin necrosis, which did not fortunately require any treatment. 2 patients who were lost to follow-up came to me with breakthrough of KOMs. Fortunately, we had a very good clinical results. All had improved digital movements, had improved hand function, and there is a significant improvement in the wrist strength. As you can see, this child is pulling water cane, which weighs about 20 kg. What are the other options? I have recently started experimenting with radialization. Radialization is a very similar option in which instead of putting K-wire in the third metacarpal, we put it in the second metacarpal. Ulnar osteotomy is needed as and when, and radial structures are all transferred to the extensor carpi ulnaris. The only procedure which is not done here is flexor carpi ulnaris transfer to extensor carpi ulnaris. As I mentioned, that ulnarization, though being popularized by Dr. Pele, unfortunately, long-term results are not very good, which were shown by Scott Cousin in our recent POSI webinar, and I have no experience personal with this particular procedure. Another microvascular surgery in which a microvascular metatarsal transfer is done with its blood supply to prevent radial deviation is also done in a very select center, and cases in Europe and America. Unfortunately, I don't have access to this surgical technology, and I have no experience with this technique. Few patients in my longer follow-up have come back to me, and they have requested that their arms were short, and I have resorted to lengthening. Lengthening hemimalias are never easy. You need a lot of cooperation from patients and need a lot of experience. This particular case went off smoothly, and this is the before and after pictures of the child who was very happy without any recurrence of the deformity. Now let me share only 2 examples of this rare condition, one which was the most compliant and one which was the most non-compliant. This 9-month-old child came to me when child was young, child was splinted, and at age of about 9 months came to me for surgery. Child had centralization and ulnar osteotomy like this, and postoperatively at 2 months he had this type of look. I could convince this child for polycization. The polycization was done by one of my friends. I don't do polycization, and this is a 1-year follow-up results of polycization. As you know that most of the children in our countries now start playing with mobile, and when that happens, the parents are really, really very happy. So this is a 1-year follow-up. This is a 4-year follow-up. You can see there is a good function of the thumb. This is child had a good splinting component. You can see that there are multiple bands in his wrist. The thumb is also looking very good, and this is about 6 years follow-up. This is the functional result. He can write something. He can hold the object very well. Small objects are also held very well. This is a 9-year follow-up. This child is not wanting me to lengthen him, but has a good functional result. This is the functional result and wrist movements and thumb movements of the child. You see, this is a beautiful procedure. If you can convince your patients for both centralization and polycization, it's a very rewarding and functionally rewarding and cosmetically rewarding surgery. So sometimes, as in our countries, patients are not very literate. Sometimes you do the surgery, but they may not come to you for follow-up. This 11-month-old was operated in 2010. I had done deletion of floating thumb and centralization with osteotomy, and this is a 2-month post-op. Child got implant removed at about 6 months' time, and he was lost to follow-up. He came back to me for follow-up after 12 years. This is his recent follow-up. He had no splinting and nothing, but fortunately, his deformity has only partly recurred and he has a good functional result. As you can see, this child is using cigarette pinch or a side pinch and has a very beautifully supple wrist and is quite functional with his upper limb. And he has a significant improvement in radiological parameters also. So even if your patient's own splint, centralization gives much better results compared to natural history of the condition. So if you embark on treating a radial club hand, what you need is a team. You need a pediatrician, you need a pediatric anesthetist, you need an orthotist, and of the lot, the most important thing is you need parents. We must discuss the treatment protocol and policization on day one. Unfortunately, in our country, many people feel that we should have 4 fingers and they don't let go 4th finger for thumb. So my policization rate is very less. I always keep a PowerPoint presentation with patient example handy, and that is very, very important in convincing patients for almost any condition. We must investigate them well for all the associated conditions like spine X-rays, 2D echo, abdominal USG. We must be familiar with altered anatomy because half the tendons are absent, mainly the radial ones in this skin. One should be able to handle small tissues. One have some experience of handling these small tissues, and one should preferably use loop. Unfortunately, I have not been able to use, but my experience substitutes for my lack of using loop. Ulnar physis should be considered most sacred, and one should never ever tamper with it. Ulnar osteotomy is used, judicious use gives very good cosmetic results, and I cannot underline that we must have a very, very long-term follow-up. And please, this is a very rewarding surgery. Children will pray you as a god if you do this surgery, but do it only if you have a sufficient training for this condition. With this, I would like to thank again by remembering our last visit at Dhaka with a iFix Express and joyous face, and would love to come back again with friends whenever this pandemic permits. Once again, thank you very much for your kind invitation.
Please.
Thank you, sir, for sharing your cases and give us the experience that you have gained on the long years of your clinical practice. Sir, I have a question. I cannot see this screen. Hello, sir. Can you hear me?
Yes, I can hear you.
That sometimes the radial club hand associated with some default syndromic part, like the TAR Halterom syndrome. What is your data about that patient? That you operated only the sporadic ones, or the associated pathology are related with your patient?
So I have 2 cases of TAR syndrome, but what happens in TAR is the thrombocytopenia generally within 1 year generally disappears. I had only 1 patient in which I had to give platelet substitutes while operating her. I have operated her on both the sides. That case again was done 10 years back, and she is doing really well. But there, TAR syndrome, radial club ends are really, really difficult to manage. So I think you should try your hands on few cases which are simpler, non-syndromic ones, and then move on to the syndromic things.
What is your age limit?
Sorry?
Your age limit, the earliest age when you should go for the centralization.
So I have done at age of about 8 months. A few colleagues in India have done it up to age of 6 months. But I think if you do it about 8 months, 1 year, the results are really good. So I don't think age is a very great criteria. But around 1 year should be it's comfortable for your anesthetist, your own self. IV related issues won't be there, and you will be able to save really smooth.
In your cases, we have seen that what is your opinion about the correcting this type of deformity with external fixator?
See, external fixator is generally for soft tissue distraction. But once you do soft tissue distraction, you have to maintain the alignment by balancing the wrist. See, there are two different things. You cannot correct the deformity by external fixator and retain it, because to retain it, you always need a centralization. So without centralization, Sandeep has some experience where he extensively lengthens and puts a K-wire and keeps that K-wire for a long period. But except him, I have never come across any literature where only deformity correction with external fixator has substituted centralization. So that is not a recommended treatment as per now.
Sir, what is your preferred sequence?
So as I said, if I can passively put the carpus back on ulna without anesthesia easily, I will not do soft tissue distraction. But whenever I have any doubt, I will do a soft tissue distraction, because currently I have now operated more than 50 cases. In last 3 years where I have not used distraction, in 2 cases we had venous problems and I had to undo some correction, let the wrist deviate into radial deviation and save the hand. So all those complications can be avoided with soft tissue distraction.
If in this patient cases, if I got patient with LP, what is the protocol then? So for the
Sorry, I'm not able to. Your volume is a little low. Can you be louder?
If I get any patient with elbow stiffness and radial clav hand, what should the protocol then?
Leave him alone, because radial lack of elbow flexion is substituted by radial deviation. So unless and until you have 90 degree of elbow flexion, centralization is contraindicated.
Thank you, sir. Thank you very much.
Thank you.
So any other question? Thank you, sir, for your excellent presentation.
Thank you.
For the next presenter.
Now it is the time for our national faculty. Renowned pediatric orthopedic surgeon, inviting Professor Tarwari Mesala. For interactive case session. Please.
Group of children also. So if we keep in mind about the appearance of the secondary ossification centers, it will be clear to us. So hereditary multiple exostosis. Sometimes things are very difficult. Like this situation, a 7-year-old girl. We know that around 90% of HME patients have tumors around the knee. But we also know that up to 30 to 60% of the HME patient have forearm deformities. Look at here, the distal ulnar growth and ulna is short. There is radiocapitellar dislocation and it is pushing here. Recently, we got a patient in Dhaka Medical College Hospital. This head came out through the skin. It created so much of pressure that head of radius came out through the skin. There was necrosis of skin. So this particular patient, she had this radiocapitellar dislocation, ulnar bow and ulnar shortening. What could be any resident, anyone, what could be our approach to this patient? I'm asking the residents, anyone from Dhaka Medical College Hospital who has seen this? Farhad, follow. Shamnesh.
Thank you, sir. Here we can do ulnar osteotomy and lengthening the ulna by applying external fixator.
Okay. So there is no consensus that what has to be done, what to be done. We did this, as Dr. Farhad said. We have excised that distal osteochondroma, and we have this X-fix. We all know, very simple thing, very cheap, thing, and we have put a cover through the remaining ulna, and we have done one osteotomy here. So we are gradually doing the lengthening. You can see 0.5 to 1 centimeter a day, depending upon the age, depending upon callus. And we have stopped here, so that we have stopped here, though it has become a little conical, but we have stopped here. And with the X-fix, you can see she was very functional. And after removing the X-fix, yet the caver was still there. We have removed that caver little later. So she had a short forearm, deformed forearm, radiocapitellar dislocation. She doesn't have full pronation and a little lag of extension, of course, but gradually she will be achieving all these things. So this is one more case, can be done anywhere in Bangladesh by one experienced orthopedic surgeon. And it is very rewarding for such a patient. You see the preoperative forearm X-ray and the postoperative forearm X-ray. Six months of age, the baby came to me at the age of 18 months. Dinobandhu Mitro, patient's name. She came, the boy came with these fractures. And you see, these are the fractures he had at the age of 6 months. It was a type 2 osteogenesis imperfecta. Osteogenesis imperfecta is another thing that is very difficult to manage for anyone. But we have some medical management that might help. At this stage, we went for conservative management. Later, after 2 years of age, we started medications. So these are standard protocols: braces, plasters, physical therapy, medications, usually bisphosphonates, surgery, intramedullary nails. So there are first generation, second generation, third generation bisphosphonates. Worldwide, pomidronate, the second generation injectable bisphosphonate is mostly used, but we don't have that drug available in Bangladesh. We use third generation, zoledronic acid, and it is widely used throughout the whole world. So I have seen many patients, they had 30 fractures, 25 fractures, 50 fractures before using zoledronic acid. And after using that, they had no fracture, 1 fracture, 2 fracture, 3 fractures. So we started with zoledronic acid, 0.05 milligram per kg body weight per dose every 4 to 6 monthly. What happened? That fracture was less. So patient was a little better, had a little better life. See that happy child, Dinobandhu, a very happy child, always smiles like that. He was walking with those bent bones. He was still walking with those bent bones. You can see how much bent the femurs are and the left tibia is. So there is always a chance when this much of bent is there that there will be a new fracture. So what we did next, we went for shish kebab surgery. So shish kebab moto kete kete rod dhukai dewa. So we did right femur and left tibia. Left femur is yet to be done. It was also worth doing. You can see, I think he was 7 years or 6 years at that time. He was walking that way. We are still using the braces, and after the left femur, he would be walking better. So these are not difficult cases to be done. At least you can start giving these bisphosphonates. It is available. Zoledronic acid is available from 3 pharmaceuticals, and it's a bit costly, 5,000 or 6,000 vial, but it can be given to 5, 6, 7 children at a time. So we make a group, we bring them and in 5, 6, 10 patients group, we use it. So it becomes easier for them to give. And for few hours, 3, 4 hours, they stay in the hospital as OPD patients. So my take-home message for you that pediatric deformity should be managed as soon as possible. The deformity correction may be individualized. Putting elastic nails through greater trochanter at the age of 6 is not recommended. But at that age, elastic telescopic nail would be better. But we have used telescopic nails. Those are very costly, and most of the telescopic nails doesn't telescope. Costly at the same time that's happening. So we have decided that we need to let the patient work, make his bones strong, and later on we might get better results from these things. So these are something can be done anywhere in Bangladesh, because there are more than 1,000 orthopedic surgeons working in many places. And we are always ready to help you, always ready to, we have a Facebook group, POSB or Paediatric Orthopaedic Society of Bangladesh. Many of you visit there. Many of you are giving your cases there, and you are getting answers from the national faculties and foreign faculties. More than members from more than 50 countries, more than 40 countries are member there. And there are more than 1,400 members in that group. So the Facebook group, POSB or Paediatric Orthopaedic Society of Bangladesh, is there for you. If you put any case, we all answer there. Professor Koiri sir answers, and all of us answers. And Shandip Padwardhan, Taral Nagda, they are also member. Premal Naik, they used to answer there. So thank you very much for the time you have allotted for me. If any last question. So this is the picture taken by me from my rooftop garden. Anyone in any Friday, you can come, have a cup of tea with me. Thank you very much.
Thank you, Professor Sarwari Misalam. Now it's time for foreign faculty. Now, I inviting Professor Dr. Shandip Padwardhan for presenting his case, cerebral palsy medicine.
Hello, can you hear me?
Please, can you,
Professor,
Hello?
can you hear us?
Yeah, I can hear you.
So unmute yourself, sir.
Yeah, I'm unmuted. Can you hear me?
Yeah, we can hear you.
Okay, can you see my screen?
Please share your presentation.
Yeah, can you see me? Hello, can you see the screen?
Please.
Hello? Hello, am I audible?
Hello.
Can you hear me?
Hello, you're audible, sir.
Okay,
Share your
can I
screen.
start? My screen is not
Unmute
visible.
yourself, sir.
Sorry, I'm unmuted. Can you see the screen? Hello. Hello, can you see my
Can you hear us, sir?
Yes, I can hear you. Hello.
I think you are using two microphones.
No, I'm using only one. Are you able to hear me now?
স্যার আমার মনে হয়
Hello. Can you hear me? Hello. Hello, can you hear me? Hello.
Sir.
Can you hear me now?
Yeah, we can hear you. Please start your presentation. And
Can you see screen?
we can't see you.
Hello. I shared the screen. Can you see? Hello. Yeah.
Sir.
No. No, I'm already unmuted and I'm sharing screen already, but I can't. You can listen to hear me. I will reconnect.
Professor Dr. Shamul.
You can see.
Is
You can hear me?
Failed pediatric.
Now I'm sharing screen. Can you see the screen?
With valgus osteotomy and pediatric.
Screen sharing you cannot see. There's something at your end because I'm sharing screen.
That's the point.
Yeah.
Good afternoon. First of all, I want to express my thanks and gratitude to everyone, those who have given me the opportunity to be here to present my paper. And thanks to audience. At this end of the day, probably a lot of audience are eagerly waiting to learn. This is showing that how much they are interested about the pediatrics and this subject. My topic is on failed pediatric femoral leg fracture, a solution with valgus osteotomy and pediatric dialysis. I will go for some introduction to the pediatric femoral leg fracture. These are pediatric femur. Proximal femur includes epiphysis, neck, and trochanter. These fractures are very rare, less than 1%, and very high rates of long-term complications demand early aggressive treatment. Always poses the problem of compliance between the parents of the patients and surgeon regarding the modalities of treatment. Frequently associated with serious complications like avian, varus with non-Indian or Malayunian premature facial closure and LLD. As almost all fractures require early operative treatment, so it is a fracture of necessity. I will go for blood supply of developing femoral head, and understanding of the blood supply of developing femoral head helps in evaluating the results of treatment. Trueta in 1950 and later Rosden describes the vascular evolution of the femoral head. These are the pictures depicting the medial and lateral femoral circumflex artery, how they are supplying by two circular bands. And this area is a zone of least vascularity through which we can find some window to enter the joint. I will go first. Clinical presentation. These fractures always present with high velocity trauma, and symptoms are inability to move the limb, pain in the inguinal area, may spread to the knee joints, and limbs is always in flexion, external rotation, and abducted. Movements are restricted due to pain and shortening. In infants, non-traumatic hip pain and pseudoparalysis should be searched for septic hip or transient synovitis or DDIs. For diagnosis, X-ray is the gold standard. for AP view of both sides for comparison of the healthy hip, and cross stable lateral view on the affected side are advised because frog leg lateral view are not advised due to pain and further displacement of the fracture. Arthrography sometimes indicated for differentiating with the DDIs, and ultrasonography also helps in guiding aspiration to avoid the rule out the sepsis, and MRI reserved for doubtful cases of unstable slipped capital femoral epiphysis or stress fracture. Now come to the types of the fracture. We all know that Delbert is the standard classification, and this is practiced all over the world still. Type 1 fractures are transfacial or transepiphyseal fracture. This can be with dislocation or without dislocation. And type 2 are transcervical fracture. These are transcervical fracture. And type 3, cervicotrochanteric or basal, what we call basal cervical. And type 4 are intertrochanteric fractures. Now, treatment. Overall treatment outcome depends on types of the fracture, amount of initial displacement, timing of surgery, age of the patient, and modalities of the treatment. In the literature, it shows that the implants of choice are given in the outline that if the baby is less than 4 years, a smooth or threaded pin has been advised. And if it is between 4 to 7 years, 4 millimeter cannulated hip screw, minimum 2 screws should be given for fixation, stable fixation. And if it is more than 7 years, 5 millimeter or 6.5 millimeter cannulated screws are advised. Hip spica should be given after fixation with the screws. And if closed reduction fails, open reduction should be attempted. These are the tips and tricks. As the pediatric femoral leg is very hard to drill and generates high amount of torque, so to prevent this, at least 2 K wires should be kept in position. These 2 K wires, because these bones are very hard, and tapping is a must to prevent the impaction of the screws. Multiple drilling at the base of the trochanter may cause iatrogenic fracture. If you put multiple holes here, that can cause the iatrogenic fracture. Now come to the complications, because my topic is on complication and management of the complications. So common complications are, as we all know, the avian is the most commonest complication. And next, the varus with malunion or non-union and premature facial closure. And infection, though it has been mentioned, but this infection is not that much common. I will try to show some complications. You see, this is a basal type of fracture. It was nicely fixed and also healed, but some amount of varus is there, and neck shaft angle has been reduced. These screws are very much prone to back out, but they can hold the neck shaft angle. Another complication, you see the screw cut out here, and the head is here, and we can try to restore with this type of implants. This is controlled, pre-controlled small DCP along with fibular graft. What is the solution of this type of non-union or any complications? Changing neck shaft angle by subtrochanteric Powell's valgus osteotomy. I think this is a very good option for this type of cases. We have done 7 cases of failed fracture neck femur in children between 2017 to 2021. All these cases were done in the NITOR, and along with me, accompanied by, Dr. Tushar Kamrujaman and many of my junior doctors were with me. 6 patients were male and 1 was female. Age varied from 8 years to 15 years. Mean age was 10 years and 2 months. 5 cases were postoperative failure. At least 1 surgery was done earlier, and 2 cases with failed conservative treatment. 4 were Delbert type 3 and 3 were Delbert type 4 at their initial injury. And treatment of choice was valgus osteotomy and a pediatric DISS. Valgus osteotomy converts the shearing force into compression force at the fracture site, which aids in healing of the fracture, and no need to open the joint capsule or any debridement of varus tissue and bone graft at the non-union site. We obtained 6 cases as good results and 1 as poor results, which resulted in avian. There was no postoperative shortening or LLD. Neck shaft angle was increased to an average 125 degree, which was initially 100 degree, and union achieved with an average 13.5 weeks at the non-union site, and trochanteric osteotomy site was united within 10 to 5 weeks on an average. No implant failure, but one case has a screw cut out. I want to spend few moments here. This is the basic principle of valgus osteotomy. This is a trigonometric estimation. You see the center of the osteotomy and center of the head. This length always remains static. Once we do change the angle, this is the initial angle, varus angle. If we do the valgus angle, this height, delta H, this height we can gain. So if we cut a few ways here, we add nothing to short the limb, but rather we can add some length to the here. On the other hand, this changes the line of fracture. This Powell's line angle has been changed to, this is a shearing line, transforms or converts into a compression line.
Hello? Hello, are you able to hear me?
Yes, sir.
Okay.
Please share your.
Can you see my screen? Can you see the screen?
No, sir.
So I'm sharing my screen. Can you see my screen?
No. The screen is not available.
We can see. We can't see your screen, sir. Yet now.
Hello.
Our next presenter is Dr. Kaji Shohidul Alam. His paper is Operative Video Demonstration of DDH by Open Reduction Only. Dr.
So good evening, everyone. So I'm going to show you a simple technique by which we do the open reduction for DDH below 2 years of age. I'm quite sure that many of you have done it in many ways. I have seen a lot of works actually, particularly on this operation, both from within our country and from outside. And along with the help of Professor Sarwar Ibn Salam, we actually made up a combination of all those techniques to make it a little bit better one. So before I start my video, I wanted to know all of you that my camera is always in one side. I actually didn't change my camera. So this up side is the medial one, downward is the lateral side. This one is the leg side, and that one will be the cranial side. So you just keep this 4 direction in your mind so that you can understand what I'm trying to say. So let us proceed. So this is the left hip that we are going to operate. And as you can see that I am first making my skin incision mark. The top 3 point is actually demarcating specific landmarks. I'm going to show you a little bit afterwards also. So as you can see, the middle point is the anterior superior iliac spine. The cranial most part is, and along the inguinal ligament, a little bit below and towards the medial is the anterior inferior iliac spine. But my incision line lies parallel to this one, just a 1 finger breadth below, not along those landmarks. So the benefit of this is I can distract the skin incision towards both laterally and medially along with my desired dissection later on. So this is the incision mark that we use. So I'm going to make the skin incision right now. Once the skin is inside, I'm going to dissect the subcutaneous tissue and fat plane. You need to remember that from the anterior superior iliac spine, basically 2 long muscle actually originates and directs into 2 different directions. One goes towards the medial side of the distal femur, that is the sartorius, and one goes directly to the lateral side, that is the tensor fascia lata. And this is the target intervening plane between these 2 muscles, sartorius and tensor fascia lata, which will be my first target. Now, depending upon your incision, you might find the muscular going, then it is tensor fascia lata. So depending upon that, you are going to retract that exposed muscle fiber to find out the opposite muscle. So you can easily find the muscular plane. So that is the incision I made in my deep fascia. And along with the direction of the fibers, it is showing me that it is directly going towards the lateral side. As you can see, the skin incision line and the deep fascia incision line are not the same. The deep fascia I have split it almost vertically. So now this is the tensor fascia lata, which has labeled as a black because that directed towards the lateral side. So I retracted laterally and the medial side was the sartorius. I stopped over there and now I came to my iliac crest. So in between my 2 fingers is the total breadth of the iliac crest. And with the help of a blade, I'm going to dissect the apophysis vertically downwards up to the iliac bone so that the iliac crest now divides into a medial half and a lateral half. The medial half will contain the iliacus muscle and it will be retracted inside towards the peritoneal cavity. And the lateral half will contain all the abductor muscles. So I'm going to reflect all the abductor muscle together, not even giving a single incision in any of the abductor muscles. So with the help of the periosteum, now I am dividing the 2 apophyseal splitted part, and in between the bony part, that is the true iliac bone. So this is the lateral half of the epiphysis that is below. All the abductors are connected with this one. And this is my main one, that main target which I'm going to retract. Medial one, I'm going to retract a little bit, but it is not that much mandatory. So once I extend this iliac crest incision towards my anterior inferior iliac spine, the sartorius will remain contacted with the medial one, medial end of the apophysis, while the tensor fascia lata along with all abductors will come into contact with the lateral apophysis. So once I cut this last fascial barrier, the apophysis along with the abductors and the tensor fascia lata as a whole will come into the lateral side. The retractor I am using on the upper side, that is the medial one, is containing the sartorius, and the rest of the part is tensor fascia lata, and the little bit whitish area with some reddish flavor in it is the hip capsule along with blended part of the rectus femoris, not the straight head but the reflected head. So now I'm going to softly dissect the reflected head of the rectus femoris from the hip capsule. Once you dissect it a little bit, a more shinier and whiter portion will come up into the visible area. That is my hip capsule. Then actually I'm going to cut the hip capsule like the same way we do in hemiarthroplasty, inverted T shape. In small incision over that hip capsule, and you will see more shiner whitish structure that will indicate the cartilage, articular cartilage of the head of the femur. So I'm cutting the capsule right now. The head will be visible anytime. In note. Which is the most brightest and whitest structure in this area right now. Over the head, if you are lucky enough, you will find this ligamentum teres femoris. In younger child, it always remains. But if it is a neglected one, if it is an older child, you may not be able to see this ligamentum teres intact. It may be torn during the disease process. But if you can find it, it actually helps you a lot, because the direction of this ligamentum teres towards the pelvic cavity, which will guide you actually where the acetabulum, center of the acetabulum is. So now I pull the vertical portion of the inverted T incision along over the direction of the ligamentum teres femoris. I haven't cut the ligamentum teres femoris yet. If this ligamentum teres were torn before your dissection, then you have to assume and confirm the position of the acetabulum with the help of the C-arm. That is the ligamentum teres I am directing. And just like the hemiarthroplasty, before we proceed furthermore, we actually hold the two corners of the hip capsule with number 1 Vicryl to be sutured later on for the strengthening of the capsule plication. Because once you put the head inside the acetabular cavity, then all the hips capsule will try to go along with the head towards the cavity, and it will be very difficult to find the hip capsule later on once the relocation has been done. So both two ends of the hip capsule is now marked, identified, and secured with a suture material. Now I'm going to cut the ligamentum teres. And after that, I'm going to remove it totally with the help of a curved scissor directed towards the acetabular cavity. And you will be surprised to see where this ligamentum teres actually goes. Because clinically, you may feel that there should not be acetabular cavity below, at the below level, but it actually always lies over there. So I confirm the position of the acetabulum with the C-arm before I cut the ligamentum teres. If you do not have the ligamentum teres after your dissection, then this is the procedure you have to do. Once you cut the ligamentum teres, then you make sure that you totally empty the acetabular cavity, which is actually filled with a lot of soft tissue, especially fatty tissues. And once you are sure that everything is cleared, with the help of little gentle traction and internal rotation, if the child is below 2 years of age, it is very easy. With this maneuver, traction and internal rotation, it actually relocates. And then you need to confirm it with the help of a C-arm. Now you can see the head is lying within the acetabular cavity. You can check the stability also by pushing it in different directions, flexion, abduction, adduction. Once you're sure that it is stable enough, then I'm going to fix it with the help of a K-wire starting from the greater trochanter towards the iliac blade. You do not put the K-wire within the acetabular cavity or within the joint. And you can see the position of the K-wire. It is started from the lateral side of the femur. The greater trochanter you can feel with the help of a K-wire, but it will not be visible in the C-arm. In the C-arm, it may show you that it is going in and through an empty space. And once it is done, as usual, soft tissue closure followed by his pica. And that is the simplest way of a non-complicated DDH reduction only by open reduction. Thank you all.
Is there any question?
So Bobby, you do
Yes,
not
please.
address videos.
Which one, sir?
You do not address the psoas sternum?
No, because it's only less than 2 years of age, so the tightness was not there. As I've already mentioned to you, sir, that it is the simplest DDH you can ever see, I guess.
So you do not do the capsulorrhaphy?
After that, we do the capsulorrhaphy. That's why I actually hold those end of the capsule with the help of a suture material so that I can find out where the rest of the capsule is. Then I do the standard capsulorrhaphy.
Bobby,
Yes,
thanks
sir.
for your nice depiction and illustration. Operative views of DDH. What you have told that very easy procedure, but still I feel that this is a very difficult procedure.
Definitely, sir. This is the simplest one.
The simplest, the complexest.
The simplest among the DDH.
So you have mentioned the simple DDS and complicated DDS and uncomplicated DDS. What is meant by simplest or uncomplicated DDS?
Usually below 2 years of age, actually they only require open reduction, sir, and do not need that much of soft tissue dissection.
Next part of my queries are, if you lose or if the baby is walking after 2 years or 3 years, the ligament of the head of the femur disappears. You may not find it out.
No, sir.
So what is the guide or horizontal cut of your neck towards the neck? You have cut and found the true acetabula.
Yes, sir.
Now what guide you follow? And next part is when you go inside the acetabulum, sometimes limbus remains inverted and it becomes so narrow and shallow a cavity. It's really become very difficult to clean it out and inverted limbus to evert it. How do we differentiate the cartilage and the limbus tissue? And what tissue you cut, what tissue you keep? Thank you.
Okay, sir. First of all, if it is a walking child, if the child is already in a walking age, then the head actually lies a little bit more upward, almost just beside the acetabulum. So in that, my little experience, I found that the laser trochanter actually lies a little bit level of the acetabular cavity at that moment. So once I opened it up, the capsular portion, and when I hit the head is visible. If I put my fingers through it, I can actually feel the laser trochanter. And just above the laser trochanter, I blindly introduced my artery forceps a little bit and check it with the C-arm where the actual direction of the acetabular cavity is. So that is how you are going to identify the acetabular cavity. Now, you are right, definitely right, sir. All the acetabular labrum and other soft tissue cartilage get inverted and they actually narrowed your vision very much. So what we, with me and Dr. Sarvasari actually do, we give some vertical incisions over those labrums blindly to make some cuts so that those become a little bit discontinued so that can be elevated upwards. We usually may use some suture materials also to lift them up to have a better look at the inside of the acetabulum. And in that case, release of the iliopsoas from the laser trochanter, we actually generally preferably do, because that is what Professor Kim always told me, that if the child is already in the walking age, you will not be able to give it a traction and it will come into a place. Better to remove the iliopsoas from the laser trochanter subperiosteally. You do not need to cut it away actually. And definitely at that point of view, the shortening and varus derotation osteotomy of the femur will be also required. Once you shorten the femur, all the abductors and all the long flexor and extensor muscles, everything will become automatically loose. Those are definitely, it took a more longer period of time, sir.
Thank you.
So one more question, Bob.
Yes, sir.
So why K-wire needed?
Okay, sir. Because the K-wire is needed because the acetabular curvature is not normal here. because the head of the femur was never into the acetabulum, and none of them were actually developed since birth. So once I put the head back into the acetabulum, once I push it inside a little bit with force, it may remain there stably, but it is actually not stable because the head and acetabular size are never matched. Along with the capsular raphe may not be powerful enough to hold them even within the hip spica. We have tried them, not giving these cavers only the hip spica, and unfortunately, most of them actually have failed. So this caver actually keeps that head into the acetabulum for a total about 6 weeks. By that time, capsular healing and contracture and everything, soft tissue stability achieved. After 6 weeks, then we under anesthesia remove the caver. After cutting the, remove the hip spica, then remove the caver, and then again apply the hip spica for another 6 weeks. So total 12 weeks.
You give the hip spica, no?
Yes, sir.
So why caver?
Because in first 6 months, first 6 weeks, the hip spica alone is not good enough to hold the head within the capsular cavity with my capsular raphe and that sort of
The
things.
obstruction of reduction is adductor tightness, capsule hourglass contracture, transverse acetabular ligament of acetabular, and iliopsoas.
Yes, sir.
If you release all these things, why caver needed?
Even if you release all those things, the head and acetabular shape never match that. So they do not try to stay over there. And I have seen in most of the journals that it is very much recommended to keep that caver. I think Professor Sarwar Ibn Salam can highlight on that, sir.
It should be individualized. You may not give it, I may not give it, but someone has to. I have talked to Sandeep Padgardhan regarding this. He has told that if you feel you can keep it, it is not standard protocol to put a caver. That is, of course, right. But if you feel putting a caver through greater trochanter to ILAM is not a big problem. I learned it from Odisha. So it's up to you.
Thank you. Next, probably Shundi Padavardhane is ready for giving the.
Yes, sir. Can you hear me now?
Yes, sir.
Okay, thank you very much. Sorry for the technical errors and delays. And I will just try to cover briefly in cerebral palsy how to make it easy. Dr. Sarwar Salam has already shown that Bangladesh has 1,000 orthopedic surgeons, and a lot of complicated cases are there which need at least primary attention. And my endeavor here is to make you aware of what you can do. So this presentation is not a very great presentation, but it will just help you to identify what things you should do and what things you should not do. So this, I call it how to make CP easy, or 8 steps to success. The first principle is, please understand that CP is not polio, and please don't apply the same concepts. The second is, please understand what GMFCA scales are. Third, please define what is your priority of treatment. Is the child a walker or a non-walker? Because your priorities will be different. Fourth, understand that the non-walkers will have hip problems, and it is a priority to diagnose hip dislocation at early age. Fifth, gait analysis, observational is always important. Instrumented is not mandatory. Sixth, if you manage spasticity well in the young child, you may avoid or postpone surgery or do lesser surgery. Seventh, importance of a trained physiotherapist and rehab center for these children all over your country so that we can manage these children better. And please, lastly, understand CP for me is a social disease. It is not a medical one. So let's highlight these concepts. CP is not polio because polio is a lower motor neuron lesion where there is flail limb with loss of power which is permanent. So in polio, the concept was either balance the power by tendon transfer, release the contracture, align the leg and give the child a caliper. The bottom line was caliper and make the leg straight and stable. Whereas in CP, it is upper motor neuron lesion where the loss of power is not permanent. If we can control spasticity, align the limbs and stabilize the child during the gait cycle in stance phase and keep him loose enough in the swing phase, and strengthen the anti-gravity muscles, you will be able to make the child walk. Please remember that for many, many years, people have been doing TA lengthening because that is what was done in polio. In cerebral palsy, TA lengthening is a strict no-no because you will over-lengthen the TA and make the child worse. He will go from equinus into crouch and make him even worse. So fractional release in the zone 1 or zone 2 is important. Never do TA lengthening. Don't apply polio concepts here. The second point was, what is this GMFCS? When you talk of GMFCS, you must understand that the child with CP can be divided into two groups. Level 1 to level 3 is child who can walk. And this gets established by age of 6 years. If by 6 the child can either walk without limitation, he is level 1. Level 2 walks with limitation. Level 3 requires a walking aid. Level 4 and level 5 are essentially wheelchair bound. Level 4 may be able to stand and walk a few steps, but level 5 is always in a wheelchair. So this is the GMFCS descriptor. By far and large, it has been proven that between these ages, you can improve the child to achieve a certain. So remember that your best chance to make them ambulatory is making them level 3 or below in the 6 to 12 years. Now that depends on how bad was the initial damage and how good a treatment they received. Third, treatment priority. For all CP children, please remember communication, education are more priority. They have to be able to tell that they are hungry, they have pain, and they should be able to talk to their parents and colleagues. Mobility and ambulation come later. In our life as orthopedic surgeons, we keep on thinking that we must make the child walk. Parents also want that, but it is more important that even if they don't walk, they are independent in communication and are educated well. So mobility and ambulation come later. You treat holistically and make sure they are educated well. So you must have a multi-faculty approach with a lot of people involved. Your developmental pediatrician, your neurologist come first, then the physiotherapist, the occupational therapist, and then the pediatric orthopedic surgeon actually comes last. Why do we need to treat CP? Now, a very simple fact. Cerebral palsy is not a disease where the patient is going to die. 30-year survival of CP is 87%. There are no adaptive mechanisms as adult CP. You see adult CP patients struggling on bus stations, in society, everywhere. They cannot climb stairs and they are really disabled because our society is designed for normal individuals. If you don't treat deformities and contractures, they have disabling effects. And mobility and ambulation are important for independent living. What are your priorities? How do you treat them? If the child is going to be a walker, which means GMFCS 1, 2, or 3, the approach should be make the feet plantigrade and stable, make sure he can extend the knee, make sure the hip is located and painless, make sure the spine is stable, make sure that the polyarticular muscles have good length of excursion for gait, and make sure that the anti-gravity monoarticular muscles are strong in the stance phase. Please remember, every word I am saying is important. Monoarticular anti-gravity muscles have to be strong in the stance phase, and the polyarticulars have to be loose enough to allow for gait. In the non-walkers, our aims are totally different. You must make sure the spine is stable in the wheelchair and progressive, and happens in about 50% of patients, especially in the non-walkers. It is easy to detect, but it is very difficult to manage if treated late. Spasticity and non-weight bearing cause the spastic hip disease. There is a progressive adduction contracture, secondary bony torsion, coxa valga, gradual acetabular erosion, and the femoral head becomes dislocated and deformed. So this is not DDH. This is different. This is acquired paralytic hip dislocation. Now this has to be managed differently. 90% in GMFCS 4 and 5. So please evaluate the hip in the non-walkers more rigorous clinical symptoms to come. Okay. Don't wait for the hips to move out like this, then they won't even be able to sit. So you must take supine PBH X-ray, which is standardized, and calculate the Reimer's migration percentage and the acetabular index. So this is all given in the textbook. Draw the lines so that you know how much is the migration. And if the migration is exceeding 33% and the child is a non-walker, you must aggressively treat the hip. Otherwise, the hip is likely to dislocate. Spastic hip dislocation has to be treated for improving function, ease of transfers, perineal hygiene, and reduce the burden of nursing care. And 50% of them will have erosions and become painful hips. So you must locate them and give them the best chance. Early management is by bracing and Botox. Intermediate management is by releases with reduction and osteotomy with pelvic support. The gauge, when he talked about gait analysis, all of us, most of us, 90% of us practice observational gait analysis and static examination of the child. You can improve on that by doing two-dimensional video gait analysis by your mobile phone. You can just use your phone and shoot the child walking in the frontal plane and the sagittal plane, and with the playback, you will be able to identify more and more problems. The 3D computerized gait analysis is a useful tool which will give you kinetic and kinematic data, but it is mainly a research tool and it is needed actually only in less than 5 to 10% cases for decision making. It is rarely used and it's extremely expensive to be able to pick up, or your examination may miss. But it does not replace observational gait analysis, neither does it dictate your treatment plan. It is just a tool to identify and understand gait problems more, analyze it and publish papers. Sixth point is how to manage spasticity. Now you know that if the muscle tone increases, biomechanics change, there are contractures, and then there are bony lever arm adaptation problems. So in CP, the muscle under tension, which is spastic, does not grow. The bone continues to grow, relative muscle shortening happens, and this leads to deformity and contracture, right? So how do you differentiate between contracture and spasticity? If you can relax the child under anesthesia and can correct the deformity, it is spasticity. If it is not relaxed under anesthesia also, it is actual contracture or shortening. And shortening needs surgery. Spasticity can be managed by Botox. In the early stages, you can try stretching, splinting, serial cast, and finally surgery. Control of spasticity at the central level by oral medication may cause drowsiness and has side effects. At the spinal level, you can try to reduce spasticity by intrathecal baclofen or baclofen pumps or selective dorsal rhizotomies. But these are extremely rare procedures and complicated, and at least in our situation, we don't use them. Earlier, phenol blocks used to be given, but they damage the nerve permanently and may cause severe paresthesia. So we have given up that. Neuromuscular block is what we use, which is reversible, that is Botox. And at the muscle level, you can use oral muscle relaxants like dantrolene. Oral spasticity medications, as I said, have side effects and very few cause good effect. Botox is a local temporary cholinergic chemodenervation, and various polyarticular muscles need to be injected, commonly gastrocs, hamstrings, adductors, rectors, psoas, and long flexors of the upper limb. So you must have accurate needle placement. This is just a few videos to show you the long muscles of the hand, the finger flexors, the biceps, the pectorals, and the calf muscles, how we place the needles. You can use ultrasound or you can do it manual freehand with experience. And these are a few results of children treated with Botox. This is GMFCS3, assisted ambulator with right more than left dynamic equinus. And this is post-Botox after his Botox has been done and good rehab has been done. You can see that he's able to walk independently with a AFO on the right side. Now this is another girl who's walking in equinus, but is independently ambulatory. And this child received just one injection of Botox, and that was her immediate post-op. And this girl at 9 years is able to walk very nice. So sometimes properly targeted Botox can give you really wonderful results, but you need to keep them under proper follow, as well as good physiotherapy is absolute must. Orthopedic surgery is needed after about 8 years of age, when there are demonstrable contractures and deformities, to relax tendons, improve their excursion and improve balance, and correct your deformities and stabilize joints. Today we do single event multi-level surgery. Avoid the birthday syndrome that you are doing operation every 6 months or 1 year. Monoarticular muscles are stabilizers and should not be touched. The polyarticulars are movers and they will need lengthening. The anti-gravity stabilizers, which ones are the polyarticular mobilizers, and treat accordingly. Treatment of contractures is level 1 surgery by soft tissue releases, depending on where you want to do it and the timing. And level 2 surgery for tibial, you need to do either Mosca or triple fusion to stabilize the foot in stance. So remember, bony liver problems, correction will give stability in stance phase, and level 1 surgery will give you mobility. And well-treated CPs can really do well, especially the GMFCS 2s and 3s, where you can restore their function to a great deal. This is another example of a crouch gait. Now this child with crouch, who was an assisted level 3 ambulator, he underwent a psoas release at the brim, medial fractional hamstring release, distal femoral extension otomy, patellar tendon plication, and a solid AFO. And we could improve him from that situation to an independent ambulatory situation. So there's a lot that can be done to improve their life, and we must give all attempts to make children who are like this and improve their life from the situation that they are in to the situation that they can become, and help them achieve their full potential so that they can at least become independent walkers. So these are just a few examples. Please remember, between 2 years to 6 years, probably you have to surveillance for the hip and give Botox. Between 8 years to 12 years is the time for level 1 surgery, and after 12, time for level 2 surgery, and try to combine or do one-time surgery and try to postpone it as far as possible. The physiotherapy team is extremely important. Early detection, early intervention with early diagnosis, sensory integration, speech therapy, neurodevelopmental therapy, everything has to be integrated. What do we expect from therapists? Hip surveillance, don't force the TA and create an iatrogenic midfoot break, timely referral for Botox, timely referral for surgery, and caution your therapists that don't be forceful, because they may end up causing pathological fractures, fascial separations, and please, they should not make unrealistic comments and should not order unnecessary investigations. Therapists can sometimes make or break the child's confidence and the family's confidence, because they are closer to that family than you are. So remember that and treat them accordingly. And finally, this was the definition which was given by Beckett and Polanyi of CP. CP, they said, was a non-progressive damage to the brain before 3 years, which was modified by Graham and Boyd, and they said, but it is secondary musculoskeletal pathology is definitely progressive because the child grows, though the brain lesion may not grow. And I have modified it recently to add my own take on it. I feel CP is a disabling disease occurring across all strata of society, about which there is a lot of ignorance and neglect at all levels. Neglect is by parents, by doctors, by health officials, and society at large. This prevents a large number of individuals from full societal participation and the dignity of existence. This is what I define CP to me. This is what CP means. And the levels of problems are in early diagnosis and proper counseling. They don't have access to trained personnel for management of CP. There is no availability of care in the rural areas where they stay. There is a large cost involved in treatment and long follow-ups are needed. Rehabilitation aids are needed, their cost can be high. They don't have access to education because schools refuse to take such children. And unfortunately, insurance doesn't cover these children and they don't have any financial aid. So the society at large becomes weakened because these children cannot be made, though they have otherwise intelligent brains. What can be done? We have a tie-up with the CSR wing of one of the industries, Phenolics Industries, that is called Mukul Madhav Foundation. I think two of your members who were fellows with me had the opportunity of attending camps with me. So we do camps, we have this mission CP, and we go out in the community, identify these children, give them therapy, give them surgery, give them aids, and give them vocational rehabilitation. And this is how we conduct a social awareness program and educate the public, therapists, doctors, parents, everybody. I think you can see your colleague here. There is a photograph, two of them are here. I enjoyed our visits in camps. And these are the number of children we have assessed, more than 550, and the numbers keep growing. So thank you for listening to me about this talk on CP, which I think is very relevant for Bangladesh in the upcoming years. Thank you very much.
Is there any question? No. Thank you, Mr. Patwardhan.
Sir, I have
There is
one
one
question.
Yes, sir.
CP with isolated ankle equinox due to gastrocnemius tightness.
Yes, sir.
So should we do fractional lengthening at the age of 5 or 6 years?
So it depends on whether you're able to control the tightness. Is it a spasticity or is it a contraction? If it is spasticity, you can give Botox and cast it. If it is a contraction, you can do fractional release and lengthen the tendon, but don't over lengthen it by doing a tenotomy or a low TA release.
The age limit.
Age is not always the criteria. It is the amount of correctability that you can achieve at that age. And what are the tools available to you? Do you have a therapist who can gently stretch the calf without creating a midfoot break? Do you have a component of spasticity which you can address by just giving Botox? Under anesthesia, how much does it relax? And then you make the decision whether you are going to put knife to it or just treat it with corrective cast or stretching. But if it is very tight and not yielding, I will not hesitate to lengthen it.
Thank you, sir. Thank you for your brilliant presentation. Our next presenter.
Thank you very much.
Thank you, sir. Interactive case session by Professor Dr. M.A. Bari. Sir is present or not? Sir, please come. এখন স্যার দুটো অ্যানাউন্সমেন্ট আমি করছি। একটা হলো বসকন নিয়ে, সেটা হলো যে বসকন আপনি করবেন স্যার 10 তারিখ পর্যন্ত বসকনের রেজিস্ট্রেশন বাড়ানো হয়েছে। আপনারা যারা ইন্টারেস্টেড তারা 10 তারিখের ভিতরে রেজিস্ট্রেশন করে নেবেন। আর একটা হচ্ছে এই প্রেজেন্টেশন গুলো শেষ হয়ে গেলে টি ব্রেক আছে, আপনারা সবাই টি ব্রেকে চলে যাবেন এক্সেপ্ট দ্য পিওএসবি members.
Okay.
Thank you, sir.
সবাই কিন্তু টায়ার্ড, তাই না? আমি কিন্তু ভোর 5টায় উঠেছি, কাজী আমাদের কোয়ারিদা টায়ার্ড কি আমি জানি না, সকাল থেকে এখন পর্যন্ত বসে আছি। But most of the young orthopedic surgeons, they have left. I have seen that middle age and above that they are sitting here. And today, dear friends, আমি জানি যে doctor is always a student. When he fails to be a student, he dies. And বিশ্বজোড়া পাঠশালা বোর্ড সবার আমি ছাত্র, নানানভাবে নতুন জিনিস শিখছি দিবারাত্র। এই পৃথিবীর বিরাট খাতায় পাঠ্য যেতে পাতায় পাতায় শিখছি আমি কৌতূহলে, নেই কোনো দ্বিধামাত্র। আমি আমার এই কথাগুলো বললাম এই কারণে, শিক্ষার কোনো শেষ নাই। I would like to start my presentation with this. কয়েকটা কেস আমি just নিয়েছি, not for that I want to share my experience and what to do as an orthopedic surgeon. Just এখানে দেখবেন আপনারা যারা এখানে আছেন, আপনারা মনে করছেন যে আমি এখানে দাঁড়িয়েছি, I'll show the Elizar of cases. The case that I have selected, just you can see, this is the case, 4 years old boy. Just look at this. আপনারা আমার সাথে শেয়ার করুন, আমি সবে বেশি নিব না। ডায়াগনোসিস বলেন তো, বলেন ডায়াগনোসিস দেখে হুট করে। হ্যাঁ, ওই পোস্ট অস্টিওমায়ালিক গ্যাপ নন ইউনিয়ন। আরো বলেন সরাসরি। সুডো আর্থ্রোসিস বলছে একজন। অ্যাট্রপিক নন ইউনিয়ন বলতে কেমন বোঝায় বলেন তো? অ্যাট্রপিক গ্যাপ নন ইউনিয়ন, লুক এট দিস পয়েন্টেড 4 বছরের বাচ্চা, হোয়াট উইল ডু? আপনি কি করবেন? শুধু বললে হবে না যে আমি ইলিজার করব, কি করবেন বলেন? No answer from the dais and from the audience. দেখেন এই ধরনের কেসগুলো I want to share my experience for the lungs starting from 82 until today. See, look at this. He was treated elsewhere 3 times, 4 times, and then what are the problems here? See, look at this boy. And this is, you can see, just compare. Just after the removal, now you see the before and after the treatment with the reserve. So this is the message for you. Now let us see the case 2. What is this? Put your diagnosis. 1.5 years old boy. Please. আপনারা করেন, join করেন. Put your diagnosis. Lower end of the femur, left. What happened to this? They are 1 and 5, 1 year, 5 months. What is the diagnosis? From right side, what is the diagnosis? Osteomyelitis of what? And what you'll do? 1 বছর 5 মাস, 1 year, 5 months, what you'll do? Oh, what will do from the left side? No answer. See, message is 1 বছর 5 মাস, you can put Ilizarov, only the wires, biocompatible thin wires, 1, 2, 3, and 4. See, look at this, just after 3 months, 1.1 year and 5 months. Now let us see the case. The video this is the 15 years old boy. Look how he is walking. Next. What is your diagnosis? আমি আগে শো করেছি অনলি ভিডিও, এখন ডায়াগনোসিস জেনুভেরাম, ব্লাউন ডিজিজ। এই মাঝখানে প্লিজ, ফ্রম দ্য রাইট সাইড। বলেন প্লিজ, বলতে হবে তো, সবাই সবকিছু জানতে জানেন, আমরা সবকিছু জানি না। আমি তো বলেছি বিশ্বজোড়া পাঠশালা মোর সবার আমি ছাত্র, আমি এখানে আসছি শিখতে আসছি। বলেন সবাই সবকিছু জানবে, আমি সবকিছু জানবো এমন কথা নয়। আসলে শেয়ার করেন, জানেন না। সি দেখেন, ওর বয়স হলো 15, ডান পাশে তাকান, ফিমার তাকান, টিবিয়া তাকান, ইপিফাইসিস গ্রোথ প্লেট অলরেডি ক্লোজের দিকে। আমি এটা দেখাবার উদ্দেশ্য হলো chondrodyastasis. I have done the patient this case because 15 years old, starting from 12, you can go for chondrodyastasis. If you do chondrodyastasis before that age, you may need to go for second surgery. So this is, look at this after removal. This is before, this is after 6 months treatment. Now see, what is this? What is this? 7 years old boy. What is this? Fracture of the right femur. What will do? What will do? Close reduction, internal fixation. Telescopic nail. Elastic nail. Very good. See what orthopedic surgeon has done. After 2 months, infection has started. Went to the second orthopedic surgeon, what he has done. See, and came to the third orthopedic surgeon with these. See, look at the right side and the left side with multiple discharging sinuses. So teaching is why I am showing this. So these are the 7-year-old boy. You see, this is the 7-year-old boy, came with simple fracture. You have done plating, and then you have done the uniaxial. And from that situation to this situation, you can see 3-year-old boy, see the left side. Here is the discharging sinus. Here is the pathological fracture. And this is the situation. This is the father. And what you'll do, what is your diagnosis? Right side. Chronic osteomyelitis, discharging sinus. What will management? Saucerization, removal of the involucrum or sequestrum, and then cast. Okay? This is also option. But see what I have done. Nothing. Only fixed with biocompatible thin wires with Elizar multi-axial. And then see, first step surgery. Okay. Then look at this. After 5 months. Now you compare from this situation to this situation. And then after 11 years follow-up, came to me again with 10 centimeter LLD. Then we have lengthened. Now you can see the next follow-up. This is after 16 years, 3 years and 13 years follow-up from that situation to this situation. And this is the final follow-up. Now you can see the scanogram. Just look at these. What will be this? Right side, no answer. Back, no answer. Left side, no answer. Then, during operation, Delta Hospital told this is a fibrous dysplasia. And another hospital told this is a non-ossifying fibroma. And then I have decided to remove the segment and bone transportation. And then look at this during treatment with 3-ring construct. See the pattern of the ring, pattern of the wire, and straightening of the wire. And this is the after 5 months. Thank you so much for your kind attention.
Is the question?
Okay, thank you.
Sir, Assalamu alaikum. I have one question. Case 3, what you have shown, the boy is already 16 years old and physis is already closed. And if we go for the scanogram, we will see that the tibia is the deformed bone there. Why not accepting like if we go for osteotomy at the proximal tibia, that may heal the genovirus, right?
Yes.
Other than going for Elizar. And I'm not telling that Elizar.
Yes. This is the case that regarding, in pediatric, there was a session, regarding the chondrodiastasis. Probably you answered, and Professor Query was asking, is there anything for chondrodiastasis? That's why I've shown you could go for osteotomy above the cora or below the cora. I have shown only for that at the age of 15, you can go for chondrodiastasis. That's why I have shown this.
Thank you, sir. Thank you very much.
Sir. Thank you, sir. Our next interactive session is by our Professor Dr. R.R. Paediatric. Sir, please.
Yes. Thank you, Dr. Said, Chairman, and Tushar, and the participants. It is now already 20 minutes to 6 o'clock, so I will not take much time. This is the last. I have kept it. I told Umar, Sarar Ibn Saram, they keep my lecture the last one, because if you give anybody as a last lecturer, he will be unhappy. So let me present as a last case. Acha. Already by this time you have learned about this DDH. So just I will show some cases. This is 2 years, 10 months post-op DDH. As Dr. Kim says, up to 8 years of age, there is chance of remodeling of the acetabulum. So we don't worry about this acetabular shape, it will remodel. This is another case. This is another case. You can see that how the acetabulum is, this type of acetabulum can remodel within time. There are a few cases. This is a case of chronic osteomyelitis with large sequestrum. Barisar has already presented. How will you manage this one? This is a large sequestrum, epiphysis is there, involving the whole sept of the humerus. So don't forget that conservative management in children also helps, because children has got the lot of degeneration capacity. Do the culture, we have given the incision, we have not removed the sequestrum, we have taken the culture and sensitivity, antibiotic and immobilization, and this is after 4 months only. Unbelievable. This was the case, and this is after 4 months of treatment. Antibiotic and immobilization. This is a case of septic arthritis of the hip. Don't forget that the septic arthritis may end up with loss of this growth epiphysis. There may be loss of the neck. There may be dislocation. Already it is subluxated. But even in that stage, do the arthrotomy. Clear the hip, take the culture and sensitivity, give appropriate antibiotic and immobilize by hip spica. Antibiotic, biopsy, treatment for 12 months and hip spica. And interestingly, the biopsy came as tuberculosis. So we have given him anti-tubercular drug, and at 12 months, this is the end result. What is the diagnosis? Chondroblastoma. Yes, many of you know chondroblastoma. Treatment is curettage and biopsy is chondroblastoma. What is the diagnosis of this case? Is it Perthes? It does not look like Perthes.
Might be tubercular.
Or it may be slipped capital femoral valgus osteotomy at 6 months. This is the end result. And I do this varus osteotomy by simple plate. Small DCP, bent at 20 degree and 4.5 screw. You can see that why 4.5 screw in a small DCP. That helps. It is this 3.5 screw are not that strong, and the screw head and lies outside the plate. It has an advantage of during removal also. You can get hold it. If the removal is difficult, you can get hold the screw head. This is a case of what is the diagnosis? Unicameral bone cyst, ABC. Here you can use this fibular graft because fibula regenerates. This case, Mohsin ID, 10 years old. Is it congenital coxa vara? Probably. Congenital, it is more on the right side, less on the left side. But right side was so bad that it is already 70-degree opposite. So we did this osteotomy. We could achieve the angle like this one. So it has become equal. Valgus osteotomy. And now the child is working very well. This is congenital coxa vara. We use this plate, simple plate, I say small DCP or narrow DCP in older child, but I always use a screw. This is a malleolar screw, up-threaded malleolar screw. If malleolar screw I use, this is less cost. What is this one? Blounce. Osteotomy and fixation on the anterior. This is the case of neck of the femur. It was fixed. Single issue spica was given. Probably Samuel has shown this case. And this was at 6 weeks. Then we did this valgus osteotomy and fibular graft. Fibular graft. This is a simple screw. 4.4 millimeter cannulated screw. And I always, when they do the valgus osteotomy, I do open wedge osteotomy. No need to give it graft in children. It always unites. Fibular graft, and at 12 weeks, it is united. This valgus osteotomy has happened. This is it. What is the problem now? Probably there are some osteolysis there. What is this? FBC. 9 months after curettage and allograft. And this is at 4 years of age. So this has gone, this has definitely improved from this one up to this one now. If needed, we can give some bone graft here also again. This is the facial injury. Simple way, you have to fix it, the epiphysis and the malleolus in children, like this one. In plain KOR will not cause any growth problem. This one, when there is cystic lesion involving the epiphysis and metaphysis and the growth plate, the diagnosis is, clinical diagnosis in our country is tuberculosis. You can take the biopsy and treat it. Biopsy and clearance, because during exploration and cleaning, you can remove the load of the bacteria. And after treatment, there may be some bar in the growth plate. And I don't know, but in lateral view, it is okay. So it will heal probably. This is again another case. You can see this is an septic arthritis of the hip. You have to do the arthrotomy biopsy and treatment. This is only septic arthritis, these are not tuberculosis. It is septic arthritis, antibiotic treatment, immobilization by hip spica, and there is regeneration of the hip like this one. This is another case, osteomyelitis, incision and drainage, antibiotic according to the sensitivity, and immobilization. Immobilization is very important. Immobilization by long left plaster, and this will heal. After 6 months, this is healed. There will be some problem in the growth plate probably in the lower tibia.
Sir, do you give any local antibiotic?
No, I don't use now, but I am thinking of giving vancomycin bead. I have shown the other people are doing, but I am giving just oral antibiotic. In these chronic cases, oral antibiotic, not even, but your clearance, cleaning, incision and drainage of the pus is important. If there is any pus cavity remains, that it causes problem. So drainage and immobilization. Immobilization in children is very important. And immobilization around oral antibiotic. This is the case. Acceptable? Definitely acceptable. This is the end result, that remodeling. So don't go for the operative treatment. This is another case. This was a septic arthritis with involvement of the upper proximal femur. This is after treatment. 3 months post-op, 8 months post-op. Post-op means arthrotomy, drainage, and cultural sensitivity and biopsy. Take the biopsy. 9 months old non-union fracture neck femur. Still there are some epiphysis, trochanteric epiphysis, 9 months old. This can be reduced and 2 screw and 1 fibula without opening at the fracture site. And this is here, 1 year post-op. This is I have shown. This is a case, very interesting. Giant cell tumor of the ileum. It is in November 2005. We explored the area, but remember this GCT in the pelvis is very difficult to treat, and it bleeds a lot. When you curated, there was a lot of bleeding. We have to infuse at least 2 units of blood. Then I put this acetabulum cavity was open. So I put a cage there and some bone graft from the iliac crest in 2005. So 12 years post-op in 2017. He's a schoolmaster. This cage is there and bone graft is there, healed, and 12 years. So in pelvis GCT, remember that the bleeding may be a problem. You must prepare for blood transfusion. In one case of the ileum, giant cell tumor, we have to transport 5 units of blood, and then I had to put a mob inside to control bleeding for 5 days. Then I have removed the mob. This is you can diagnose. This is osteoidostoma. CT scan is diagnostic. This is osteoidostoma. This lesion at the site of the metaphysis, this is osteolytic lesion, this is tuberculosis. This is tuberculosis. This is again a osteolytic lesion in the calcaneum. This is on biopsy, it is tuberculosis. It is after 18 months of treatment. SCFE modified down procedure. This is after removal. This was a very interesting case. Fifth capital femoral epiphysis presented to us after Samuel was with me, and This is about 3 months old. This is 6 months old. He could not walk. Siam, he could not walk for last 3 months. So we did the first one. We did this. I think it will be easy to do this. We did the done procedure. Then after 2 weeks, we did the second one. And this is a follow-up. This is after 2 years removal of the implants. So this hip can also be reconstructed. This is again osteomyelitis involving the diaphysis. This is only by antibiotic treatment and immobilization. This is only by antibiotic and immobilization, but immobilization, hip spica for 3 months. This is Musfika presented to us at 7 years, 3 months of age. We had lot of discussion with the parents, but the parents were eager to be operated, so we took the risk at 17 months post-op and at 4 years post-op. This is simple. This one I want to say this 8 plate. But 8 plate of the Universal company has got some problem. The screw is broken and it is difficult to remove the screw because it has controlled the growth, it has corrected the deformity, but the screw is broken at follow-up at 6 months, about 9 months, broken screw. So it is difficult to remove. This is again an infection. 1 year treatment, debridement, antibiotic, hip spica for 8 weeks. You can see this one the case. This is our antibiotic, debridement, and hip spica. So in children, don't hesitate to give immobilization by hip spica. This case I have shown because there is epiphysis, growth plate is there. This is a lesion. We are really confused what it could be. We know that the giant cell tumor is an adult lesion, but biopsy came a giant cell tumor. So we did this. But still, osteotomy helps. 1 year post-op, 18 months post-op. This case, we thought it is a pseudoarthrosis. Definitely it is a pseudoarthrosis, but not typical pseudoarthrosis. Constriction ring of the skin was there. So when we opened, we sectioned the wound and immobilized by plate, and it healed. So not that it all pseudoarthrosis will not heal. This is a case. Cystic lesion, evidently we thought it is ABC, but when we explored, the pus came out. It was a case of tuberculosis. This was a tuberculosis, 6 months NTTV, and at 18 months. Not this. That was another case. That is at 6 months, about healing stage. This is another case, almost flat, but even then now, if you read the books, they'll say type A and B can be treated by BDRO, but type, this is the follow-up after 3 years. Thank you. So we are at this stage. We are at this stage, and all of you are here. And we have to go like this way. Our Paediatric Orthopaedic Society is now here. So thank you very much. Thank you all once again. Any question?
Is there any question?
না সবাই টায়ার্ড, 6টা বাজে, আমরা যে এতক্ষণ ধরে রাখতে পারছি এই বেশি। হ্যাঁ
লাস্ট একটা কোশ্চেন করি স্যার।
হ্যাঁ
স্যার আমরা কি ওই সেপটিক হিপ যেগুলো আমরা করলাম, যে প্রতিটাতে হিপ স্পাইকার দেওয়া হয়েছে,
হ্যাঁ
instead of that can we give traction for 6 weeks or
no you cannot give traction for 3 months, but traction does not immobilize the hip adequately. ট্রাকশনের মধ্যে বসবে, নড়াচড়া করবে, অ্যাডিকুয়েট ইমোবিলাইজেশন হবে না। হিপ স্পাইকার নো প্রবলেম, বিকজ আমরা অস্টিওটমি করে 2 মাস হিপ স্পাইকার রাখি। হ্যাঁ তা আবার হিপ কনজেনিটাল হিপ ডিডিএইচ করে 2 মাস হিপ স্পাইকার রাখি, কাজে একটা septic hip immobilization by hip spiker, you must need it needs adequate immobilization. Rest of the joint is very important. তো আমরা যদি ট্রাকশন দেই তাহলে সে বসবে, নাড়াচাড়া করবে, তাতে ওই অ্যাডিকুয়েট ইমোবিলাইজেশন হবে না। রেজাল্ট তো দেখছেন। থ্যাংক ইউ।
so here is the end of the evening session.
Concluding speech, Dr. Rumel Sarawat.
থ্যাংক ইউ এভরিওয়ান। আমরা বাংলাদেশের প্রতিজন অর্থোপেডিক সার্জনকে কৃতজ্ঞতা জানাই যারা এখানে এসেছিলেন। এই করোনার মধ্যেও সকালবেলা বা দুপুর পর্যন্ত 250 জন ছিলেন, সবাইকে আমাদের ধন্যবাদ। আপনারা এখনো যারা আছেন তাদেরকে আরেকটা অতিরিক্ত ধন্যবাদ, এবং আমাদের খুব স্পেশাল ধন্যবাদ হচ্ছে ইউনি হেলথ ফার্মাসিউটিক্যালসকে, ইউনি হেলথ ইউনিমেট, স্পেশালি তোফাজ্জল এবং ইমরানের নেতৃত্বে তাদের যে বাহিনী, ওরা সবকিছু করে দিচ্ছে আমাদের এই কাজগুলো। আমরা শুধু সায়েন্টিফিক অংশটা দেখছি, কিন্তু এই অর্গানাইজ করা, সুন্দর করা সমস্ত কিছু ওরা করে দিছে, ওদের স্পেশাল ধন্যবাদ। আপনারা সবাই চা খেতে যাবেন, উপরে চায়ের ব্যবস্থা আছে, শুধু পিওএসবির মেম্বাররা সামনে এসে বসবেন। চায়ের ব্যবস্থা আছে স্যার, চা, কফি, পাকোড়া, জিলাপি আছে। আর পিওএসবির মেম্বাররা একটু সামনে চলে আসেন, আমাদের খুব শর্ট একটা এজিএম হবে পিওএসবির মেম্বাররা।
পিএসবি মেম্বার তো অনেক এখন, কাজে চলে যায় না, বসে।
Anyone can stay, তাতে কোনো সমস্যা নেই। দেবাশিস সামনে আসো। না জুম বন্ধ করে দেন। হ্যাঁ জুম বন্ধ করে দেন। হ্যাঁ না তো ও ওরা আছে, ওদের বন্ধ। পিওএসবি মেম্বার একটু সামনে আসবেন।